अच्छा,
हमारा तो वीसा ही अलाउड नहीं है, सो तो कहाँ जाए। Otherwise I was to go.
B1 वीसा अलाउड नहीं है आप जाना ना।
टोटली है।
और सूद साहब,
Good afternoon, Sood sir.
How are you?
How are you? रावल साहब, मैं भीमताल में हूँ।
हाँ लग रहा है आपके ऊपर जो छत है वो घर की नहीं है।
Rajiv, you look all pink today. What is it?
सर उनका शर्ट नहीं है, उनका गाल भी पिंक है, सब पिंक है सर वहाँ पर।
थोड़े बाल बचे हुए हैं, बाल नहीं उड़े अभी।
बाल पिंक नहीं है, बाकी सब पिंक है। सिर्फ बाल एक काला है, बाकी सब पिंक है।
नहीं वो पिंक ही है, वो काला कर रखा है। तो तुम कब गए यार, कब गए भीमताल?
ये लो, ये मेरा कॉटेज है, और ये देखो भीमताल।
सुंदर है, बहुत सुंदर।
Lovely.
I mean, my
Raval, you have not gone to Bhimtal?
No, not yet.
You should not miss. You should not miss. It's got a wonderful cottage there.
I know. I had been to that area a lot. I have been in hills many times.
Not one yes, but 14 cottages.
Oh, yeah, I know.
So I thought you should also enjoy.
Anup, is Vipul going to join or record it?
Yeah, sir. Vipul, he will join late in the evening.
Okay.
So we'll have him recording video playing. Yes, because right now the time is.
I know. That's exactly.
Yeah, must be sleeping everyone.
Yeah. So that was a great challenge to have people from different parts of the world on the same platform. So we have to have recorded videos of them, sir.
That's true.
They won't be able to join.
Evening we'll be sleeping, they'll be awake anyway.
यूएस में तो 150,000 हो गया ना, या 200,000 हो गए केसेस।
बहुत ज्यादा है। In fact, the thing is not being covered very well, but like last time, but it is too much this time. In fact, it is very terrible. Last time, at least out of fear, people were wearing a mask. Now they have been given a license not to wear a mask. So then nobody is bothered now.
बद्री से बात हुई थी, अगर कोई मास्क भी पहन रहा है ना कार में, तो उससे लोग लड़ते हैं कि ये मास्क क्यों पहन रखा है तुमने।
Yes, but what I'm saying.
Now they have withdrawn that instruction of not wearing the mask. Now that is reversed.
If they come, if the majority of the time, if you are wearing a mask, they come and from distance they ask you, "Are you sick?" That means you are sick, so you are wearing a mask. That has become the norm there.
Even Israel is getting a lot of cases now, though it was fully vaccinated.
Next is going to be Afghanistan. Next is going to be Afghanistan now.
वो तालिबान वायरस होगा।
No, Talibanized.
I think Taliban has abducted 125 Indians.
ये करते रहेंगे वो भाई साहब, यही होगा वो।
तो क्या सब सैटेलाइट फोन से फोन आया क्या? राजीव को सैटेलाइट फोन से फोन आया क्या? Hi, Jens. Jens has joined in the morning.
So we are going live. We're going live in less than 30 seconds now. You're on time. So we are live now, sir. So good afternoon, everyone from India, and good morning from different parts of the world, and good evening for the other parts of the world. So today we have gathered together for the next edition of World Robotics Symposium 2021. which is being convened by Society of Robotic Surgeons in association with USI North Zone and Robotic Urology Forum. And in this program, we are also not only aiming for the academic fees, but also we are trying to collect some funds from international societies so that we can help the Indian society in dealing with the COVID pandemic. So I will first start by requesting the convener of this program, my co-convener, Dr. Vipul Patel, to give his welcome address to the August gathering. Dr. Vipul Patel, sir.
Hello, good morning, and welcome to the World Robotic Symposium 2021 in India. I first want to start by congratulating Anup on putting together a fantastic event. I also want to thank the faculty for taking their time to help us with this event, and also, of course, all the registrants. I think as I look at the Congress and I look at the faculty and all the lectures, I think it's a fantastic educational experience, and I think everyone will enjoy it. I think also what's very important is the cause of the event. Anup's been very kind in helping to raise funds for the COVID response in India. I know all of us have been affected by our friends and relatives who have struggled in India with the COVID issue. I myself had my parents there and went to great lengths to get them out during the COVID crisis, and also have many friends who lost loved ones during this time. So I think it's a fantastic event educationally, but I also think spiritually it's important to try and help our friends, relatives, and colleagues in India. And so that's why I think this event is especially important. So hopefully you're going to enjoy what's to come. Once again, congratulations to Anup. You know, you trained with us many years ago, but you've done some amazing things since you've gone back home to India. So congratulations on another great meeting. Thank you.
Thank you very much, Dr. Patel, sir, for guiding us for this beautiful program. Last year also you supported us. This year also you are the guiding force for this program. So now I will request the President of NJ USI, Dr. Sudhir Rawal, sir, to give his welcome address.
Thank you, Anup, and welcome all of you for this wonderful program of World Robotic Urology Symposium organized by SARS and North Zone. I remember 2 years back, me and Anu were there in Orlando for the physical conference, which was great learning. Not only there was session about urology, there was session about all robotic surgery, including hernia, general surgery, head, neck. Now, because of the pandemic, they are focusing in India from urology point of view. And the program which he has made is wonderful. I think there's a lot of learning for everyone with this program. And I welcome you all again and hope that everybody will be benefited with the videos, with the experience of the great faculty which he has gathered for the program. Thank you.
Thank you very much, Dr. Rawal, sir, for your kind words, and you've always been the guiding force for the North Zone activities and always there to help us in organizing various programs. Now I will request the USI President, Dr. Mallikarjun, sir, to give his welcome address. And we all know he has been so kind that he's always there to support all our activities, and we're really grateful to you, sir, for giving your precious time.
Thank you, Anup. I should, first of all, at the outset, I should congratulate the Society of Robotic Surgeons and the North Zone Society of Urological Society of North Zone chapter for conducting this great event. Most important, more than the scientific content, which I appreciate, is the motto behind the whole thing of raising a fund for COVID patients or COVID affected patients in India. This is one motto which drives the people, and I think you can see the amount of participation and the way the meeting has shaped up after this sort of a motto. I should congratulate Anup for a wonderful homework for this and the idea of it, and I should be thankful for the Society of Robotic Surgeons, Dr. Anup Patel, for giving this a helping hand to make this possible. And I can see a fantastic program with a stellar faculty all up lined up all from the world, and I'm going to see this as going to be a great program. And I think more and more programs for helping with this sort of a motto will be helpful for the society here afterwards. Thank you very much, Anup, for this opportunity to be in front of you.
Thank you very much, Dr. Mallikarjun sir, for your always motivational and kind words. Now I will request the President of Robotic Urology Forum, Dr. Mahesh Desai sir, to please give his welcome address and his blessings.
First of all, I would like to congratulate you, Anup, and Vipul for such a wonderful program. Scientifically, I think it is a step forward. For there are so many of our young urologists who are looking forward to using a robot in a various condition, and this is really a treat to watch the national as well as international people giving this, and it is full of wisdom and full of program. So and again, I would like to congratulate all the faculty who has taken part into this, and this is wonderful. So from my side, I'm very happy, and I welcome everyone who's participating it for having the best time. Thank you.
Thank you very much, Dr. Desai sir, for your blessings. Now we'll request Professor Rajiv Sood sir. He is the chairman of Indian School of Urology, and he's always been a torchbearer for all kind of academic activities, especially which is focused for young urologists and students. So I will request Professor Rajiv Sood sir to please give his welcome address.
Thank you, Anup. Greetings from Indian School of Urology, Urological Society of India. It is the great occasion when all the stalwarts of robotic surgery across the globe, they have gathered together, and even in this pandemic times, we are able to adhere to the new norms of education in India. 2019 onward, now the competency-based education and training, which has started as a part of that level 2 competency, that is the show and show how, and the first level know and know how, that is very beautifully integrated, and this program has been crafted beautifully on those lines. And now our residents, young consultants, and even the faculty is going to exchange their skills, their upgradation of their knowledge, interactions, and imparting training to each other is also a part of that. So as the chairman of Indian School of Urology, I congratulate North Zone USI and especially Dr. Anup and Raval, and also they are themselves stalwarts in India. And we are seeing here Dr. Mahesh Desai, Dr. Vipul Patel, Raj Weller, almost everybody is there. It is difficult to name all, and I extend thanks to all of them to help us in our educational endeavors, training, imparting training endeavors in India. It will go long way. Thank you very much, and all the best for today's symposia.
Thank you very much, Professor Rajiv Sood sir. You have always been motivational for all of our young urologists, and we look forward for your support in the next meetings also. Now we'll request Dr. Sanjay Kulkarni sir. He's the president of SIU, and we all know that he's a world-renowned surgeon, and he's the chief patron of this conference. So I will request Dr. Sanjay Kulkarni sir to give his opening remarks.
Thank you, Anup. I congratulate Anup and all the team for organizing this great symposium today. I thank Dr. Mahesh Desai, the president of Robotic Urology Forum, Dr. Mallikarjun, president of Urology Society of India, Dr. Rajiv Sood, he runs the Indian School of Urology, Dr. Sudhir Raval, the president of North Zone, for conducting this meeting. I just want to give you a brief history that my daughter still lives in Detroit, and I used to go and visit Professor Maniman since year 2000 every year. And then I saw tremendous progress being made in robotic surgery. So I invited V. Patel for the first time in India in 2005, where Dr. Ajit Saxena conducted a India's first live robotic surgery workshop in New Delhi. And then it is spread like wildfire. And with the guidance of seniors like Dr. Mahesh Desai, Dr. Narmada Gupta, people have taken up, and now India has one of the largest number of robots in the developing world, and the junior doctors are doing fantastic job. I watched Dr. Sudhir Raval demonstrating the radius sparing robotic radical surgery, prostatectomy in UCCon, and that was fantastic. I congratulate all of you for allowing our young generation to look at the best robotic surgeons in the world to learn from them. Anup, I thank you very much.
Thank you very much, Dr. Kulkarni, sir. And you have always been a role model for many of our young surgeons. And we hope we continue to have your support in our future meetings. And now I will request President of AUA, Dr. Raju Thomas, sir, to please give his welcome address. Dr. Raju Thomas.
Greetings from the US. I am indeed humbled, honored to be part of this great movement that the North Zone and the Robotic Society of India is putting together, especially the fact that it is for COVID relief. This is a plague that nobody asked for, but we're going to be stuck with this for a little while. And certainly, I want to congratulate the organizers for putting this together, and hopefully, this will bring focus not only to the disease process, but also to the good work that is happening. I always feel privileged to be part of anything in India because, as I say, you can take the Indian out of India, but you can't take the Indian out of you. So it's something I cherish. My heritage and my background. So as we are planning to have the next AUA in Las Vegas, and unfortunately, many of you may not be able to attend because of constraints. I want to make this pitch to have you plan for the next AUA meeting when I will be the president of the meeting. It is going to be in my hometown of New Orleans in May of 2022. Hopefully, by then, all the scourge that we are going through will abate. So as we are looking forward to a great meeting, the lineup of speakers are incredible, world-class speakers. I'm hoping that the younger folks in the audience, either as residents, either as young faculty, will take home the innovative spirit that these speakers are presenting and put that to good use where you are. As we reflect on the robot in a country like India, we cannot forget the fact that we need to take care of our citizens who are not in the 1% privileged, who can afford to seek out robotic surgery. That's the simple procedures that mean a lot. The TUR of the prostate, the stone surgery, the urethroplasties have such a high impact in numbers that we cannot forget the basics of urology. So once again, congratulations to the organizers and for the privilege of being part of this meeting. Congratulations to the speakers who have spent a lot of time in developing their robotic techniques. And congratulations to all of you in the audience for participating. Good luck on this great cause. And I look forward to seeing all of you in person sometime soon. Bye.
Thank you very much, Dr. Raju Thomas, sir. And we know that AUA is always a helping hand for USI for various activities, and we look forward to your support in the future meetings also. And now I will request the Honorary Secretary of USI, Dr. R. Keshavamurthy, sir, who has been so dynamically involved in organizing various meetings in the last 1 year. And he is always very kind enough to support us in all our activities and give his precious time. So Dr. Keshav Murthy, sir, please give your opening remarks.
Thank you, Anup, for your kind invite. I bring greetings from the Urological Society of India. I must congratulate Dr. Anup and Dr. Vipul Patel, who are the conveners, for putting up an excellent program under the banner of the World Robotic Symposium 2021 in collaboration with the Society for Robotic Surgery and the North Zone chapter of the Urological Society of India. If you look at the program, you will find the galaxy of international and national faculty and the who's who of the robotic surgery in the panel. And I am sure all the young urologists would benefit from this program. Wonderful cause, Dr. Anup, for this program, for the COVID response. It's a fundraising program. I congratulate you and wish you all the best. Thank you.
Thank you very much, Dr. Keshav Murthy, sir, for always be there for supporting us. And now we have Dr. Ramalingam also, who has joined us and is a very near friend of Dr. Vipul Patel. So I will request Dr. Ramalingam. He's also a very known surgeon across the world, to please give his opening remarks. Dr. Ramalingam, sir. Yes, sir, we can see you. Yes.
Hello, Dr. Anup, Dr. Vipul, and all the patrons, USA office bearers, SIU President Dr. Kulkarni, and our mentor, Dr. Mahesh Desai. It's a very good gesture to conduct a scientific program coupled with sort of helping hand. So really excited that our people abroad are thinking back about our country, and they want to give back in whatever best way possible. It's wonderful. And as all of you know, that Vipul Patel is so friendly to our country and so simple and humble. He is always helpful whenever you approach in whatever format you want. So good luck for all the people who are doing this charity work, and hope we'll be able to help our country in a much better way. Thank you all for asking me to give my comments, and we'll look forward to a good program and a scientific program. Thank you, Anup. All the best.
Thank you very much, Dr. Ramalingam, sir. So we have divided this program into 7 sessions, and there are 6 sessions which are focused on reconstructive urology, renal transplant, then kidney cancer, prostate cancer, bladder cancer, and then also we have a master class by Dr. Jens Rosweiler from Germany. So we have a galaxy of not only international but the national stalwarts in robotics who have been the leaders in their field. And we are going to start the first session very soon. In fact, we are running quite ahead of time. We have still 5 minutes to go to start our next session. So we are going to start the first session, which will be on the reconstructive urology and the robotic radical nephrectomy session. We're going to start in next 2-3 minutes. Dr. Ramalingam has already joined. So we are going to show this program live on various online portals. That includes the Ministry of Health and Family Welfare online e-health program portal, which is being telecasted to 52 colleges across the country. And also we are streamlining this program to 20 different countries through the help of various other organizations. So I hope that this program will again clarify the doubts of the young urologists who want to become the robotic surgeon, and will also help them to in the taking up this field in the future. So thank you very much all the esteemed faculties for joining us. So we're going to start the first session in the next 2-3 minutes. So I will invite the chairpersons one by one, and then we can start the first session. So the first session which we are going to start today, this is a session on the radical nephroutectomy, and we have the esteemed chairpersons for this session. So my request to chairpersons will be that they will invite the speaker, and once the lectures are over, we have kept sufficient time for their comments. So there will be a 5-minute comment from the experts each, and they can also take some questions in the last so that we can have good discussion. So we have tried to keep a buffer of time so that we have ample time for a discussion and keep the program interesting. So we can start.
Thank you, Dr. Anup, for inviting us. I hope Dr. Anil Mandani, Manav, and Raghavan are joining me shortly. And the first talk of the program will be a step-by-step approach to robotic radical nephrouretectomy for 15 minutes by Dr. Raghunath from Bangalore. All of you know he is an excellent robotic surgeon, and he is going to highlight on the technical aspect of the robotic nephrouretectomy. Dr. Raghunath, the mic is yours.
Good afternoon. Good afternoon, sir.
Hello, good afternoon. Welcome.
Thank you, sir. 1 second. Can you see my screen?
Yeah, we can.
Yeah. So at the outset, I would like to thank SRS and Dr. Anup Gupta for giving this opportunity. Yeah. So I would be speaking on step-by-step approach to robotic radical nephrouretectomy. So the gold standard all of us know for the management of upper tract urothelial carcinoma is radical nephrouretectomy with ipsilateral bladder cuff excision. This is standard of care, all of us know. But robotic radical nephrouretectomy is considerably adopted due to its reduced postoperative pain, morbidity, and shorter convalescence time, with similar oncological outcomes when we compare with open radical nephrouretectomy. So I would like to present here the step-by-step video of robotic radical nephrouretectomy using Da Vinci Xi robotic system using a single docking technique. Sometimes when we don't have Xi system, we may have to do double docking system technique with the SI system, and probably with even X system, single docking should be sufficient in most of the cases. So this is the 58-year-old lady with no comorbidities presented with painless hematuria. On evaluation, she was found to have a right renal pelvic tumor extending up to the interpolar region, and upper ureter was also thickened. So we started suspecting a renal pelvic tumor, that's urothelial carcinoma, and the upper ureteric tumor. The cytology was positive. Hence, we started planning robotic radical nephrouretectomy. These are the steps of the procedure. Coming to the position, generally left lateral position should be good enough for the right kidney. The table tilt or table bend is generally not required, and ports either depends on the single or double docking system. These are the steps of my surgery. First of all, we have to, after port placement, we have to mobilize the colon and cauterize the duodenum, and dissection and early ligation of the ureter is recommended so that the tumor cell seedling coming down along the urine and implantation into the bladder can be prevented theoretically. And dissection of the renal hilum after cauterization of the duodenum, dissection of the adrenal gland and posterior lateral attachments, and in case if it warrants, probably regional or perihilar lymph node dissection may be required. That is yet controversial. I would not go into the details of that. However, in this particular case, we did retroperitoneal lymph node dissection and dissection of the distal ureter and bladder cuff, and extravesical excision of the bladder cuff and closure of the cystotomy. So these are the steps. I would go into the details of the surgical video. So this one we did flexible ureteroscopy. You can make out tumor was found in the renal pelvis, the middle calyx. So we decided to go for robotic radical nephroureterectomy. This is the video I'm presenting you. So these are the position and port placement, which is familiar to most of you. So the first step is on the right side, you have to retract the liver. After releasing the adhesions, you can retract the liver by various means. Here we retracted by using a Cocker's forceps, laparoscopic Alice forceps. This is cockerization of the duodenum and releasing the peritoneal attachments so that we can go directly to the renal hilum after dissecting the lower pole and part of the ureter. These are the common steps for even radical nephrectomy or nephroureterectomy. Release all these adhesions. The beauty of this robotic approach is you will have excellent vision and dexterity, and surgeon will be comfortable sitting and doing this procedure. So you can make out absolutely bloodless field. If you go through the natural planes, it would be very nice field will be there. Sometimes some small adhesions can be there, peritoneal adhesions, which can be released. So that is the gonadal vein you can make out. So we dissected and we prepared this dissection so that it will be easy for the further dissection of the lymph nodes. So our dissection was planned like this. That is the renal vein you can make out. We are taking all the fibrofatty lymphoareolar tissue along the specimen so that all the lymphatic tissue will come along the specimen. Whatever separate tissue is there, separate lymph nodal packet can be removed separately. So we went very close to the gonadal vein and IVC. So this part of the dissection included even paracaval lymphadenectomy has been done, and all the lymph nodal packet is along the specimen. The small veins which can directly drain into the IVC can be divided either using metal clip or preferably 5 mm Hemlock clip. 5 mm Hemlock clip would be better secured clip than metal clips. Fortunately, we had only one renal artery and one renal vein. We dissected at the upper pole, towards the upper pole, as the artery was towards the upper pole. So posterior dissection has been done. This is quite easy. So we made sure only one artery was there, and we took the vein on the loop so that the dissection of the artery would be further easy. So that is the artery. We can make out the pulsations. It has been clipped doubly using the Hemlock clip, either 10 mm or 12 mm clip. It depends on the size of the artery. Generally, 10 mm clip should be good enough. After doubly clipping it, divided the artery. Now we are left only with the vein. And that is the vein. Sometimes you may have to use 12 mm clips, or very rarely you may have to go for division of this vein by using a stapler, vascular stapler. So artery and vein has been divided. The rest of the dissection is similar to radical nephrectomy. The upper pole has been removed. Here, you don't have to remove the adrenal most of the time. It depends on the size of the tumor and stage of the disease. Generally, it is not required unless it is T3 disease where infiltration towards the upper pole is there. Probably you can go for adrenalectomy. Otherwise, generally, it's not required. So after completing the upper part of the dissection, you focus more towards the lower pole. Since it is done with X-ray system, we also thought of doing the lymphadenectomy in this particular case, as the size of the tumor was relatively big. And we don't have the staging, exact staging at this point of time. It's always better to do lymphadenectomy if it is possible and if it is indicated. So all the pre-caval, paracaval, and part of the intra-aortic caval lymphadenectomy has been done. that is the ureter. So we generally try to clip the ureter before dissecting rest of the kidney, because otherwise the malignant cells, while manipulating the kidney, it can come down and it can cause nidus in the, it can implant in the bladder. So nephrectomy is almost been done, and you keep the kidney there itself so that it doesn't come in the way of your ureteric dissection. Now we move towards the pelvis. The beauty of XI system is you can do with a single docking. Otherwise, many a times with SI system, you may have to do double docking. Push all the ports down. You may have to use additional ports and do the lower part of the ureteric dissection and bladder cuff excision. That the ureter being dissected all round. However, in this particular case, there was no tumor in the lower ureter, so we could manage easily. Sometimes, if lower ureter tumor is there, big tumor is there, you have to be very careful, and you have to go extra wide to prevent spillage and for better oncological control. So, after reaching the bladder, you identify the detritus are all around the ureter where it is entering the bladder, and take a bladder cuff all round. At least a minimum of 0.5 centimeter to 1 centimeter of bladder cuff should be good enough. In case of lower ureteric tumors, sometimes you may have to do lymphadenectomy. It depends on the stage of the tumor. If it is T2 or T3, post-neoadjuvant, sometimes we may have to do even pelvic lymphadenectomy. That purely depends on the stage of the disease. However, in this particular case, there was no lower ureteric tumor, so we did not do PLND. So that is the ureter. So part of the bladder cuff has been excised. Sometimes it's a good technique to take one stay suture just to prevent the bladder. Sometimes it can retract back. Otherwise, you can close the bladder carefully, either in single layer or sometimes maybe in 2 layers. So that is the complete completion of the radical nephrectomy and cuff cystectomy. Thank you. And I would like to acknowledge Dr. Ginil Kumar for this support of this video. Thank you.
Thank you, Dr. Raghunath, for showing this step-by-step technique of robotic nephroureterectomy. And this particular case, you had done the part of the lymph node dissection in the upper abdomen. Is it because the tumor was big, or you had a grade of the TCC?
So cytology was positive. Probably it's a high-grade tumor, and the tumor size was also big. In view of this, we did the lymphadenectomy. As with robotic system, it's very easy to do lymphadenectomy in this particular case. So we did that one. Sometimes it may not be required, but in this particular case, we did the lymphadenectomy.
Did you do ureteroscopy and biopsy or breast biopsy or something?
So cytology was positive. So
okay, then there was no need.
Ureteroscopy has been done. That showed a papillary growth in the renal pelvis.
Okay, Dr. Anil, do you have any questions?
Yeah, Raghu, very nicely done dissection. So one question, you rightly said that you clip the ureter first before going down towards the cuff. So suppose a patient has lower ureteric stone, large ureteric stones. So do you do the cuff dissection first, or remove the cuff first and then do nephrectomy?
I've not done that. Probably that suggestion is a valid suggestion, but I've not done that. I've not come across any such situation where stones are there. Even otherwise, by clipping the ureter after dividing lower ureter. Yeah, lower ureteric tumor. Probably I think it's a good point. It's better to always.
And the second, how do you stage T2 and T3 ureteric tumor? You're doing MRI routinely, or?
Generally, CT scan should be good enough. In case of doubt, probably we can go for MRI. But staging of the upper tract tumor is very dicey, unlike bladder tumors. So if gross tumor is seen outside the ureter, probably you can consider it as T3. Otherwise, very difficult to stage this.
And in your practice, do you give neoadjuvant chemo for upper tract?
Yes, more than bladder tumors,
All
we
upper
give.
tract?
Yes, most of the upper tract tumors we give, neoadjuvant chemotherapy.
Okay, thank you.
Anil, can we move on to the next presentation?
Yes, sir. You can invite the next speaker, and then in the
I
last
would like
we can
to
have a question
invite
answer.
Dr. Mihe to talk upon the management of bladder cuff, the robotic radical nephroureterectomy, the techniques. Dr. Mihe, yeah, welcome.
Good afternoon. Thank you very much to the organizers for inviting me to give this presentation. Today, I'll be talking about the distal ureterectomy portion of a robotic nephroureterectomy. The principles of distal ureterectomy for treating high-grade upper tract urothelial carcinoma have not changed. The goals are to achieve complete excision of the entire urothelium, including the entire ureter, with a bladder cuff that includes the ureteral orifice, to avoid and minimize spillage of any urine from the ipsilateral kidney as well as from the bladder if possible, and also to make sure that one does not damage the contralateral ureteral orifice in fashioning the bladder cuff. The latter part is more relevant in large intramural tumors that may require a more significant excision of the ipsilateral hemitrigone that could sometimes encroach on the contralateral side. We believe that the robotic approach allows us to achieve all the three principles in addition to being able to primarily repair the bladder opening for optimal healing. In a robotic approach, the distal ureter can be handled in one of three ways. This has become a little more straightforward with the XI robotic system, where the actual position of the patient side cart does not need to change. Only the angle of the camera and orientation has to be different during the ureteral part if need be. But with the SI system, if you are doing a double dock, even if you do not change the position from flank, you may need to bring the robot through a different angle. The double position, where the kidney part is done in the flank position and the ureteral part is done in the lithotomy position, is another option. We reserve the final approach for patients with very distal juxtavesical or intramural ureters for two reasons. One is it gives you the best approach to the bladder, and number two, it also allows for a safe and efficient ipsilateral pelvic lymph node dissection. For all other tumors, one can begin with a single dock and progress to either a double dock or a double positioning based on patient anatomy, body habitus, and the surgeon comfort level. I will go through the port positioning as we do it. There are many variations to it, and I would like to mainly highlight the SI position since many of my colleagues in India still use the SI. But the same configuration can be used with the XI. Just the camera honing to the target anatomy will need to be changed. So this is a patient with a right side up flank position. The feet are towards this side, the head is towards this side. I'm going to go through the port positions one by one. This is the direction. The arrow shows the direction in which the actual patient cart comes in the SI system. You have the camera port, which is a 12mm port here, shown above. This is the 5mm assistant port for the liver, a unique thing for the right side. This is the subcostal port, which is for the right robotic arm for the nephrectomy portion, but this becomes the fourth arm for the distal ureterectomy portion. This is the left hand port for the nephrectomy position as well as for the distal ureterectomy. You will note that for an SI configuration, we have made this much more medial so that you can get good triangulation to the ipsilateral ureter for the ureterectomy portion. And the lateral port is a fourth arm port for the nephrectomy part, but becomes the right hand port for the ureterectomy part. And so it must be slightly higher than the ASIS so that you can get good angle to the pelvis. and this is the air seal assistant port. Now, for the single dock position, what happens is you have a broad triangle, and the right hand, left hand, and the camera fairly remain the same. You can reassign the right hand to this lateral port and reassign the fourth arm to this upper port if need be. The robotic arm positions are shown here, and the key with the SI system is to keep the robot as away from the table so that the blue arrow should be in the very distal part of the blue zone. This is a video clipping showing the distal uretrectomy in a female patient, and this is a single dock type approach. Here is the right hand reassigned to the lateral port. The left hand is as shown here. This is a right distal ureter, and this patient has not had a hysterectomy. So the ureter has been, the nephrectomy part is all done. The ureter has been dissected almost up to the level of the iliac vessels, and now the dissection is commencing into the pelvis. Doing a distal uretrectomy or a nephro-U in a female patient who has not had a hysterectomy has several challenges, and I think this is one of the more trickier ones compared to a male patient or a patient who has had a hysterectomy. Firstly, one has to dissect the ureter underneath the broad ligament and also underneath the uterine vessels, and try and avoid and try to preserve these structures as far as possible. Um, in this patient, the tumor was in the pelvis, and so there has been a clip that has been placed below the tumor, distal to the tumor, above the ureter, so that even if we get some ureteral violation here, there is unlikely to be any tumor spillage. The fourth arm retractor at some point will provide continuous cephalad traction to the distal ureter. You can see here, because the tumor is in more of the proximal collecting system, this part of the ureter is nice and pristine. So even though the patient is in flank, and one thing I would like to mention is that when you do the distal uretrectomy, you may want to reduce the airplaning of the patient to a less acute angle, say maybe a 15 to 20 degree flank as opposed to a 45-degree flank that we typically use for the nephrectomy. But if the exposure is good, you can keep continuing in a single dock format. So there is constant cephalad traction on the ureter, and as you can see, the ureter is now going underneath the structures of the broad ligament, and you will now see the uterine vessels crossing anteriorly. In case you are encountering that the uterine vessels are adherent or there is a risk of bleeding, one can easily clip the ipsilateral pedicle. But in this case, we decided to preserve it as is. And if you stay in the nice plane around the periureteral adventitial sheath, you will get a good exposure. The assistant always keeps the ipsilateral bowel retracted distally. And as you can see here, dissecting underneath the broad ligament is somewhat challenging. As you keep pulling the ureter up, you will deliver the bladder mucosa, and you want to make sure that you are delivering mucosa all around. Then you will start dividing some of the detrusor fibers, as you can see here. And now this is the dissection of the intramural ureter. And this should be done all around. So we basically keep moving this from 12 o'clock to 3 o'clock to 9 o'clock to 6 o'clock, and keep the retraction on the ureter in the contralateral direction. So for example, here we are dissecting the 3 o'clock position, here we're dissecting the 9 o'clock position, and this is basically the ureter going all the way inside the bladder. As you can see here, this is a funneling is done, and now this is the bladder mucosa that has been delivered all around. So once you get an adequate amount of bladder mucosa, you take 2 stay sutures at the 12 and at the 6 o'clock position. We use a 3-0 V-lock on an RB1 needle. This is an extremely important step because without this step, the bladder mucosa is going to retract inside, and the further dissection is going to be much more difficult. A second stitch is taken at 6 o'clock. This actually is the more important angle because this is going to recede inside if you do not take this stay suture. So once this stay suture is taken, the fourth arm retracts one of the stitches up, and then with the scissors, we start now opening and fashioning the bladder cuff. You have to be careful not to cut the stitch during opening of the bladder cuff. So here you make an incision. I usually start anteriorly to look inside because then you can see that you have the urethral orifice in sight and you can circumscribe it. I can see the urethral orifice there. You can see it with the blue dot. Then you look inside and then you keep opening the mucosa on each side. Make sure you do not disconnect the ureter right here. You have to make sure that you take the entire urethral cuff. So then we will retract the urethral cuff laterally. You can see here, that's the intramural ureter, and you can keep going on either side to make sure that the entire urothelium of the urethral orifice is excised. And once you're on the other side of the urethral orifice, you disconnect the specimen. And as I mentioned earlier, this ureter has already been clipped. Now, once this ureter has been disconnected, we put retraction on the 6 o'clock stitch with the fourth arm and start the mucosal closure. So this is closed in 2 layers. The top stitch comes down for the mucosal part, and then the bottom stitch will come above as the detrusor buttressing. So you start at the 12 o'clock position with the second stay suture, and you have to make sure that you get both edges of the mucosa nicely. Once you take it in the first couple of bites, then the remaining bites are that much more straightforward. Usually it's a backhand stitch that works well because it avoids hitting the structures of the broad ligament that the assistant is retracting. Now remember, if you did not have the stay suture, this would recede back completely. Once the inner layer is taken, the stitch is disconnected and then it is tied to the 6 o'clock stitch. And then the 6 o'clock stitch then comes to form the detrusor layer to overlay this. And then we always keep the Foley catheter in the field and we fill up the bladder to make sure that the bladder is filled nicely. This is the stitch being tied, the first layer being tied. And once that is completed, you take detrusor on both sides to make sure that you cover the mucosal closure. The double dock, all you do is instead of the robot coming from this direction and the triangulation being such, you undock the robot and bring it from the leg side so that the triangulation becomes between the camera port stays the same, the fourth arm becomes the right hand, and the left hand stays the same, and then the right hand for the nephrectomy becomes the fourth arm. Now, double positions, as I mentioned earlier, are done for distal urethral tumors, intramural tumors. If they are very large tumors where you expect extra urethral extension, then as you saw with the single dock, you have to do a lot of manipulation and traction. And so in that case, it is probably better to reposition the patient. Also, morbid obesity, prior pelvic surgery, and difficult exposure on the lateral part are some indications. I'm going to show you a brief video. This is a left-sided urethral tumor. It is actually a tumor that is at the level of the iliac bifurcation. So not very distal, but look at how big and large the tumor it is. And so you have to be very careful here. And so if you were to do this in a single dock position, this is not going to be an optimal cancer operation. So you must take your time, and this way you can ensure that you get the complete ureter excise. So here we are now beyond the tumor, getting into the very juxtamural tumor, going into the bladder. And so for tumors like this, we really recommend a double position. So this is the end, and then at the end you can do the node dissection. For proximal tumors, we do almost an RP-LND. For distal tumors, we do a pelvic lymph node dissection, and this is the end of the procedure. So again, this is our technique of robotic nephrouretrectomy with the various approaches that have to be customized according to the tumor and patient factors. Thank you for your attention, and thank you for the invitation.
Yeah, thank you, Mayor. It was a very well demonstrated procedure of nephrouretrectomy, and I agree with you that even if you have XI, a double position would be much better if you have a situation like large ureteric tumor or infiltrating tumor. So there is a question from audience. Then I'll put 2 thoughts to pick your brain on those 2 thoughts related to this disease. I think we have 4 or 5 minutes remaining. So question is, have you come across any port site metastasis in patients with upper tract TCC with positive lymph node.
So, Dr. Mandani, sir, I think you can ask the question to Dr. Raghunath, because Dr. Mihir has to log off. So you can ask the question to Dr.
Okay.
Raghunath, and you can discuss with the other.
Yeah, Raghu, please. Yeah, maybe Dr. Mahesh Desai would come in looking at his vast experience. Because I have written one article, this is published in Indian Journal of Urology. Personally, I feel that port site metastasis is an anomaly of systemic disease. It is nothing to do with port itself or laparoscopy or robotic. Sir.
So I haven't seen any port site metastasis in a bladder cancer, but I've been very, very concerned if there is a tumor in the bladder, and for that near the ureteric opening, it is opening up, and you are doing a nephrourectomy. I'm very concerned that there should not be any spillage, because there is a likelihood of local recurrence in future. So that is one thing. Initially, when the robot was not was in place, what I used to do a cystoscopy first, and then make a incision around cuff, and then we used to deepen it, and then pull the tumor inside, and then clip it, and then push it out, and then do the closure with a short suture, and then do the laparoscopic position, and then or robotic position, and do the nephrouretectomy. So that was the one alternative. But no, you have to select the cases where you can do it. But
sir, on the very same thought, the question is like when we saw both the dissections, both the surgeries from Raghu and Mihir. The Raghu's bladder opening was little bigger than what Mihir did. Mihir did intramural dissection. So why don't we stop short of that orifice? Why do we need to resect 1 centimeter of cuff? Why not 2 centimeter? Why not 3 centimeter? Or why not no cuff? So what is your thought on this?
Well, if if the tumor is in upper tract, then I will have the minimum mucosal thing.
No, but the reason we do cuff, no, just to, in follow-up cystoscopy, because intramural site is not visible.
Yeah, because that mucosa.
So why cuff?
No, that two things. One thing is that mucosa is sensitive to make a tumor. So I want to cuff off that thing. But even nevertheless, even if you do a nephrourectomy, you have to do the follow-up, because your urine flow, which comes from the ureter, it goes across and hit the other wall of the tumor. So very often we have seen the recurrence after the nephrouretectomy. Sometimes it occurs. It occurs on the opposite side as well. So there are two ways the recurrence can occur. So what we are preventing at the moment is that by doing. Now, your question regarding very close to the meatus, 1 centimeter from the meatus or 2 centimeter from, I think if it is going to come from the ureter, I think the maximum 1 centimeter is okay. The remaining part, you cannot take it out because it is not guaranteed. But what you have to do is afterward, what is the histopathology at the cuff margin? That is important. And second thing, your follow-up. Your follow-up, you need to have a follow-up for the scopy, initially 3 monthly or 6 monthly, but then yearly. You need to do a scopy, but before that you can do a sonography and cytology, because it is no guarantee that taking out the cuff will prevent any settling in the bladder. So regarding your question, how much to take it out? I think probably around 1 centimeter is good enough, where you have a good cuff.
Anil,
Thank you.
can I
Thank you,
add?
sir.
Can I add?
Yes, please.
Yeah, previously we used to dissect the ureter. Once the artery is clamped in the upper tract, then we come to the hiatus and then mobilize the ureter, a little bit of mucosa, apply a Shimala clip there to prevent the spillage. Because I had about 20 years ago when I was doing a nephrouretectomy, young patient, that patient presented with tumor recurrence at the hiatus. He presented with the hematuria within 3 months when we did the cystoscopy, and we could see a small tumor deposit in the area of the resection. So what I do is, once the artery is clipped, they are not worried about the vein or mobilizing the kidney. Don't waste time. Come down and then put a hemolag. And then when you are coming, dissecting everything downwards, then you can still mobilize the bladder mucosa by dividing the detrusor anteriorly, pulling the bladder mucosa a little out, and then you can take a stitch. This way we can prevent the spillage. So occasionally we are done in a high-grade tumors, even applied stapler, so that absolutely there is no spillage. And then you remove the stapler line once the specimen is divided. In between the stapler lines, you divide, and then remove the stapler line, and then again you do the suture with 3O V-lock. You take more of detrusor, and maybe about 2 millimeter, 3 millimeter detrusor, 1 millimeter of mucosa, and then that way in a single layer you can complete the closure. You don't have to do in 2 layers. But we always take a stay.
Anil, it is difficult to judge from the extravesical view how much is a 1 centimeter and how much is a 2 centimeter and that thing. So that time I thought that going through the bladder and you making an incision around the mucosa would be where you can see the intravesical image of the ureteric opening, and then you can calculate how much is the you want to take it out, and then you divide that including the diffuser muscle, and then so that was my thought that time, that you can judge it. But once we got a robot, I have stopped that technique from the scopy. But I felt that whenever the ureter tumor is near in the lower ureter, I would do that.
Yeah, then the story becomes different.
I have a question for Dr. Desai. Sir, when we do agree that cystoscopy is a mandatory part of robotic nephrouretectomy, then why not use coring even today? Because we have to inspect the bladder anyhow before starting the surgery.
No, we can do that. I think, I used to pour out the mucosa, the muscle, and go up to the extra vesical fat, and then with the short shoot, the suture which we use it for endopyloplasty, that suture we used to do and close the mucosa, and then go to the laparoscopic part, and you can still do it. You can still do it.
And Dr. Mandhani, a comment to your lower ureteric tumor. I actually presented 8 years back in USICON that lower ureteric tumors, when operated robotically, the surgery should be named as robotic ureteronephrectomy rather than robotic nephrouretectomy. So I would always handle the ureteric part first. So I gave it a short form of run.
Thank you, Manu. Thank you for your comment, and thank you, everyone. I think I'll hand over this podium to Anup to carry forward to the next session. Thank you.
Thank you, Anup and Manav, and thank Dr. Anup Kumar.
Thank you, sir. So, Dr. Raghavan, so now we have all the 4 experts. We request them to give their take-home comments for this session. So I will start with Dr. Ramalingam sir first, and Dr. Mandhani, then Dr. Manav and Dr. Raghavan. Please give your comments for this session.
I think from my side, it all depends upon the grade of the tumor. If your cytology is positive, then you are dealing with a high-grade tumor. we always try to combine with lymph node dissection, one thing. Second thing is once the artery part of the renal dissection or clipping is over, I quickly come down and then dissect the distalmost ureter and then apply a clip there so that there is no spill. And then go ahead with the rest of the nephrectomy part and then uretrectomy and then even dividing the detritus a little bit and taking a stay stitch in the mucosa at least about 0.5 centimeter away from the ureteral mucosa and then do the suture with V-lock. Initially, we were doing applying coring the bladder mucosa and then pushing away. But over a period of time, we have found every time we get extravasation and you are worried about the spillage and you need to put a drain and the patient used to give complaint of pain and all. So we have given up that technique of coring the technique because dissection of the distal ureter with even dividing or even you can split the detrusor, don't have to even cut. Split the detrusor, you will get a little bit of mucosa for sure. You can take a suture, stay, and then get a good cup of mucosa. So that way, the coring is almost, I think, given up, and we can always deal the lower ureter in a much better way. So that's all from my side. And large tumors, one has to be very, very careful. And in the women, coming to the nephroureterectomy in women, whenever I have such patient, I don't hesitate to divide the ureteric vessels and then doing a comfortable ureteral dissection. The uterine vessel, if you divide on one side, it gets a supply from the other side, even from the vaginal artery. So don't hesitate to divide the uterine artery and vein. Just apply 2 Hemalox on either side and then do a comfortable dissection of the lower ureter, a little bit of bladder mucosa. That's how I do.
Thank you, Dr. Ramalingam, sir. So, Dr. Mandani, sir, you please give a comment. And there is one question also. I would request you to answer this question. That what template of lymph node dissection you will want to do in this kind of patients? So, you please answer this question and also your comments on these 2 lectures.
Comment on what?
So the comments, yeah, yes.
Lymph node dissection.
Okay. Okay. So lymph node dissection, if it is a pelvic tumor or upper ureteric tumor, I dissect from renal hilum to the bifurcation of common ileum. If it is mid or lower ureter, then I do the proper pelvic lymphadenectomy. Regarding nephroureterectomy, you see, in last 9 cases, I have not removed the cuff. I have just, I just removed the intramural ureter because I'm reviewing the literature. Maybe I'll send this manuscript for publication, but the number is short. You see, the concept is we do remove intramural ureter just to avoid a blind area in follow-up cystoscopy. And beyond that, if you're removing 0.5, 1, 2, then question comes, why not whole bladder? So there is no logic or concept behind limiting your cuff size to 1 centimeter. That is my question. And I haven't found, I mean, I have reviewed a lot of papers and there is no mention that the recurrence rate is more at the orifice. So they just describe the recurrence rate, but only 1 or 2 papers have described recurrence at the previous ureteric orifice. That is one. Second, Manav asked, why don't we do coring? So if you believe, if he is putting a clip with a thought that it would cause extravasation while doing dissection, then coring beforehand would further cause extravasation because you are leaving that much time for urine to contaminate that pelvic area. Rest, I think now there is a saturation in surgical technique. Every surgeon has its own way to do it, but conceptually, what both the surgeons have demonstrated, we follow all those steps, except this cuff, which maybe I'll send the manuscript for publication once I have good data and good follow.
Thank you, sir. So now
Sir,
I will
can I ask one question, sir?
Yeah, Dr. Raghavan, yeah, you please ask question, and there is one question directly to you also, Dr. Raghavan. One question directed to you, that any incidence of port side metastasis in these patients when you remove lymph nodes? So this is a question directed from the audience. So you can answer this and you can give your comments.
My personal experience is that I haven't seen any port side metastasis, at least since the advent of robotic surgery. When we were doing lap cystectomies a while ago, 2010, 11 and all, there were 1 or 2 incidents of it. And therefore, there was a lot of concern. And even today, I have lots of concern. Many times I put all the lymph nodes in a packet and take it out in a packet at the time of the specimen retrieval. So that is about the port side metastasis. So the concern for port side metastasis cannot change. And my personal view is that it should be the concern all the time, and we should be aware of that. That is point number 1. My question to Anil sir and others is that when you have a lower ureteric tumor involving the ureteric orifice or the intramural ureter, where you believe that a clip below the tumor cannot be achieved, how do you deal with it if you choose to do robotic surgery? I have my personal view on that matter itself. I'll express is that I do the nephroureterectomy part up to the pelvis and do an open extraperitoneal approach to approach the lower ureter if I feel that I cannot get a proper control of the urine spillage, because for me peritoneum is a natural barrier. That is the approach I take. Am I overdoing it, or is it something which is acceptable? That is the question. I want an answer from Ramalingam sir, Anil sir and seniors like that.
I think you are doing the right thing by doing open lower phalansteal, giving phalansteal incision and removing it with open surgery. What I do mostly in such cases where the tumor is.
I mean, a lot of people used to say, why not? So the principle, as you said, conceptually, the principle of not allowing urine filled with tumor cells to spill into the peritoneum still remains good, isn't it? Is that something you'll agree as well?
Yeah, that's what I'm saying. So doing open is not a bad idea, but the way I do is I do lap nephrectomy in this particular situation, or if I have robot, I would do a lap nephrectomy and I do double positioning, what Meher described, the way you do prostate, because that would give you a better exposure and better control of the situation. Otherwise, open is not bad.
So would you approach such a tumor that is jutting out of the orifice intravasically, or would you approach it extravasically?
I would do extravasically.
Okay, so Dr. Manav, now your comments and one question directed to you. One question directed to you is that any role of neoadjuvant chemotherapy in upper tract TCC? So please address this question and your comments.
So Anu, for neoadjuvant, my simple answer is I send it to my medical oncologist colleague, and as they decide, I follow their advice. But in case a patient is symptomatic or throwing hematuria, I would straight away take him up for surgery. And secondly, my comment is that a lymphadenectomy is a very important part of the surgery. I have seen many people just going ahead with nephroureterectomy and not doing a very meticulous job. But this is my personal belief, this behaves much more aggressively, and lymphadenectomy should be done very meticulously in these cases.
Yes. So it's very important.
I think so. Thank you very much.
Yes, sir. Do we have a minute? Regarding neoadjuvant, you see, initially I said I have two philosophical thought to pick Meher's brain, but this was the second thought about neoadjuvant. Now there is not much data available for upper tract TCC as far as neoadjuvant treatment is concerned. We draw parallel from bladder cancer. Even in bladder cancer, I personally don't believe in the concept because, the survival advantage is 5%. Now, if you look at the response rate of chemotherapy, so it's not if you give chemo to 100 patient will respond. The response rate is maximum to the tune of 60%. So 40% would not respond, and you're delaying the treatment by 3 months. So you're not concerned about those 40% who are not responding, but you're concerned about 5% improvement in survival. So that is the point of contention.
Thank you. Thank you very much. Both the esteemed speaker, Dr. Raghunath and Dr.
Anil
sir,
Anil sir, beautifully put, sir. Very beautifully put. Very beautiful.
Okay, so
thank you.
I want to thank all the chairperson, Dr. Ramalingam, Dr. Anil Mandhani, Dr. Manav, and Dr. Raghavan for excellent discussion in this session. And we have finished the session, in fact, 5 minutes ahead of time. So we are moving to the next very important session. which is the robotic renal transplantation. And the chairpersons for this session, I would like to invite Professor Anant Kumar, Dr. T. Kishore, Dr. Ajay Oswal, and Dr. Prasun Ghosh. So I will request the chairpersons to please invite the speaker and they can take over the session. Over to Dr. Anant Kumar and the team.
Hello.
Yeah, Dr. Kishore. Yeah.
Yeah, I can see myself and Dr.
All the
Halawat
four,
is there.
all
So
the
can
four
I
are there. Yeah, please.
Sure. Can I start inviting Dr. Halawat, who's a pioneer in this field, to present his technique, method of the verticular Vedanta technique of robotic renal transplant.
Hello, can you hear me? Yeah. Hello.
Yes, sir.
Am I audible?
Yes, sir.
Okay.
Please go ahead. Yes, sir.
So, it's steps of robotic kidney transplant, step by step. That's the brief that I have been handed over. And the first thing that I would like to say is one of the patient selection. And frequently this question has been asked that who are the ideal patients for robotic kidney transplant. And the only contraindication that I would like to point out is bad iliac vessels. So all these patients should undergo pelvic vascular assessment before they are accepted for robotic transplant. Although surprises can happen even with open surgery, and they can happen during robotic transplants also. And one has to deal with the situation accordingly. So first step is in robotic kidney transplant with regional hypothermia positioning and port placement, then the bed preparation, then outside the on bench work of graft jacket and its introduction, which is a very important step. Then followed by the venous anastomosis and the arterial anastomosis. Then the revascularization is done and the graft is flipped in the right iliac fossa for the fixation, then proceeding to ureterovascularizacostomy and then the closure. So that's the positioning and the port placement that, the patient lies supine. One can have the legs on yellow fins, or one can have straight. It's not necessary to put lithotomy all the time. One can dock between the legs or by the side. It's a choice whether one has SI or XI, and a small periumbilical incision we give. There are some variations, people do it differently, and a gel seal cap is introduced, which allows us to create pneumo and has the lens port and an additional port. So it gives you 2 access ports. After this, the pneumo is created and the patient is turned in about 15 degrees. It's much less Trendelenburg than one sees in the prostatectomy or cystectomy. And the rest of the port placements are the same. Right and left ports and the fourth arm and the assistance port on the right side if the graft is on the left side, and vice versa. After that, you dock the robot and then you start the bed preparation. And bed preparation is simple. It's exactly like we do lymphadenectomy, like you are doing lymphadenectomy on the right side, minus the touching the lymph node. So just bearing the vessels is all that is done. Video is not running somehow. So, it's just that, you prepare the vessels, bear the vessels, the whole length from the external iliac artery and the vein. And then the next step is that you give a transverse incision in the flap, which is a T-shaped flap between the colon and the around inguinal canal. And you raise the 2 flaps up and down and these are used for the preparation of the graft. And after that, once the flap has been, you fill up the bladder and you create a submucosal tunnel as the standard ureterovasculostomy. And then I like to put in a loop through that, and then we create a hole and put in a suture at the apical suture, which will tell us that, otherwise sometimes in blood, it gets lost. And then we proceed to the graft preparation. I hope it works. And, the standard after the defattening of the graft. And the important step is to tackle all high blood vessels very meticulously. And simultaneously, cut Toomey syringes, they are modified. Every Toomey syringe will provide 50 ml of ice. And then you put in a jacket with a hole. And this jacket is fixed on the lateral side. And the hilar vessels are taken out through the cut in the jacket. And while one end is the ureter, the other end, a long suture is left so that you keep the graft oriented. It serves the dual purpose. It allows the graft to be put in, and it also allows the graft to be held and taken around, which is very important step, because otherwise with robotic instruments, you can't handle the graft. After that, you come to the next step, which is the venous anastomosis. And once venous, you put the two clamps on the two sides, the graft is placed in the somehow. I'm sorry. So the graft is placed on the two sides, and the venotomy is done. And after you have done the venotomy, a suture is passed from the upper side, and the vein is anastomosed up down the posterior first. And once you have reached the other end, then you turn around and you take a suture. And this is the suture that we use, the CV6 suture on a 9mm needle, which is the important part of this suture is that it's strong. As the monofilament, it can be pulled through like a monofilament suture, like a proline, but it's strong enough. And otherwise, the proline keeps on breaking, and it doesn't break easily with big instruments. So, once that is done, you turn around and you complete the anterior wall. And once you finish the anterior wall, you put in a ureteric catheter through the ureter, and you put some saline into it. The urologist, the cannula, the ureteric catheter, and it tells you about the leaks. And if there is a leak, you can tackle it. And then you put in a clamp on the renal vein, and you take the two clamps off on two sides, which are now put on the artery, distally and proximally. And once this is not running, so you have put a clamp on the vein and the artery on two sides. Then you do I used to use this knife previously. Now this is not available. With the scissor, you can do arteriotomy. And once the arteriotomy is done, the artery is flushed with the saline once again. And once it is flushed, that's the important step, that 3.6 or 4.5 the sponge you put in through the gel point, and you do a round arteriotomy. And with the same suture, the other end of the same suture. So, the same length can be used, the two ends, 15 centimeter each, one for the artery and one for the vein. And this anastomosis is done similarly. I start from the top again. You can start from the bottom if somebody is fond of. And that's the way, you can pull through the suture easily. That's the beauty of the suture. And the left hand, you see the black diamond forceps, which acts like a debaki. Forceps in the hand, and then once again at the corner, you turn around, you take a suture here so that you can again do the anterior wall from the right to left. And once it is completed, the same, you flush it. And once it is flushed, and then you put a clamp on the renal artery, take the distal clamp off first before you take the proximal, then later on, so that you can test the artery right now instead of doing it later on. And then this is an important step, that once you have revascularized the graft, taken the graft, so then you cut off the jacket, and jacket has been cut off, and it is because it is fixed on the lateral side, so it has to be cut medially. You can design your own jacket, and because you can see there's still ice inside the jacket. So the intracorporeal cooling was sufficient. And then the graft is flipped in the right iliac fossa, and the two flaps that you made, they are fixed with a hemolock suture. And after that, you look at the turgor of the graft, the color of the graft, look at the vessels, whether they are rightly placed. There should be no kink, and you can see the arterial and the venous anastomosis, and the graft has been fixed. And then you proceed to the uretrovesicostomy. Uretrovesicostomy is step is same, that it's a standard. Take the suture and the apical suture. You do the one side of the anastomosis, and then you put in a stent before proceeding to the other side. And with a barbed suture or a V-lock suture, you is closed, and the uretrovesicostomy is completed. And proceed to placement of drain. The drain is placed through the right port, assistant ports. Usually we put a 24 or 28 size drain in the pelvis. And once that is placed, you proceed to the closure of the wound, that's the umbilical wound which has been closed. Subcuticular stitches are put, and then you proceed to we usually, before we send the patient to the ICU, we do a Doppler of the graft, which should show good vascular perfusion of the graft, so that you are happy. Sometimes urine is slow to come, and which happens in all the transplants. So a good perfusion of the graft at this stage gives you the confidence that you don't have to wait, and you can send the patient back to the ICU. So that's it. That's a step-by-step technique. If there are questions at the end of the session, I would be happy to answer them. Thank you. So epidural catheter is not put in these cases. Drain fluid creatinine is done on day 2, and the drain is removed, irrespective of the amount, because it's a transperitoneal surgery. Foley's catheter is removed on the day 4, and 90% of these patients are ready to be discharged on day 6. Thank you.
Thank you, Dr. Alawat, for a very good illustration of step-by-step robotic transplant, and your video and everything is so excellent, and you make the operation very simple. Such a complicated procedure you do with such a ease. Thank you for such a nice demonstration and video. Now I invite Dr. Pranjal Modi. Dr. Pranjal Modi is one of the very gifted and skilled surgeon. He is the only surgeon, I think we can remember him, who could do regular laparoscopic transplant all the time, and we always used to admire his skill. And then he started robotic transplant, and he has done all kinds of robotic transplant, cadaveric, live, dual transplant, pediatric transplant, and he has modified many techniques. And today he is going to speak on the dual robotic kidney transplantation. And it's my pleasure to invite Pranjal Modi to present his presentation and his video. Dr. Pranjal Modi.
Thank you very much, sir, for a very kind introduction, and let me thank you for giving me the opportunity to talk. Just I'm waiting for this to get a full screen. I don't have video. I have presentation, but I don't have video. It's not getting full screen here somehow. Anyway, go ahead without making it full screen. Is it okay with the chairpersons? Because there is some technical error here. I'm not able to put it in full screen. Shall I proceed?
Yeah, we could see it. You can proceed.
Yeah. Since there is no video, there are pictures. So and probably pictures can explain in a several way, because the video has been shown by Dr. Alawat. So I'm going to talk about the dual kidney transplant. Donor factors, we know that marginal deceased donor, when they are present, then it's a dilemma whether to discard the kidney or use the dual kidney, or maybe occasionally the single kidney in two different recipients. There are recipient factors also, especially when patients are difficult to manage on dialysis, when they have fistula failure, they are diabetic and difficult to manage on hemodialysis, or they have very old age and to go for the transplant or not. Very occasionally you have zero mismatch, means full house match is present in a highly sensitized recipient, and there is marginal kidneys are available. So in this case, we should go ahead with the dual kidney transplant. The techniques are like use the one kidney in one iliac fossa. So you use both the iliac fossa by doing anastomosis with the external iliac artery and external iliac vein. However, these are the marginal kidneys, and we all know that in few years later, these patients may require a second transplant, and maybe 5 years, 10 years down the line, and hence it is worth spending one of the iliac fossa. So the second option is monolateral fossa. Here there are some reports where only the one artery is used, external iliac artery only, and the venous anastomosis is carried out either with the common iliac vein or with the one with the common iliac and one with the external iliac vein. The third option is monolateral iliac fossa with transplantation with external iliac and common iliac artery. And here I'm going to present the few pictures related to the same. Like the docking position is akin to what we are doing, the robotic radical prostatectomy here, and the distance between the two working ports are two robotic ports is around 8 centimeters, and there is a single assistant port. Nowadays we used it, and we put a financial incision like what Dr. Alawat has shown is using the midline incision, but we use the financial incision and no device, no hand assisted device which we use it. We put a external aponeurosis incision, that is transverse incision around 7 centimeters, separating both the recti and just to drop down the kidney in. Before doing so, we mobilize the bladder. So dropping down of the bladder takes place first so that it doesn't injure while putting the incision over here on the sheath and mobilizing the, opening the peritoneum. The next step is to dissect out all the vessels. Here in this case, you can see this is the external iliac artery. The ureter and gonadal complex is crossing the vessels at its bifurcation, and this is the common iliac artery. Similarly, here is the external iliac vein, and this is the internal iliac vein, and then just behind it, there is a common iliac vein, which is not seen in this particular picture. Now, through the financial incision, we place the kidney allograft here, and the external aponeurosis is closed. There is no need to close the skin and subcutaneous tissue and other things. So within 2 minutes, the wound is closed and one can go for the anastomosis. You can see here the common iliac vein, which is controlled by the 2 bulldog clamps, and then the venous anastomosis is completed. The video had been shown. Similarly, in the deceased donor, you are having advantage of having Carroll's patch. Here we took a larger Carroll's patch and larger arteriotomy and anastomos. You can see very close by sutures should be taken and tightly, snugly fitted sutures should be applied. Otherwise, there will be a leak from the anastomosis. So once the anastomosis is over, the kidney is flipped to the iliac fossa side, that is on the psoas muscle. You can see the periureteric fat on pelvis and so, and this is the anastomotic vessels, renal vessels. Now, it is a female recipient, you can see, and the second kidney is to be transplanted. So again, the wound is open, and you can have the second kidney. This is the right kidney with the extension of the renal vein, right renal vein from the vena cava, and it was anastomosed with the iliac vessel, in external iliac vein. And then the artery was anastomosed with the external iliac artery. This is completed anastomosis. Here the Carroll's patch is removed because there was a big atheroma at the hilum, at the ostium. And now the kidney is flipped over the, again on the, to the right side here, you can see the flip kidney 1 is here, flip kidney 2 is just above it, and the peritoneum flap, which was raised previously, is now closed at the edges of the, this is the peritoneum, which was left behind, attached with the cecum and appendix, and this was the distal to that, the peritoneal flap was created. You can see that multiple clips are applied to extraperitonealize both the grafts. And then this is one ureter, attached clot is there. So it is implanted ureter 1 and 2 and with the bladder, which was dropped previously. So we don't use routinely the stands and the drain and other thing. Everything is to be done on table, confirm it, especially when output is there. There is no problem in avoiding the stand and drain. It reduces significantly the incidence of urinary tract infection and the number of operative procedures in a post-operative period. You can see this is the incision here. This is the port sites, and this is the wound infection, here immediate post-operatively in a relatively obese recipient. We did just 6 cases like that. That represents around 1%. Till date, we have done 600 robotic kidney transplant. Out of that, only 6 cases are like this. So it's a rare thing to happen. The donor profile, if we see that most of the donors are marginal, higher age, CV stroke or MI and CV stroke are the complications. Very rarely you see RT or so in this age group. And there was comorbidities. What is important is Ramosi score for kidney biopsy is above 5 or 6 in all the patients, and then the terminal creatinine was higher. So these are the cases which we have selected, and then the recipient, if you see, they are not exactly 60 above or so, but they have a long-standing hypertension and difficult to manage on dialysis. They have the loss of vascular access also. Important thing is like the first patient is now having more than 4 years of graft survival. Second patient expired because of pneumonia, which was developed 3 months after transplant. Third patient had a 2.7 creatinine at the end of 12 months, 3.2 at the end of second year, and subsequently graft loss. The fourth patient also had a graft loss after the 2 years. Fifth and sixth patients are having finished 2 years, and they are doing very well. This which we have published in a urology gold. In conclusion, robotic dual kidney transplant is technically feasible and safe, and it is associated with reduced morbidity related to the wound. Thank you very much.
Thank you, Dr. Modi, for wonderful presentation and doing a difficult case and showing the results. So now this session is open for question and answers. And let me check the chat box if there is any questions. So there is a one question is, I think Dr. Alawat has already answered, but he can say it again. What are the indication of doing robotic renal transplant?
So thanks, indications of transplantation are the same, whether it is open or robotic. And since, it depends on the experience of the person. One can do endarterectomy in open surgery also, and in robotic surgery also. So it depends on the person's experience, how he can handle. But initially, at least for initially 50 or 100 cases, I think it's a good idea to select patients who have good iliac vessels and not have atheroma. Otherwise, other question could be about BMI. And as all of us know, who have other people who don't know, they must be apprised that in Chicago, the Oberholzer group, they had been doing kidney transplants in patients since very long time who had been refused open surgery because of obesity. So obesity or high BMI is not a contraindication for robotic transplant. But I think vessels is, there have been patients even in open surgery when we have failed to do and refused transplant. And similarly, a bad vessels would be the main contraindication for not doing a robotic transplant. The third thing that would be a very small child, or where you are not able to create pneumo or flip the kidney, or fourth indication of not doing a transplant is previous transabdominal surgery, where you expect a lot of adhesions and things. So basically the 4 groups: the bad vessels, experience of the surgeon, the previous abdominal surgery, although we have done patients with previous abdominal surgery, depends on how bad the adhesions are, and a very small size. So if Pranjal has to add anything, that will be good.
I think what you said is right. By and large, extremes of age and the very skinny, thin patients do not require a robotic transplant per se, that there is no advantage of it. You can have a small incision, 6 centimeters, 7 centimeter open incision, dissection, and then you can do the transplant by open operation, which is cheaper and quicker, easy to replicate. And even dual kidney transplant has been demonstrated to do it with a 7 centimeter single incision in a skinny patient. So there is no advantage to do it in extremely skinny patient. However, in all other patients, it can be done. Children, we have done 63 liver, this kidney transplant, robotic kidney transplant in a pediatric patient. What is interesting thing is my pediatric nephrologists now, they do not want open kidney transplant. And often you can tackle the concomitant situations like a seminal vesiculectomy, if cyst is present in a renal associated with ipsilateral renal agenesis or so, or maybe uretrectomy if patient is having no much urine output, or maybe combined with the laparoscopic surgery, like we do extraperitoneal nephrectomy, just kidneys to be put into the ilia fossa side and then just do the transperitoneal transplant by endo. The incision through which you are going to put the kidney in, through the same incision you take out the native nephrouretrectomy, what you wanted to do in a grossly refluxing unit or so. So there are several advantages of the situation, and that's the reason why the pediatric patient, the indications of robotic kidney transplant in children are increasing in our center. Previously, we were also skeptical, and my youngest patient was 5.5-year-old kid with a 12.5 kg weight. So it is technically demanding, but it can be doable. So I think the indications are expanding, and one can easily do in most of the patient robotic kidney transplant. Yes.
I think I would like to add one more thing. The young females, it is also a good cosmetic results, and many young females like it once they come to know and come forward that they can avoid any scar, because penile incision can be hidden. An obese patient, it is a definite advantage because they avoid the wound infection and wound complication. Now that next question is that what is the learning curve? You can say that, but we also published a paper, and after 15 cases, you start improving dramatically, and around 25, your most of your learning curve gets stabilized and you can move forward. So what is your opinion about the learning curve? That's what the paper we have published.
So I think we.
Please,
yeah,
please,
Pranjal, please. Yeah.
I found the anatomical variations are pretty good in number, and we have started registering those things. When the arteries are very much oblique, there is no problem. But when it is obtuse, when it goes very steeply down into the femoral vessels, or in some patient, it is a S-shaped artery, almost like a because of the prolonged hypertension. And then these are the cases where the anastomosis is quite challenging. And what kind of case you have, it is very important when you are learning it. And even after doing several cases, sometimes you find it is not an easy task to do. Like in obese patient, the sigmoid colon or rectum sometimes is almost on the right side. It is not on the left side. And with the progress, you retract it, but still there is no adequate space to put the kidney in and to carry out the anastomosis. So all these are variables, and I think one should be very careful when you are learning at the time in selection of the cases. So get done those cases where there is a straightforward anatomy, not very obese, not very skinny patient, and then the pristine vessels are present. If this kind of, like in European patients, rarely you get such type of difficult anatomy, but in Indian patient, we have seen several such. So I think around 30 to 35 cases I would put as a learning case, and also that is to use the left kidney. If you use the right kidney, then it is going to be further challenging, because there are chances that the anastomosis can give away, positioning of the graft is difficult, and you may get a vascular complications also. So I think it depends on the case by case, but overall, if you do the left kidney transplant and pristine vessels, learning curve is around, initially I thought that it can be less, but I think it is, if I try to give it to somebody, I'm concerned a lot about it because this is mostly the living donor program, and vascular complication once occur, it's very difficult to repair many a time. Thank you, sir.
Okay, I think there is a next question is multiple vessels. Yes, the answer is yes. Everybody has taken the multiple vessels. 2 vessels are not difficult. You can join together, reimplant one. And the people have used 3 vessels also using the inferior epigastric or taking the internal iliac. Next question is extraperitoneal. Yes, it is always it is done extra. Finally, it goes to extraperitoneal space. Already, it is quite difficult to look at iliac fossa and that is on the side. Port placement has to be given. I think most of the questions have been answered, except there is one question: has anyone done an extraperitoneal robotic kidney transplant? Yes, in the literature, it is done that they have given the extraperitoneal incision, created the space, docked everything extraperitoneally, and have done it. But the docking is the more lateral side. That paper is published, and rest all the questions has been answered. If anybody wants to say about multiple vessels, what is the youngest age? You have already said about 5.6 years. And I think all questions have been answered in different ways.
Yes, sir. So I will request the chairpersons to give their final comments one by one. And there was one question directed to Dr. Rajesh Alawat, sir, that if there is a case of failed renal transplant, in his experience, will he go for a robotic renal transplant in that patient? This was directed to Dr. Rajesh Alawat, sir.
Yeah, so we have done quite a few second transplants robotically, which means that you are putting the graft in the left iliac fossa instead of right iliac fossa, and it's relatively simpler because in live transplants, when you use most of us may be using internal iliac, and it implies that you have to use external iliac for the second transplant, and you use external iliac anyway for robotic transplant. So it's end to side anastomosis, left side. Only thing is that if you are used to keep on doing on the right side, being a mirror surgery, sometimes you have to get used to that mirror effect. Your hands are moving on the wrong side, but it's quite doable. And secondly, on the left side, actually the vessels are a bit superficial, so actually the anastomosis are simpler than on the right side. About the right-sided grafts being used, I would say that it's much simpler robotically than in open surgery, because I have had a long experience with open surgery, and now with robotic surgery, I can say that I'll use right-sided grafts with much more confidence robotically than open surgery, because in open surgery you have to anastomose them in the depth to the external iliac vessels, while in robotic transplants they are just lying close to the lying in the pelvis. The vessels are just next to each other. The anastomosis is much simpler. The only thing one has to do is that the anastomosis has to be slightly distal, since the external iliac vessels are coming superficial. So if you do slight distally, then the right-sided grafts fall very well. And since the artery is longer, so the artery a bit proximally, and vein, there should be a distance between the anastomosis of the vein and the artery, and that does for the right-sided grafts.
Yeah, I think you're very right. I also initially I was little apprehensive about the right side, but once I started doing, I think I've done 12 or 13 right side and found it quite easier to do it. And one more thing, you usually use the short renal artery, because sometimes there is not enough space to put the bulldog the way you have dissected it. But the short renal artery goes nicely, and that will avoid the kink. And that is the important steps to remember, that whenever do a right kidney, whether open or robotic, renal artery length has to be tailored to avoid any kinking.
So now we'll request all the 4 chairpersons to give their expert comments one by one. Dr. Anand Kumar, Dr. Ajay Oswal, Dr. Kishore, and Dr. Prasoon Ghosh. Please give your comments one by one as a take-home message for this session.
But for robotic transplant, my take-home message is for 3 categories I found it very useful. One is the obese patient, and sometimes we get international patient with BMI 41, 42, 45. And I found when I look at them, probably open would have been very difficult, and robot is doing well. I selected few patients. I did had a problem, but once I overcome my learning curve. Even doing obese patient is not very difficult. Even sometimes you have to press the kidney with the fourth arm to reach to the vessels because of the so much of fat around there. And the female patient, I found it once to suggest them, and they can avoid by penicillin incision, they can avoid any scar, and they are very happy about it. I also found in children this is a very good procedures. But I think the why robotic transplant is not picking up is the cost. Cost is a major hindrance because patients are coming, and I tell them, if you have any financial problem, please do not go for robot. You should have money for your immunosuppression to continue, and robot is not all that important. But if you have no money problem, yes, it is a very good modality to do that. And robotic transplant is picking up, and I must say that in India, it is the maximum number of robotic transplants are done. I think there are now 12, 13 centers who are doing it regularly. And it is all because Dr. Alawat and Dr. Modi who have shown the way and encouraged others to do that. So thank you for such an opportunity, and that's why my comment about robotic transplant.
Thank you. Now, Dr. Ajay Oswal, sir, you want to please give your comments on this session.
Thank you, Professor Anup Kumar. It was really an excellent demonstration of robotic transplants by the pioneers in the field, Professor Alawat and Professor Pranjal Modi, and we hope to keep on learning from them. And I foresee a day when every district in the country will have a robot and common man can afford it. That is the way forward. Thank you.
Thank you very much. Now, I will ask Dr. Kishore to give his comments.
I think looking to the future now, Dr. Kahook from Cleveland Clinic has performed a single port transplant. So I think we being the trailblazers in robotic transplants, I hope somebody will take up an SP2 and a robotic transplant through that. That might probably again change the paradigm once more of the robotic transplant. Thank you.
Okay. So now we'll request Dr. Prasun Ghosh because he has been associated with Dr. Alawat in this pioneer job in India. So his comments on this topic, Dr. Prasun Ghosh.
Thank you, Dr. Anup, for this opportunity. It was an absolutely thrilling experience to watch the stalwarts in action. And it was my privilege to be associated with Dr. Alawat and the team in the initiation and continuation of this program. Well, to put it in very short words, robotic transplant is the future. Very soon, once the cost compromises are taken care of, I think everywhere it will be promoted. I have just one comment and one question. To begin with the comment, for a contraindication to the robotic renal transplant, the cardiac status of the recipient becomes important. So in case the patient is not able to tolerate a steep Trendelenburg or a pneumoperitoneum, that would kind of be a contraindication to this, in addition to what Dr. Alawat and Dr. Modi has already mentioned. And my question is to Dr. Modi, in cases of these dual transplants, monolateral, what is the sequence of the graft positioning? Which one goes first, proximal, distal? I mean, how do you open the clamps? If you could just give me a short brief about that.
Yeah, as shown in the talk, the proximal anastomosis is done first, that is with common iliac vessels, or maybe the common iliac artery and IVC. You open the clamps, so then that graft is already perfused, and then and allow the urine to go into the peritoneal cavity in case the urine production is there, and then go to the distally like with the external iliac vessel. So you never compromise the blood supply of the proximal graft. Just it's a distal graft. So sequence of it is same, which has been shown in my talk, and in that way there is. Of course, the second kidney remain in the ice box before we put it in. So first clamp is open, everything is clear, hemostasis is done, the graft is showing that urine output is there or not, and then after we reopen the wound just to drop the second kidney in, reclose it, and then after the rest of the things. So in my place is I have to look after a lot of economical aspects of transplant, and especially we cannot afford the gel point and so this is the thing very well accepted, and we didn't see any wound infection or wound gapping because of the 2-time opening and closure. That's the caveat inside, but the sequence of event is very straightforward.
Thank you very
And we will always first open the venous clamp followed by arterial clamp.
Yes. Thank you, Professor.
Thank you, Dr. Prasun Ghosh. Dr. Alawat sir, there was one last question directed to you again, because you are the pioneer of robotic transplant in the world now. That suppose a young urologist is trying to start a robotic program, when he should plan to start robotic renal transplant? He's doing the robotic renal transplant open previously. When he should plan to start a robotic renal transplant? After how many surgeries and after doing what all procedures he should actually plan for a robotic renal transplant?
I think the learning curve has been shown to be slightly longer with people who are naive to robotic surgery. Otherwise, robotic surgery, after the basic principles of robotic surgery are learned, one can practice anastomosis first. There are quite a few models which are available, and once somebody is has practiced those on the renal anastomosis of the vessels, one can go ahead and do the transplant. So it's the confidence of the person, and but definitely, if you have about experience of about 100 open transplants and about 100 robotic surgeries in the background, then probably it will be a good point to start, because it has been shown that the basic nuances of holding, how much pressure one should give, how to handle the thread, the hand movements and everything, they take about 100 cases in robotic surgery.
Yeah, thank you very much, sir. So thank you very much all the speakers, Dr. Pranjal Modi sir, Dr. Alawat sir, for excellent demonstration, and all the 4 chairpersons, Dr. Anand Kumar, Dr. Kishore, and Dr. Oswal and Dr. Prasun Ghosh. There was a very enlightening session, and now we move on to the next session. In fact, we are still ahead of time, and hopefully we'll finish ahead of time.
Thank you very much.
Thank you very much, sir.
Really appreciate it.
So we,
thanks to the chairpersons, and thanks to the organizers to give the opportunity. Thank you.
Thank you very much, sir. Thank you.
Thank you, Dr. Anup, for the invite. Thanks.
Thank you. So we move to the next session, which is a robotic radical cystectomy. And the chairpersons for this sessions is the Dr. Hemant Tongaonkar, Dr. Janil Kumar, Dr. Nitesh Jain, and Dr. V. Chandramohan. So I will hand over the session to the chairpersons, and they can start the session now. Dr. Hemant and Dr. Janil Kumar.
Video allowed to open, sir?
Yeah. Good afternoon. Can you hear me?
Yes, sir. Yes, sir.
Yeah. I think good afternoon to everybody, and thank you very much for inviting me to share this session. We'll start with the first presentation on the robot-assisted radical cystectomy. Steps in brief, and I think it's going to be done by Dr. Yuvraj, who's a robotic surgeon and a uro-oncologist from Kokilaben Dhirubhai Ambani Hospital, Mumbai. Over to you, Yuvraj.
Thank you, sir. Good afternoon. Can you hear, sir? Can you hear me?
Yeah.
Yeah. Okay. Thank you so much. Thank Anup and SRS for giving this opportunity. So I will be presenting on one of the video which shows a male cystectomy and a few minutes of female cystectomy, and also extended lymph node dissection. So we know that as discussed in the transplant session, the patient selection is very important. So avoid obese patient, to choose non-bulky disease, and no prior abdominal surgeries. So to learn, so I think we have to divide them into different steps that we're going to show in the video for important. And port position, posterior dissection, lateral dissection, anti-dissection, DVC control, and urethral dissection. So we have still challenges when we do cystectomy, especially when we do intracorporeal urinary diversion, long operative duration, compartment syndrome, etc. So the most important what I feel is that the complications are usually due to prolonged surgeries and patient positional complications. So we should have special care to guard the head and shoulders and adequately padded to avoid neuromuscular injury. And then we have elastic drapes wrapped around upper and lower extremity. Use warm air blanket, hydraulic current stirrups, and then also to prevent DVT, we have to use intermittent compression. So this is the steep tenderloin position. So if you see the position, I think for all the beginners, it will be a little bit scary, but actually it's quite straightforward. So the steps, usually we put in an open technique and all the ports are the direct vision, and pressure usually we measure around 16 to 18 and reduce to 10 to 12 before surgery. And additional bedside assistant placed on the patient left. So I'll just show you the port placement you can make out. So this is the port placement. Actually, it's little in straight line camera, and two ports I put on the right side. Some people put on the left side, it doesn't matter, but I usually put the cardiac forceps from the port C, and one 12mm port here for the assistant and another 12mm from the lateral side. So that's how we do it. And then, so once you're inside, so the first step I do is that is like a radical prostatectomy posterior approach. Go dissect the peritoneum of the subnervous cycle, but don't dissect the subnervous cycle or vas deferens. You create a plane just to separate the rectum. That is the first one. The second step is to lateral dissection, so that where you create a lateral pelvic space medial to the vessels and lateral to the bladder, and this is, we can name it as a lateral paravesical space. So that was on the right side, and this is on the left side. So on the both sides we develop it. So and then once we develop this one, we go for the ureter dissection. So you can clearly see that the ureter dissections with a lot of tissue around the ureter. Don't catch the ureter directly, and we always send frozen section, although it is controversial. So this is on the left side, similar one. So don't apply artery near to the ureter, and also don't skeletonize that. So next is the lateral pedicle, very important. So this is the main important step. When we take the lateral pedicle, there are many methods to do that. The first, usually we apply clip for the obliterated ligament, and then we take N-seal. And with N-seal, it's quite easy to create a space, and then all the it coagulates as well as it cuts the pedicle. You can see that very nicely seen rectum on the right side. This is the lateral pedicle, left side. And you can see that this is the pedicle. When we go near to the base of the prostate, usually I take the clip rather than N-seal, because the rectum is very close, and then sometimes lateral injury may cause injury to the rectum. And the next straightforward step is to drop down the bladder down and go to the apex of the prostate. And then there are two methods again. Either you can ligate it or you can cut it. Because I usually close the urethra when we plan for ileal conduit. So I take 2-0 V-lock and put 2 or 3 throws, and then keep the needle there only. Once in the end, I'll show you that how I close the urethral opening. You can see that. So now I kept the needle there only, and then cut the DVC, and then go directly to the prostatic apex, and then dissect the urethra completely 360 degrees, and then always apply clip proximally. So this is the golden clip. That is the large clip, extra large clip, wet clip. So once you do that, everything is done. So actually cystectomy is quite straightforward. It takes 1.5 hours. And you can see that I close the urethral opening and also take additional sutures on the DVC. Keep the specimen aside in the bag. Generally, I keep it in the bag, and then we go for the extended pelvic lymph node section. The first one is like identify the artery, cut the tissue on the artery. I think majority of you know this, but still. So lymph node dissection makes a very important part of the radical cystectomy. And here, unlike in prostate, we go lateral to the artery and dissect all the external the lymph nodes along the lateral to the external iliac artery. And then you can see this is the vein, external iliac vein. So all the tissue is removed, and then we go medial to that again. So once we finish the lateral one, you go to the medial one. Almost the entire comes as the mass comes as only one piece. So identify the obturator vein and then dissect. And laterally we already dissected the fossa of Marcy. You can see that this is the now there, and remove all the nodes tissue medial to the and as well as lateral to the obturator. Now we can see the deep obturator nodes. So once we do this, this is the standard one, and then we go to the internal iliac. So nodes along the medial side of the internal iliac artery. This clip helps me in identification of the iliac artery. Otherwise, if we don't put the clip, we don't know whether sometimes it looks like a lymph node. So once we do that, then we go for the common iliac. So now we extend the dissection proximally. This is 30-degree telescope down, and then you can see that. So the entire common iliac nodes has been removed. And then medially, you can see that we go for precervical nodes. So just medial to the common iliac artery, you can go there and see the complete removal of the presacral nodes. So this is how we do extended lymph node dissection. Once we complete this, so then we go for the intercorporeal that will be discussed by the next speakers. And then few steps in female cystectomy. This is the left-sided lymph node dissection. You can see that. So nicely, all the boundaries are made out. And then we transpose the ureter to the right side. And then the female cystectomy. So the steps are almost the same. So I go posteriorly. You can see that lift the, fold the uterus up, and then go and try to dissect, create a plane between the rectum and the cervix and the vagina. And once you do that, the lateral dissection remains the same. So we go lateral, and in this patient, I think young patient, we preserve the ovaries. And this is the ureter dissection, which we already saw that. And then the most important is the posterior dissection. So now we know that all other steps are same except the posterior dissection. In the posterior dissection, what I generally do is that I keep a sponge in the vagina, posterior fornix. So this is the the round ligament that is fine side forward. Sorry. So now you can see that. So there is a sponge stick there in the vagina, and this is the all the pedicle which is lateral to the sponge stick, we take it with the NC and then drop down the bladder. Here again, so we have to identify the junction of the bladder and the urethra. Little difficult because you can see that. So the almost entire urethra, I can say more than half of the urethra is completely removed after clipping it, and then the specimen is delivered through the vagina. And then we close the vagina by using Vila. That is a quite straightforward technique. And so this is how we do female cystectomy. So as of now, we have completed almost 250 cases, and mortality, 30-day mortality was in 2 cases. Thank you so much.
Yeah, Yuvraj, thanks for sharing your huge experience of radical cystectomy. Now we'll go on to the next video. That is by Dr. Abul Fazil Hussaini. He's from Karolinska University, the center from where neobladder became popular. So I invite Dr. Hussaini for his presentation.
I want to thank Dr. Karolinski for Dr. Hussaini for accepting this invitation. Dr. Hussaini is a consultant urologist from Karolinska University Hospital. He's the head of the bladder cancer section from IRUS Scientific Working Group. So welcome, Dr. Hussaini, to this program, and please you can share your screen.
Thank you so much. Can you see my video?
We cannot now. Probably you may have to reshare it.
This one. Can you see now?
Yeah, now we can see.
So thank you so much. It's an honor to be in this prestigeful Congress, and I'm going to talk about the neobladder specific Karolinska technique. As you know, the number of intracorporeal diversion is increased during the last year. In the particular time, the ileal conduit was increased, but we can see even the slight increasing of the neobladder from 7 to 70%, but this publication is almost 7 years old, and I think that is much number today is done intracorporeal urinary diversion with neobladder. There are some, sorry, Yes. This is some centers that have done its own pouch. It's a powder pouch, pyramid pouch, Y pouch, Southern California, U-shaped pouch, W pouch, and our own technique, Karolinska technique, which is one of the pioneers in the robotic cystectomy since 2001. Regardless why and how you do the reconstruction, it has been with good capacity, with low pressure. It should be enabled spontaneous micturition, easy with endoscopic access to upper urinary tract, and of course, preservation of kidney function in long term is very important. The neobladder should be, of course, continent, and some factors that can affect the continence: a good urethral length, intact pelvic structures, nerve sparing in male, and of course, organ sparing in female. Should it be anti-reflux function? It's debated, and there is some randomized trial that show no difference in reflexive and anti-reflexive reimplantation of the ureter in terms of the kidney function in long term. In Karolinska, we use 6-port technique as shown in the previous talk. We use the camera port about 4 to 6 centimeters above the umbilicus, and 2 robotic in the line of the umbilicus, 2 assistant on the right side, and the 4th arm on the left side, which is a 15, and the staple is going through this 15mm port from the left side. During the diversion, we reduce the Trendelenburg to 12 to 15 degree, and this is our pouch. We use almost 55 centimeters from the ileum, which is isolated about 25 to 30 centimeters from an ileocecal valve. I'm going to show in these schematic figures that the first step that we do, the open ileum, and in some case that you may have difficulty to reach down the ileum to the urethra, we can of course use the different tricks, and this is one of the tricks that we use: put a legal loop around the ileum and put it down to urethra. And this as an anastomosis done with one Welthoven technique. After anastomosis, we separate our reservoir, use the 60mm staple, and then we make the anastomosis of the bowel with double 60. And when the bowel is isolated, we open almost 40 centimeter distal part of the C segment, anti-mesenteric, and keep the 12 to 15 centimeter in the proximal side as a chimney. And then we close the dorsal wall. Then we fold down the half of the anterior wall, and then we make the Wallis technique, put ureters through the chimney to ureters and make this anastomosis. And that last step, we close the left side, the anterior part of the reservoir. That is completed. This video is showing the female reconstruction, but we do the same technique with the male. I had some issue with my male video, but this is almost the same technique that they use. And as you see, I kept the uterus and all gynecological organ intact for this lady. You can see in this video, here is the appendix. From the appendix, we identify the ileocecal valve, and from here, we choose almost our segment, 25 to 30 centimeter. The first thing that we do, open the ileum here and make the anastomosis to the urethra. I never had any issue to take down the ileum in female patients to the urethra, but in some cases of male, it can be very short to take down, and you can use the different trick with the legal loop that I show. You can even cut the meso in the different part of the meso, take a longer meso length, or in some cases, even maybe you have to separate, isolate your 60 centimeter segment from the gastrointestinal canal, that you can make it more release of the bowel to do this anastomosis. But this is a tricks that we are not going to show in this video. This is a standard video for orthotopic no bladder. This thread is 2O coil. And you see it's a Van Welthoven technique we use here. As you see, urethra stump is very dominant. It's very important that you keep the length of this urethra in both female and male. Maybe you have a more consider about the retention in female, but less in male. In our hands, we have about 10 to 12% of female that have retention that needs to do catheterization. When this anastomosis is done, you see almost without any traction. And then from anastomosis to the urethra, we measure about 12 to 15 centimeter. And here we put our the first staple, it's a 60 that go through the bowel. This is our distal segment for the pouch. And you can see you can use the same segment to measure the other proximal site, which is about 40 centimeter inclusive or chimney. When this separation is done, you can make the anastomosis of the bowel. I hope that you can see good quality of video. I don't know how is with Zoom transmission here, but so this is a 60 millimeter staple that we go through the bowel, one side, and this is the other side. The staple is coming from the left 50 millimeter port that I show with my first slide port placement. And I do always two 60 millimeter staple for this anastomosis, that we don't have any issue for the wide of anastomosis here. And this is the last 60 millimeter and close the bowel like this. And you see the good length of the bowel. Now the distal part of the reservoir or pouch is open in the antimesenteric line. Assistant is coming from the right side, help me that stretch the bowel. And here we are going down close to the anastomosis to the urethra. Here you have to keep in mind that this part of the bowel should be quite wide, that you can make your anastomosis later on, which I'm going to show you. Here is the proximal part. From here it's about 12 to 15 centimeter, which I left for chimney, and the rest of the proximal part is open antimesenteric, go down and reach the other opening that I started from the right side, you can see here. So when this is done, we do some state suture for dorsal wall. You can see this is just left for chimney. And this is our last stitches in the corner. I don't put in the corner here, a little up from the corner. It's about 6 to 8 centimeters from the corner. This is the same place that we are going to fold down the anterior wall, which I'm going to show you in the later now. The stage switcher is put now, and we close the dorsal wall by using the V-lock. It's a 3-0. It's important you can keep the just cerebromuscular layer to make this anastomosis. So this is the part of the dorsal wall. And here is the corner that I told you, which we are going to fold down the anterior wall here at this level. The catheter is almost inside through the urethra, and the balloon is filled just with 3 cc normal saline. So that is almost the last part of the dorsal wall that I'm closing here. And when this is done, we go to fold down the anterior wall. So you can see here is the anterior wall. I'm starting from the corner that I make my first stage suture and go down almost 6 to 8 centimeters from the urethra anastomosis. I put the first stitches there. And then continue just like this. In some cases that this is video done by just 0 optic, but in some cases you may need 30-degree down to have a better vision, specific in the patients that have a deep pelvis. It's strongly recommended to use 30-degree down here. Just go down to the close to the urethra, and now I grab the catheter through this opening. And put it here and go and complete this anterior wall that you can see here. Here is our urethral anastomosis on the right side here, that when you close here, it's going to be like a S form and not cylindric shape. So this is the last part of the anterior. The urethral anastomosis is here. And then we make the Wallace technique. The ureter is almost to the right side. The left ureter is passed underneath the colon to the right side. And with the right ureter, we make the Wallace technique. It's a 5 OPDS needle, which is very nice needle. It's a sharp needle, but it's not cutting, which is very good for this part. Some surgeons prefer to do the breaker implantation here, but we do always Wallace technique, even we do the open cystectomy with diversion. So now the posterior wall of the anastomosis is closed, and now I am opening the proximal part of the chimney. This is our chimney, and I go through the chimney with needle driver through the opening of the reservoir and take the ureter, which is coming from the abdominal wall, and put in each ureter. This is the left ureter, and this is the right ureter that you can see here. So it's very clear here. We have the chimney, the proximal part of chimney here. Take the 3-0 quill for this anastomosis, start from the corner of the chimney and take the first bite on the left side of the left ureter, not in the corner, slightly up from the corner to the left. And go back. Here is again the Van Welthoven technique. So the left part, we put 2 stitches, and now from the other side, try to take also here a seromuscular bite to put the stitches to the, the first is also put in the left ureter, you can see here. This is still on the left side. I think this is a very important part of the surgery. If you have some issue with leak here, it's going to be a problem in both short and long periods. So its adaptation of the posterior side is done, and then we started from the anterior side, close to you. Again, from the bowel, take a seromuscular bite here and go through the whole wall of the ureter on the right side. So here is the anterior side is closed, and now we take down and go to the left side. And now you see it's much easier to find the ureter here when I put my first scissors on the left side, not in the corner, a little higher up. It facilitates this part of the closing of the anastomosis. So you don't need to go down to find the corner when you are here in this part. So now it's the last part. The anastomosis to ureter is done. I'm going to close the rest of the anterior wall here. The same thread. It's a 3/0 V-lock V23 needle. It's a small needle. So now the pouch is down. You can see here. This is the ligament, round ligament on the both sides here. It's a female patient, and the reservoir is down. We fill the reservoir with almost 60 cc normal saline. Just check if we have any leak or not. This is a thread of specimen, and now we fill. So I think it's done. Okay, which patient can be a good candidate for neobladder? We have some general consideration about the overall functional status of the patients, comorbidity, of course, and which age has the patients. About the oncological consideration, cancer at urethra margin is absolute contraindication for orthotopic no bladder. Involvement of the bladder neck is associated with a higher risk of the urethral recurrence. But bladder 3 and 1 involvement are not at higher risk of the recurrence in urethra, and the patient with lymph node dissections, lymph node metastasis is not at the higher risk of the urethral recurrence. Some exclusion criteria for orthotopic no bladder is neurologic disease, pre-existing urinary incontinence, urethral strictures, unable to self-catheterization, previous pelvic radiation, bad kidney function with glomerular filtration less than 60 millimeter per minute, and severe hepatic insufficiency. I want to some message home. Critical patient selection is maybe the most important issue to select of the patient for neobladder. Nerve sparing RARC in male is strongly recommended, like gynecologic organ sparing in female in selected case, of course. And when you do the female orthotopic neobladder, for prevention of physicovaginal fistula, you can put omental flap between the neobladder and vagina. And last, the surgeon and not the technique can improve the functional outcome. So thank you very much. This is my last slide.
Dr. Hosseini, shall we take the questions at the end of the session, or will you be available after the session, or should we take the questions now?
Yes, now we can. You can decide. It's okay for me. I can stay with all sessions.
So we'll finish the session and come back for questions then. So
yes.
Shall we proceed? Yeah.
Gilil, I just have to make one comment here. Hello, can you hear me?
Yeah, we can hear.
Yeah. I just wanted to say this was an excellent demonstration of a robotic intracorporeal orthotopic neobladder, and he's been able to replicate almost all the steps that one would do in an open orthotopic. But one of the criticisms of robotic cystectomy is that neobladders are underutilized. Now, do you think that only a person who can do an orthotopic robotic neobladder should be doing a robotic cystectomy?
Should I answer?
I said one of the criticisms of a robotic surgery for bladder cancer is that orthotopic neobladder is underutilized. Most people after a cystectomy tend to do an ileal conduit, and unless one is very experienced in robotic surgery. So do you think that only someone who can do an orthotopic neobladder, only that person should be doing a robotic cystectomy?
It's a very good question. I think that the less utilization of the orthotopic neobladder generally depends that we have in our client, we have a very elderly patient which is not suitable for an orthotopic neobladder. I mean, we have a limit of the age with 75 that we don't go over for have a neobladder. This is the most important factor. And second factor, of course, I think it's depend to the surgeon. If the surgeon, it doesn't matter, even you do open cystectomy, if you are not familiar to do orthotopic neobladder, you never recommend your patients this diversion. And this is the same issue in robotic cystectomy. When you learn these two techniques and you can do orthotopic neobladder as the same way that you can do even open, of course, you can offer your patients the orthotopic neobladder. I think there's a lot of this decision is depend to the surgeon and the patients, of course.
Thank you so
Added to that
much.
question, sir, how many cystectomy or conduit you prefer to have being done by the surgeon before you switch over to neobladder?
Yes, I think so. Yes, I do.
Approximately how many we have? 30,
I mean,
40.
yes, I have been proctor almost in every center in Europe, and we started robotic cystectomy But my recommendation and my experience, because I worked with Peter since 2001, and we have done more than 1,000 robotic cystectomy at Karolinska. My recommendation to my colleagues is that start with breaker conduit and do at least 20, 30, 40. It is very individual. I mean, some surgeon can learn very quick and do the same procedure maybe after 15 breaker. Some surgeons needs to do after 30 or 50. It's self-confident that you can, but at least to do 20 to 30 breaker, because orthotopic neobladder is a diversion with many steps. It's not difficult, just to keep in mind that you do all the steps in the same way that you have to keep in mind. If you forget some steps, is unforgettable. So that's my recommendation. Yeah.
So among all the steps, which step you feel that a junior person who is going to start a neobladder should be very well versed with? Stapling, then ureteric anastomosis, or suturing, or urethral anastomosis? Which is the critical step where there can be issues, maximum issues?
The biggest issue with orthotopic neobladder is the two anastomosis. One, the urethra-ileal anastomosis. In some cases, as I mentioned in my talk, you may have very difficulty to reach down the ileum to the urethra. So you have to be able to use the different tricks. You can do the Rocco stitch, you can cut through the meso, you can put a legal loop around the ileum, but you have to be able to do, and you have to be familiar to do. And the second part, which can be very important, is the anastomosis to the ureter. I mean, if you have leak of urine, it's a catastrophe, you know. Even you have a very nice bowel anastomosis, but if you have a urine leak during the long period, it can harm your bowel anastomosis. And I look at in our study to see the rate of the urethral and ileal anastomosis strictures, and it was the most important factor that was was the urine leak in this part of the anastomosis. I think it's something that we have to keep in mind to do this anastomosis very safe, that you can be safe and sleep overnight.
Hosseini sir, very nice demonstration of the technique. I wanted to ask you, in this technique, after making the neobladder, you made the two ureters brought to the center and side to side anastomosis is done. With this, do you need to mobilize a little more ureter? And they were looking little taut to bring the common ureter into the proximal part of the ileum of the neobladder. Instead, can we put on the sides? Anyway, we are doing non-refluxing anastomosis. When they have to bring together, especially in a neobladder, are they not put under tension?
It's very good comment. I agree with you. You can put the ureter-ileal anastomosis in each side, and you don't need even to do the wall split. I mean, some surgeons like Gaston do the anastomosis according to breaker in each side of the chimney. So you can do it, especially in the case that you have a short ureter, and if you have a ureter, in case of cancer in situ, I usually take frozen section. And in some cases, I have cancer in situ in distal part, which I have to cut more and more. And at least maybe I have a very short ureter on the left side, which is not suitable to take to the right side, because you increase the tension, you increase the risk of the strictures. And in that case, you can always, of course, put on the left side to the chimney, which I do when I reoperate of or anastomosis strictures. I cut and put the left ureter on the left side of the chimney. Yes.
Yes. Thank you.
Dr. Hosseini, initially I was very skeptical about the shape of the neobladder, because what I used to do in the student was not exactly replicated in any of the neobladder. Do you think that the bladder function of all the neobladder different neobladder are similar, or is there any advantage for any particular method? Or do you think that your own comparison of open versus robotic, is the bladder function similar?
We didn't done any urodynamic study in our orthotopic neobladder about robotic, and something that I just can compare that they can reach a capacity up to 400 cc after maybe 6-8 months, and they can. I mean, in our study, we had almost about 90% continence in daytime in our male patients, and about 75% continent in female patients, which is comparable with open cystectomy that we have done in Karolinska. The capacity is almost the same. The shape is almost the same after a while, and but we didn't done any urodynamic study to look at it closer. Is any difference between the open or orthotopic neobladder? I don't know. I can't answer.
Dr. Hosseini, Dr. Himal wants to ask one question. He wants to make one comment, and then Dr. Janil, you can carry to the next speaker. So I think because we have to go to the next.
I just wanted to ask the question: is hello?
All right.
Have you had instances where during your surgery you find that the ileum is not reaching the urethra? Is there any particular procedure that you follow in such instances?
If the ileum doesn't reach to the urethra,
yes,
so
that happens occasionally in patients with a high BMI and a short mesentery.
yes, maybe the patient which has high BMI and the patient which is short, not tall, the fatty patient short is very difficult issue that we have to take down the ileum to the urethra. And in some cases, I had converted the ileum because I couldn't reach down the ileum to the urethra. It's happened, yes, of course. Even I do a lot of tricks, but still I can't take down the ileum to the urethra, and it happens, but it's not very common.
Great talk, Dr. Hosseini. This is Dr. Hemal from Winston-Salem, North Carolina. As always, wonderful talk. So, the couple of questions were being asked, so I was just listening. So the reason is, there are three factors when we talk. You should not go with, oh, I want to do ileal conduit or we want to do a neobladder. So most important is a patient factor. Patient factor in a sense, you have to think about the disease. You are treating a cancer. You are not treating a reconstructive surgery. So you have to see the biologic aggressiveness of the cancer, whether you can do a neobladder or not, number one. Number two, also you have to see what kind of, if it is a variant histology or so, because these people, they're not going to survive more than a year or 2 years. The third factor is, think about the patient coming from the remote area. He cannot do a CIC. Perhaps he may not want to do a neobladder. And same thing coming to the kidney function. If the kidney function is not good, the GFR is low, perhaps you don't want to do, because it's not the question of technically fit. You did the surgery and everything was fantastic. And after 6 months, patient is coming with the several problems. Now, the Raghunath asked question for the robotic versus open. As Dr. Hosseini, myself, we all learned, like I was in AIMS, we were doing open surgery. Then we have been doing laparoscopy. And actually the first robotic orthotopic neobladder we did in 2002 in Egypt. That is the first robotic surgery published for the orthotopic neobladder. So think about that. 18 years back, we described these techniques, and we learned from Dr. Hosseini and Dr. Wiklund, because we were doing a W neobladder, because we learned initially from Mansoura, they were doing a more W neobladder. So in those cases, as Raghunath was asking, if it doesn't reach to the bottom, what you can do. So W neobladder and the other kind of technique you can do. But if you are doing a Studer's technique, in this, the first thing is you can anastomosis the ileum to the urethra first, and then open the ileum, and that is the way to assess whether your, the ileal, the neobladder part will reach to the pelvis. Great talk, Dr. Hosseini, and thank you, Dr. Anu.
Thank you, ma'am. Thank you.
Thanks for your comments, sir. That was an excellent session by Dr. Hosseini. We'll move on to the next session. Next is about female neobladder by Dr. Manohar. Anup, I think Manoharan had some issues in logging in, isn't? Can we run the
Dr.
video?
Manoharan, yeah, we can play Dr. Manoharan's video now.
Hello, everyone. Today, I'll give you a brief overview on a few steps in robotic-assisted neobladder reconstruction in women. I have no disclosure. As you all know, since 1983, the number of ileal neobladders being performed have increased significantly over a period of time. But however, since 2005, the numbers between the ileal conduit and the neobladder reconstruction have plateaued. In our center, in men, about 70% of the people undergo ileal conduit, about 30% undergo neobladder reconstruction. Whereas in women, about 86% undergo ileal conduit and 14% undergo neobladder, and this trend is seen all around the country and the world as well. There is a significant difference between a male and a female anatomy with regards to bony pelvis, space, sphincter, and the urethra. If you look at men, whether it's a large man or a small man, the pelvis is narrow and the pelvic outlet is acute, and it allows for the rectum and the urethra. Whereas in women, whether it's a large woman or a petite woman, the pelvis is wide and the external outlet is obtuse, and the levator allows for the vagina, urethra, and the rectum. If you look at the female urethra, it's very short. It's about 4 to 5 centimeters in length. And the sphincter is away from the bladder neck. It's situated in the mid urethra, which is crescentic in shape, mostly in the anterior and the anterolateral aspect. When you look at the male and the female urethra, if you take the male, the resection margin at the apical aspect of the prostate is directly onto the sphincter, which is at risk. However, the bladder neck is away from the resection margin. Whereas in women, the bladder neck is away from the sphincter, and the sphincter is in the mid urethra, so the sphincter is not at risk, but the bladder neck can be positive for disease margins. When you compare the male and the female neobladders, in females, because the pelvis is wide and the neobladder can flop backwards, and the angle between the urethra and the neobladder can increase, leading to hypercontinence, and about 40 to 50% of women might need CIC, whereas only 10 to 15% men need catheterization on a regular basis. The fistula between the neobladder and the vagina is not uncommon, whereas the fistula in men are very, very uncommon. I normally place a omental flap between the urethra, so between the neobladder and the vagina to prevent the fistula formation. When you look at the robotic approach for the female neobladder creation, one of the biggest advantage I feel is that I can remove the specimen through the vagina and there is no formal extraction incision or any incision to do the neobladder formation. But as I mentioned, I always prefer to do an omental flap which supports the neobladder, supports the bladder emptying, but with a robot, it's difficult to create a formal flap, omentum flap, and put it between the vagina and the neobladder. Today, I'm going to discuss some steps of neobladder reconstruction over the next 5 or 6 minutes. And the key thing in the neobladder reconstruction using the robot is to make the procedure standardized, repetitive, less help from the assistant, and it makes it easier and quicker. The first step will be, for me, will be to remove the specimen through the vagina. I normally remove the uterus separately, either through a bag or directly, which is a straightforward procedure. Once I've done that, I use a 15 centimeter extraction bag through the vagina, and I put the specimen, the bladder specimen into it, make sure that the bladder neck is inside the bag, and then I pull it out through the vagina. And this is a reasonably straightforward and somewhat good aspect of the procedure. And then I close the vagina with a 2-0 vicryl or a Bob suture. After this, we are going to do a formal lymph node dissection, and you're going to remove the, move the left ureter under the sigmoid to the right side. Once you've done that, you're ready to move on to the next step of the neobladder recreation. And once you've selected the segment of the neobladder, I identify the apex of the neobladder. The most important step is to anchor the apex of the neobladder segment to the pelvis under the urethra. This one step has changed the way the neobladder is done. It fixes the neobladder to the pelvis. What happens then is that the entire neobladder throughout the procedure remains stable, and I do the step even before I do the bowel resection. This has made the procedure so much easier compared to the way we did that 10 years, 15 years ago. And I use a 3-0 barb suture, and it's a cerebromuscular suture on the neobladder side and the tiny sutures on undersurface of the urethra. It will be usually tension-free, and it anchors the neobladder very nicely. Once you've done this, I do the bowel resection, and that is much more easier because the bowel is stable, and you had really need very little help from the assistant. Once I fix the apex of the neobladder to the undersurface of the urethra, I move on to the anastomosis between the neobladder and the urethra. This step, I do it before I do the bowel resection. What I do is that we create a small opening, which is about 32 French in size, using the Bowie. And once I do this, you can see that the neobladder is so stable, you don't need much help from anybody. And this opening is directly anastomosed to the urethra using a double arm suture with 3-0 barb sutures. And if you look at it, this anastomose is exactly the same as the way I do the prostate. It's reasonably straightforward. Everything is fixed, nothing moves, and the vision is good. And you do the anastomosis between the urethra and the neobladder, bladder neck directly in a sequential fashion all around it. Some surgeons do only half of this anastomosis, whereas some surgeons prefer completing the entire anastomosis at this point. I normally prefer to do the entire anastomosis at this point and keep the neobladder reconstruction separate. As you can see that the assistant just needs to move the catheter in and out for you, and otherwise the whole thing is very, very stable and reasonably straightforward. And I complete the anastomosis just like any other robotic, bladder neck urethral anastomosis. I normally use a 3-0 V-lock sutures at this point of time, but you can use any suture you like. Once I've done this, what I'm going to do is that complete the neobladder creation, but I will be doing the bowel resection at this point, then go on to the neobladder. When I do the neobladder, I normally create a J pouch with a 20 centimeter or 15 centimeter chimney. I've tried different pouches, but at the end of the day, all the pouches become a sphere. So the J pouch is much more easier. It's, as you know, that the right and left limb is about 20 to 25 centimeter long. I place about 4 to 5 stay sutures using 2-0 Vicryl on the antimesenteric border and leaving a small tail as a tag. This allows me to give traction when I suture them. I'm removing the staple line from the urethra. Then I'm using the third arm. I give a traction, and using my left hand and a scissors, I open the neobladder along the entire length. Here we are opening up the right limb of the neobladder, and you go all the way down up to the bladder neck. But when you come close to the bladder neck, remember you've done the anastomosis already, the resection should be closer to the mesentery so that the bladder neck is, the anastomosis is away from your suture line, and where you're dividing now becomes the posterior wall of the neobladder. I've done the right side at this point of time under the apex. Now we are going to move on to the left side. You can see the Foley catheter coming in nicely and the anastomosis separate. Now I'm going to open the neobladder along the left side to the entire length. Remember, the whole thing is about 20 centimeter posterior wall, 20 centimeter anterior wall. It needs to be sutured together. The key to this procedure will be the stay suture, which makes the life much more easier. Now, like I'm completing the opening, I'll be ready to suture the posterior wall. With the third arm, along the distal aspect, I give traction, and the assistant holds the other stay suture and gives traction. And I use a 3-0 Stratafix, which has got a nice needle, to suture them together. You suture it just like any other neobladder in a serial manner, which should be watertight. You can see that my third arm pulls up the stay suture as you move on, and the assistant pulls the other one. He makes the suture line straightforward, and he keeps suturing again and again until you complete the posterior wall. Once you've done the posterior wall, all that you have to do is do the same thing with the anterior wall and complete the neobladder formation. Before you close the anterior wall completely, I will be doing the urethral anastomosis to the chimney, and I'll be bringing out the stent. Once I bring out the stent through the anterior wall, I secure it to the anterior wall and bring it through a separate stab incision the right side. The stent stays for 2 weeks, and the catheter stays for 3 weeks, and I don't normally place any suprapubic catheter. And you can see the stents are coming out along the thing. and the entire neobladder formation is complete. And then we continue with the closure of the ports. And in summary, the take-home messages are: the female robotic assisted neobladder reconstruction is safe and is an established procedure. And as a surgeon, you should make the procedure standardized, repetitive, and make it easier for yourself. Vaginal preservation, vaginal sparing is safe in most cases and certainly improves the outcome. And in my view, barb suture is very helpful and safe. It allows for a quicker reconstruction. Thank you for your attention.
Thank you. Thank you. Thank you very much. I think that was an excellent demonstration of neobladder in a female patient, and we all know the procedure to do even by the opening, like fixing the bowel right up front, so that there is not much of a movement while you're doing the anastomosis. And I think that was a very nice idea. Well, so, how often do you do a neobladder in a woman? Suppose 10 women have to have a cystectomy. In how many would you really consider doing a neobladder on an average?
So, Dr. Hemant, sir, we can take the questions in the last because he has logged out. So we can go on for the next lecture, sir. It is Dr. Raghavan. Yeah, we can invite the next speaker, Dr. Raghavan, for robotic conduit, sir.
All right.
Yeah, Dr. Rajpruti couldn't log in, so Dr. Raghavan has taken up that topic. Over to Raghavan. Conduit.
Good evening, all. I hope all of you can hear me well. And my most respects to Dr. Hemant and my close friend Ginil and Anup. So good evening, all. Today I've been given the task of talking about intracorporeal ileal conduit diversion. So I'll start off with the video. I hope I'm clear in my thing. So the first step of the ileal conduit diversion is that cystectomy has been done, and we need to create a window between in the mesocolon to reroute the ureter to the left side. So one technique which I wanted to tell is that if you lift the mesocolon well, you will see the pre-aortic tissue, which will be part of your lymph node dissection when you're doing the pre-sacral. Most of us tend to do pre-sacral as well. I tend to do it as well. So that window will automatically open up and give you the routing for the left ureter to come to the right side. Once it has come to the right side, you place the ureter, and I tend to place it and put it a clip at the end of the ureter into the right side of the lateral wall. Now, at this point, we create a new port on the left side, and you because the assistant has to bring the stapler into the abdomen, and hence we change the arms. Just to give a context, I tend to do my cystectomy with my left hand on the left side, or the third arm on the left side, whereas most of the people will do it with the third arm on the right side. So once the cystectomy is done, only for the conduit diversion, I bring my extra arm to the right side. So the port, the 11 mm port, which was usually used, the assistant arm on the right side, we put the robotic arm, the 8 mm robotic arm, and that becomes the third arm on the right side. And the port which I was using for the third arm will become the stapling port. So once again, everybody is different in the way they suture. I use just a vicryl thread or 20 centimeter thread to or a scale, whichever the nurse is ready to give, and make a tiny window and mark it there, and put one suture there, which is marked as the distal suture. I do not do more than one suture, just one suture, and then you work your way up there. And this is just an extra suture, but it is more for holding rather than anything else. Now the assistant brings a staple inside. I use a 60 centimeter staple length for that. If the mesentery is thin, I use a 45 centimeter staple. This one is a 45 centimeter staple. You look on either side and apply the staple. the end of the stapler always will bleed. So use a bipolar diathermy to diathermize, and then gently work your way so that you get the extra length in your mesentery. Repeat that in the distal loop as well. And once again, bipolar and divide that extra length. And inevitably, this is sufficient. Place the ileal loop more caudally, not cranially, and then you are ready to do the intestinal anastomosis. Definitely use 60 centimeter. I think Yuvaraja sir does 100 centimeters, which is 100 millimeters. That is, you do 60 and 40. Whichever is comfortable, do, but 60 is bare minimum. After that, I tend to close the opening with PDS, and that will finish the ileal anastomosis. So once again, to repeat, you use 145 for the distal, 145 for the proximal, 160 for the anastomosis. If you are not comfortable, put a 60 plus a 40, and then close the ileal loop there. I also put the safety suture beyond the anastomosis, and now you are seeing what you are seeing there is the ileal loop staying there, which is there for us to remove. The suture, the technique which I do for the uretero-ileal anastomosis is called modified Bricker. Give me 1 second, I'll put the phone on silent, just 1 second. Thank you, Ganil. I'm so sorry. So what we do is both myself and Sanjay does this often, modified Bricker. So you take the left side ureter and do end-to-end anastomosis, versus the right side ureter will be end-to-side anastomosis. The suture which I use for this is the Stratafix 30, which is the same suture which we use for urethro-ileal or robotics after robotic prostatectomy, vesico-urethral anastomosis. So you do one layer posteriorly, that is one side of the window. The Stratafix suture allows a very snug fit. In this step, all the layers of the ureter and all the layers of the ileum are taken. The mucosa becomes a buttress for the urine, and therefore the leak, in my opinion, doesn't happen. There are a lot of people who do only mucosa to anastomosis. I find it a bit uncomfortable with it. I do tend to take a tiny bit of periureteric tissue to give me the buttress and the mucosa in the ileal loop as well. Once you complete it, you do a knot there so that you are not having a completely cicatrizing all around suture. So then go to the anterior layer now. Before going to the anterior layer, put a stent in. I tend to use a mono-J stent. And then what I tend to do is I fix the mono-J stent using a vicryl repeat suture. Then the anterior layer is started. The other end of because it is a double-ended needle, so you have another needle to start with, and that will take care of the anterior layer. After comfortably, you start threading the stent into the other side so that the anastomosis can be completed comfortably. Usually the end-to-side anastomosis takes longer, anywhere between 7 to 8 sutures on one wall is required. Whereas on the right ureter, you will hardly put 3 and 3. That will finish it off. So then you rotate the ileal loop. On the posterior side of the ileal loop, make a small hole. That is a very nice urine flow. So, and make a buttonhole in the ureter as well, and then do the anastomosis for the right side. So this is what we describe as modified Bricker, which we recently published as well as a video journal article. So the general experience with modified Bricker is that the stricture rate for me so far has been one patient has had stricture, especially the left side, in a neobladder patient. The rest of all the patients have not had strictures. Now, and I haven't had any urinary leak from the modified Bricker as well. Once again, finish one wall, put the stent, fix it with vicryl repeat, and then start the other wall. And after you've taken the first suture, then thread the stent into the ileal loop to bring it to the other side. The one thing I wanted to say is that because it's a continuous suture, do not cicatrize the anastomosis. Put a knot in between. I tend to put 3 knots so that the anastomosis doesn't become a tight ball. So at the end of this, then the mesentery is closed and the ureter is ready to be taken out. What you are seeing is the ileal loop being taken out of the abdomen. Thank you so much.
So, Neil, yeah, you have 10 minutes now. You can have a discussion and comments from the chairperson.
Yeah, there are some questions. Chandramohan,
Bhagavan,
any
sir,
point?
I wanted to ask you a question. What is the advantage of the left ureter opening so much on the left side and doing end to end? It can be placed side to side like in pyeloplasty, where the movement will be less and the stenting will be easy. I mean, I have done it in laparoscopy. That means it easily can be done in robotic. Can you emphasize the advantage of this modified Bricker, please?
Yeah. The most commonest point of stricture in ureteroileal anastomosis is left ureter, because the distal part of the left ureter is where the vascularity is thin. So what happens is when you reroute the ureter to the left side, the distal part inevitably is very the vascularity is not great. So when you do a spatulation, almost bringing to the level of the mesentery, you have a wide length to anastomose. So what I start to do is that I have about 6 or 7 suture points in the one wall and the other wall. The advantage of this technique is that you have a wider anastomotic line, thereby reducing the stricture rate. Normal stricture rate of ureteroileal anastomosis is supposed to be 7%. So far, I have had 1 stricture in the left side, none on the right side. So
But,
that the stricture.
by opening 1.5 times of the lumen, you will not get any advantage of the luminal. Any lumen more than opened 1.5 physically, physics point of view, will not give any advantage. If at all schema is the concern, you can cut it off a little bit distal and see the bleeding and then do anastomosis. I mean, what I mean, by opening a large surface anastomosis, can we counter the effect of the ischemia?
I believe that by having the distal most or proximal most point of the cut quite close to the mesocolon, the amount of ischemia where the lumen comes will be low. So this is what I do, and I appreciate that, you know, having a logger anastomosis for me is more comfortable. So that the part that almost I cut off almost 3 to 5 centimeters of the distal ureter off, and the anastomosis comes very proximal. And in the handling, the distal part is where you hold and suture and whatever. So the point where you're handling is cut off and almost a pristine point is given for anastomosis. The second advantage is that you are not having 3 suture lines. In the classical Bricker, you have the intestinal closure point, the right ileal point and the left ileal point. Whereas in modified Bricker, you have only 2 suture lines, the left and the right, that's all. These are the advantages. And the stricture rates, as I said.
Do you think that we have to always exercise the staple line, or can we keep it there? Because I have seen a lot of people keeping the staple line. I'll just
Gilles, do we put a staple in the bladder? We don't.
No.
Why are we not?
That
Why
is
are we
why
not doing it?
never we had done. But thing is, in the robotic era, we see that a lot of people, including I have kept the staples recently, because that was not my habit earlier. So any comment from Dr. Hosseini or Yuvraj also on
one
that?
of the seniors can
keep
comment on that. I find it
inside?
very bit uncomfortable. That's my point.
Yeah,
of
I'm
course,
also
failures can come
uncomfortable,
in
but
that.
I'm keeping it now because others are keeping it. So, Dr. Hussaini, what is your comment on that? Manoharan, he was excising.
And correct, did I understand correct? You mean a staple in neobladder?
Staple, no, whatever be conduit or neobladder, can we have the staple line there, or you think that it has to be excised? Because since you are doing a valise, that is fine. But in Bricker, majority keeps the staple line there.
Yeah, I personally don't do. I take out the staple row out, but I saw some surgeons keep half of a staple row and minimize the opening of the anastomosis to the ureter. If you have a wide ileum, when you put a staple and have a wide ileum, and this wide ileum should be anastomosis to the small opening of the ureter, maybe you need to keep some staple row intact. So, but I take out all staple row, yes.
So there were some questions for you, sir. One is about renal function, GFR. Are you insisting that 60 should be the cutoff, or in some other papers, it is mentioned that up to 45 we can do a neobladder, GFR up to 45. What are you insisting that it should be above 60?
Yes, yes, I do, because with orthotopic neobladder in long period, you have a more effect in renal function compared to Bricker conduit. So I try to keep a 60 millimeter ES per minute as a standard, at least.
Next question, Dr. Yuvraj. Yuvraj, are you here?
I think you can ask other
Dr.
speaker.
Hussain, what is the technical difficulties after chemotherapy and radiation?
Gunil, can I make a comment?
Yes, sir.
Yeah, so there are two reasons. One question regarding the stapler, because see, the reason is staplers, the biggest problem is a stone formation. So it all depends if your patient is going to live 5 years, 10 years, and these people, they can form the stone. In ileal conduit, what you can do, even you can divide with the stapler, but you can just throw another line of suture just above the staple line, whether you can use a 3-0 vicryl or something like that. So that's what we do. And it's not necessary to excise the staple line. But as Ravi Mohan was pointing out, very good point. What is the advantage of Bricker versus Wallace technique? So if you are doing a Wallace technique, then you got to excise the staple line and you anastomose both the ureter to the butt end of the ileal conduit. So in those cases, you need to excise the stapler line. And I think, Wallace technique is more being done in Europe in comparison to the North America, and I also see in India. But basically, the advantage of the Wallace technique, if you look into there's no randomized control trial, but there is a comparative trial, and we have also published data from IRCC about 2,000 cases. There's a Wallace even turned out to be less stricture rate in comparison to the Bricker's technique. The proponent of the Bricker's technique, what they say, if you are doing a Bricker's technique, so both ureter are separate. So if some guy is going to develop a cancer at the lower end of the ureter, you can excise only one nephroureteral unit. You need not to, take care of both the units. So that is the advantage of doing that. Now, the cause of the stricture is not because of the length of the anastomosis. I feel it is all technical. So you ought to be extremely careful. You should maintain a good blood supply to that area. And we are also using indocyanine green to make sure there is a great blood supply to, and there is a paper published from USC. They found reported literature is almost 0% after using indocyanine green. But beside that, I mean, it's a technical problems are there. I mean, like if you have twisted the anastomosis, if suture is not good, if your mucosa is everting and there is a urine leak, all these things, they lead to the stricture formation. It's a very humbling operation, and you ought to be very, very careful what you are doing. Thank you.
Thank you very much, Dr. Janil. I think we need to finish this session now. And I want to thank all the speakers, Dr. Yuvraja, Dr. Hosseini, Dr. Manoharan, and Dr. Raghavan for excellent presentations. And all the chairperson, Dr. Hemant, Dr. Janil, Dr. V. Chandramohan for excellent moderation of this session. Now we go to the next very important session, the robotic reconstruction surgery session, and I invite the chairpersons for this session, Dr. Sanjay Kulkarni, Dr. Amlesh Seth, and Dr. Ravi Mohan. And our two giant stalwarts from US already have joined, Dr. Raju Thomas and Dr. Gopal Badlani. So over to Dr. Sanjay Kulkarni and Dr. Amlesh Seth, sir, for taking on the next session. And please invite the next speaker.
Thank you, Anup. So I welcome my two guests. First lecture will be by Dr. Raju Thomas, who is professor and chairman Department of Urology in New Orleans, and he is the president-elect of AUA. So we hope to see him as the president next year in his hometown. Raju is going to talk about ureterochalicostomy and robotic pyeloplasty. Raju Thomas, please.
You got my slides, right? It is indeed my privilege to be presenting the technique of robotic ureterochalicostomy. The robotic reconstruction has been gaining steam since 2002. Started with pyeloplasty, and now we do much more complex things like pyeloplasty, as well as the Boari flaps, reimplants, and so forth. The technique is based on the location. And if you have a upper urethral stricture which is long, then the options are primary versus secondary. Ureterostomy, ureterochalicostomy, buccal mucosal interposition for a ureteroplasty, as well as bowel segments. The secondary strictures form and options are using bowel, autotransplantation, etc. The indication again is usually because you have a stricture segment that is too large in length, and therefore these patients are prone to have a tight anastomosis, and we need to save the kidney. So here you have a stricture which is long. And the question is, can we bring this kidney down with a nephropexy and then do end-to-end, or do we find a position so we can hook it up in the lower pole calyx by tilting the kidney? So the treatment option again is ureterochalicostomy, especially if the kidney is in intrarenal pelvis, and so on and so forth. This is our port placements that we do with the Da Vinci Xi, usually forearms across. This is the pivotal area that we're dealing with, and this is the bedside surgeon's port. I normally place a 5 French open-ended catheter into the ureter just prior to putting the trocars. This is because we can use indocyanine green into the catheter, so we can go right, save time, and find the ureter. This technique can also help us place a retrograde placed stent. Okay, so this is how indocyanine green, which is relatively very inexpensive, can be injected to find the ureter using the firefly technique. And here you can see the normal ureter, and you can see the stricture being highlighted with the indocyanine green. The Foley catheter is placed for 3 to 4 days, and also we have a closed suction system in place. So you've all seen this illustration in the literature, whereby it is recommended to do a lower pole excision of the parenchyma. Very often you don't take much parenchyma because there is hydrochalicosis in the lower calyx. And then what I recommend is that you suture the internal mucosa to the capsule in several places, so that will tamp out any bleeding, and then you do the ureterochalicostomy. The nephropexy downwards can gain you a few centimeters, as seen by the pre and post-op films. For this, you have to free up the entire kidney so that it is mobilized and hangs by the hilum. Sutures that I use are 2-0 or 0 polyglactin on a CT1 needle. You have to take the capsule, not the perinephric fat, and then you pex it by attaching it to the side wall and the psoas muscle in about 3 to 4 places. This way, what happens is you are able to tack it down in a lower position so that you can get less of a distance when you're doing management of these strictures. So as you can see, a nephrostomy tube is in place for this particular patient, and therefore we are able to connect the upper ureter to the calyx here. How do we do that? Initially, of course, you find the ureter, and we have a 5 French catheter in there, spatulate it without manipulating the mucus, the mucosa of the ureter. This is then brought up to the lower calyx. Ultrasound is performed, and then we excise a small segment of the lower calyx period. With the robot, of course, it's easy to clamp the artery so that we get a few minutes of ischemia, keep it as minimum as possible. Once the lower pole segment of the kidney is removed, we find the mucosa, and once you open the mucosa, you can see the ureter getting closer. The mucosa is identified, cautery is used, but I like to suture the mucosa to the capsule, and that will actually go ahead and tamponade any bleeding there can be. So once that is done, then we start the anastomosis. So the posterior layer of the ureterocalycostomy is done, and you can use any suture you want to. 3O polygalactin is fine. And now you can see how the anastomosis is being done. And you can see that in this kidney, we've already closed the gap. The tamponading sutures are in place. And once the posterior anastomosis is completed, this, of course, is a barb suture that is being used. And then, because we have a retrograde 5 French catheter, we pass a guide wire and the stent is in place. And then we close the anterior wall of the anastomosis. This is a still picture showing how we take a suture from the mucosa to the capsule, and that will tamponade it. In this segment, the same thing. We mark out the lower pole segment. We clamp the artery. And once that is done, the lower pole is excised. And the electrocautery can control any slight oozing there might be. Once again, the lower pole calyx is entered, and this is followed by anastomosis of the capsule to the mucosa so that you can tamponade the parenchyma. The ischemia is kept to a minimum as much as you can. Usually it runs about 5 to 6 minutes. Of course, you've got to have everything ready for that procedure. And then, of course, once a posterior wall is done, you can also pass the stent in an antegrade fashion with a needle in the anterior abdominal wall. We remove the stent in about 6 weeks, and we then get follow-up imaging in about 6 further weeks to make sure that it is all healed up nicely. There is ample literature that shows that this is very much possible, duplicable. This is one of our colleagues from India who wrote that up. In conclusion, even though it's an advanced surgical procedure, and if the surgeon is facile in the robotic techniques, ureterocalycostomy is very much easily duplicable and can be taught. Thank you from New Orleans. We welcome you to the AUA, which is in New Orleans next year in 2022, when I will be the president of the AUA. God willing. Once again, thank you, greetings, and much success.
Thank you, Dr. Raju Thomas. May I request Dr. Amlesh Sheth to introduce the next speaker, Gopal? Amlesh?
Before that, I obviously it would be my pleasure to introduce Professor Gopal Badlani. I just wanted to ask Professor Raju Thomas a question, because ureterocalicostomy would normally be required in a situation of secondary PUJ obstruction where one pyeloplasty has failed. And in that situation, if it is possible to do a redo pyeloplasty, then would you prefer to do that going into the scarred area, trying to dissect in the hilum, or would you prefer to do a ureterocalicostomy straight away? Or how do you decide between the two? How do you decide between a redo pyeloplasty and a ureterocalicostomy?
Thank you for that question. I appreciate that. Hopefully you can hear me. Number one, if there is a recurrence, which does happen, between 5 to 6% will recur when I look at my large series. And we published our secondary pyeloplasty robotically in the British Journal of Urology International several years ago. My first algorithm is, if it's a very short stricture, 2, 3, 4 millimeters, then I do a ureteroscopic endopylotomy. That usually, and a balloon dilation will pretty much cover most of that. The next algorithm is when the stricture is longer, then what do you do? 1 centimeter, 2 centimeters, then I go back again with the robot and I free up the kidney and do a secondary pyeloplasty end to end by freeing up the kidney, a little nephropexy. It's a little bit more scarred at that time, but we can still do it, no question about it. So I do every effort to re-anastomose the ureter to the renal pelvis, whether if it's really dilated, I can do a flap, etc. So I can manipulate that. The rare instance, and I use the word rare instance of ureterocalicostomy, is only if the stricture length is really long, and then it's going to be a lot of tension when I anastomose. So I totally agree. I think a secondary pyeloplasty is something I would highly recommend. It will take much longer than your primary pyeloplasty, but I think it's still worth it to save that kidney.
Thank you, sir. Now it's my pleasure to introduce Professor Gopal Badlani. Although everyone knows Professor Gopal Badlani, he has been a speaker for practically so many conferences that I'm sure it would be very difficult to find a person who doesn't know Professor Gopal Badlani. Anyway, because it is customary, he is Professor of Urology at Wake Forest University. And before this, he was at Long Island Jewish Medical Center for a very long time. He has been president of almost all the societies of, he has been very active in Endourology Society and in American Urology Association and in New York chapter before he was at the helm of affairs in the AUA. He was very active in the New York chapter. And last year, it was my pleasure to welcome him to All India Institute to deliver a very prestigious Professor Sarinder Mansingh oration. And this time, it's again my privilege to welcome Professor Gopal Badlani for this World Robotic Urology Symposium.
Thank you very much. I hope you can hear me well and see my slides. The operative word in my introduction was has been. That is my claim to fame now. And thank you so much for inviting me to this meeting. For a non-robotic surgeon, my role comes only after you guys are done, some time to regenerate and or improve situation for the quality of life for some patients. It still remains a futuristic endeavor in terms of what we are planning to do. So the cell therapy is not a new concept. It is a process of introducing new cells into the tissue in order to treat a disease. And there may be many different forms of cell therapy. Xenotransplantation of non-human cells is used to produce needed substance. An example is a diabetic patient where insulin-producing cells are brought from another species and injected into the muscle. Stem cells is the ubiquitous word used, autologous from the patient or allogenic from another donor. But we have realized that more than stem cell, it's the precursor cell which are formed in the organ that you want to enhance is a better form of cells. So mesenchymal stem cells are proposed largely as a cell-based therapy due to their plasticity. They're able to be isolated from a tissue biopsy, and then you can grow them ex vivo in expansion and then apply them. The concept, the central concept in regenerative therapy is that you're replacing fibrosis with tissue-specific cells. The mechanism of how this happens, whether you put it on a construct and or direct cell injection, remains somewhat controversial. Most of our work has been construct-based in the bladder, and then in the outlet is been cell-based. But you can see the plasticity of mesenchymal stem cells in each of these systems. Basically, a lot of the orthopedic use in terms of chondrocyte, tissue regeneration in knee as well as in the shoulder has been popularized now in terms of collagen replacement or cartilage replacement. Certainly, skin is the highest use of this sort of work, but the easiest grafting technique was adipose tissue cells, and to conform them into the local tissue has been a technique. You can get paid for liposuction, and then you get paid for injection also. Unfortunately, this hasn't borne out to be successful technique as yet clinically. Most of our work in the incontinence world has been in the muscle precursor cells. They have the ability to form new myotubes, long-term survival. This has been shown, formation of motor units. Most importantly, you get growth arrest after maturation, not unchecked growth, which has a malignant potential, which is present in stem cells. The concept is your host site is urethra. You can bring the cells by isolated from the biopsy, and then you locally attract mesenchymal stem cells from the host. You can put it directly as cells or a scaffold plus cells, or now more recently injecting a secretome. It's not a secret, but it's called secretome from the tissue generated host. This is conceptually looking at, it's customary to show a video in a robotic, and that's why I'm showing you this. But in general, you're injecting biomaterial. This was collagen injection. It was a great concept from Dr. McGuire's work, and you can see the bubble forming to co-opt the urethra. Unfortunately, didn't last very long. As such, you had to go to other aspects. In terms of muscle or cells, you can see how far back we have been trying. This publication is in 2001. So the study was done prior to that using chondrocyte. This is about the only material I know a single injection had a fairly long response. Unfortunately, this company went out of business and we are not able to continue this process. Cell choices are many. The adipose tissue has been used by the USC group. We and Pittsburgh and Beaumont now use muscle progenitor cells. And there are a group from UCSF that work on bone marrow cells. The concept of acute versus chronic injury is very, very important. And today the debate is, should you pursue the cell therapy or go towards a chemokine-based regeneration? Animal modeling is important because that's the easiest ways to prove a point. However, they don't replicate a patient defect, particularly the collagen-based defect, which has been identified in stress incontinence, etc. So we have looked at the small animal, the large animal, and so on and so forth. So start with the rat model in terms of testing the concept of sphincter injury and then creating a repair to see how well it works. You have certain markers to look at the development of the muscle cells, and be able to inject that. We go to a canine model, which has a much longer urethra. So you take a 2 centimeter segment, you take away the muscle, create a defect, and then re-inject the cells. About a decade ago, we developed this female non-human primate model because it actually simulates a female patient. You can create an acute injury, a chronic injury, and all the aspects similar to the birthing, etc., can be replicated. The only change is the monkey doesn't have symptoms. It doesn't complain about particular symptoms. Everything is objective visual assessment. So you can characterize this anatomically between the human urethra and the primate urethra to show that the distal urethra is different. However, the proximal and the middle urethra is about the same. You can functionally study to measure pressure in proximal and middle urethra that is the same, and then create a denervation model for incontinence to produce a injury that's reproducible while keeping the bladder nerves intact. And once the incontinence is created, you can study this radiographically. So you have pre-injury, then you have post-injury. You can see the dilation of the urethra. If you create a sling or a treatment here, the bladder neck, then you can see the difference in the assessment. So once this is done, you can measure the muscle versus the scar content, which is the control. At 3 months, you have more scar. 6 months, you have more scar, and then you inject something, and that will improve the muscle therapy. So you see the improvement after injury. This is the untreated animal after injury. This is after treatment. So the pressure in the urethra is improving.
Injury. The kidneys, of course, are at the back in a retroperitoneal location, so it seemed logical to go through the back of the patient.
I'm listening to some echo or noise. Sorry. In terms of the non-human primates, we have ISD as well as the chronic injury model. And basically, it's in the chronic injury that we're able to show that the cell therapy is not as effective. In the cell therapy, what's the observation is the response is poorer in older monkeys, in heavier monkeys, and in chronic injury. This actually is our new study now, comparing the older monkeys to nulliparous new monkeys to see where the defect lies. And that's a study just about to be presented at the AUA. Unfortunately, we will not be doing that, at least in live situation. So most animals today with the muscle cell injection are young animals shortly after creating SD. And that's why this has become an important feature, because the patients, when they present, have a chronic injury. The injury occurred a long time ago. So the next approach has become the non-cellular approach, targeting using growth factors, cytokines, or chemokines. And this is our chosen regenerative molecule, the CXCL. This is produced at the time of injury. It's measurable in the tissue at the time of injury, and that's how you create. This is what the molecule looks like and how it works through the improving the proliferation and causing chemotaxis for the adjacent cells and from the bone marrow to come there to repair the injury. Simple diagrammatic concept to show you that CXCL then looks at bone marrow and adjacent tissue is attracting the cells to the site of injury. Now, you can prove this by creating an acute model of injury and a chronic model of injury. A chronic model of injury is a monkey that has had urethral denervation and preserved for almost 6 months, which is a prohibitively expensive process, and then treat them. And then you can see that the cell therapy response is here, and the chemotherapy, the CXCL response is here, which is very close to a normal response, the uninjured monkey, basically. So this was a very successful process. Again, the tissue markers to show that the CXCL works well. What's most important today is to look at male incontinence, which is perhaps more pertinent to your conference today. Most of you experts never have the incontinence post-radical prostatectomy, but I do get patients that need this treatment. And cell therapy has been tested by a group that looks at, we created, thanks to Dr. Himal, a primate post-prostatectomy model, and to create a deliberate incontinent model by doing the radical prostatectomy. So again, the concept is first to study the animal and look what's the similarity and dissimilarity. So when we look at it, you create the radical prostatectomy. Of course, this is done in an open fashion. And you can see the prostate specimen with the seminal vesicle. The seminal vesicles are much larger in a monkey than they are in a human. Otherwise, the neurovascular bundle and the surrounding tissue, et cetera, is very, very similar to the male patient. We can then measure the baseline capacity, look at 3 months, so the bladder capacity remains the same, compliance remains the same, there is no detrusor overactivity, but the leak point pressure drops significantly after 3 months. So the leak point pressure is 80 plus prior to the surgery, 80, 18 or so, much less, and 6 months even worse. And that's when we start injecting. We have some pilot data. We also obviously simultaneously looked at sexual behavior in the monkeys. You look at mounting behavior and look at the ability to have the erection and have the corporal pressure measurement. So this is what we've done, is to measure the corporal pressures, both pre-papaverine and post-papaverine, to study the effect of neural injury on the corpora. You can do this micro-CT studies to look at the anastomosis, look at the healing, and then have the necropsy specimen at 3 and 6 months to look at the scar formation. It's actually a very good work from a group in San Diego to show that the healing occurs in a disorganized fashion, and the collagen and the muscle fibers are disorganized, and that's why they're less functional in terms of sphincter mechanism. So a novel energy approach has been the shockwave treatment by Tom Liu to treat with progenitor cells activation, and this has been a concept to apply again an injury by shockwave, thus bringing cells to the. This is a corporal ED model that he treated to bring more cells, and you can see without and with the injury, you have much different approach to the thing. So conceptually, the sphincter repair could be done with an injection of a CXCL if and when the incontinence is established. Our newest endeavor is to look at a kidney injury model. This is a ischemic injury, perfusion or reperfusion. As you're doing more and more partial nephrectomies, we are conceptualizing that there will be injury, although the claim is up to 30 minutes, nothing happens. This is an animal model, and what we are trying to do, this is a prevalent condition in cats. So we've used the cat model for this and be able to create injury, chronic injury, then treatment, measure them 1 to 3 months after that. In the lab, we were able to do the injury and study single kidney out of the 2. And then in a clinical environment, we were able to study cats who have elevated creatinine and inject them. So that's just our current project in terms of trying to show that this is a control without injury. This is post-injury, so you can see more scar tissue formation. And then low-dose CXCL, mid-dose CXCL, and high-dose CXCL to see the recovery. So here to here, you'll see that there's much less scar and there's a lot more scar here. So that's currently the ongoing project in terms of showing the repair. We're able to study directly the scar tissue. This is a CT fire stain to identify the collagen muscle, the collagen fiber, and then we're able to study the fibers individually to learn more about the fibrosis. So I thank you very much for keeping me in the loop and allowing me to share our work with you. It remains a very exciting project to be able to carry on different genitourinary organs. There are lots of futuristic trials possible with regenerative therapy model. Thank you very much.
Professor Badlani, you said that the CXCL injection that you are making is for the kidney. Is it with the nephrons, with the cells, or it is just the CXCL injection? And similarly for the urethra, is it only CXCL or the isolated myocytes are also injected?
So we compare one group of cellular therapy with the sphincter and compared to the CXCL alone. We have not combined the CXCL with cells because we believe the CXCL has the ability to attract the progenitor cells from the mesenchyme as well as bone marrow. And we have labeled bone marrow cells and been able to show that after CXCL injection, the cells get attracted to the site of injury.
And you said in the post-radical prostatectomy model, it's a neural injury, but how do you kind of establish how much is neural damage and how much is muscle damage, and how can these two different situations be addressed?
So the neural injury can be best measured in the ED aspect of it, because that's where we're able to see response to field stimulation and or to injectable therapy. In the incontinence, it is postulated, but not exactly confirmed. You can have both muscular injury as well as neural injury. As you clinically know, most patients who have incontinence will almost definitely have ED also. Whereas the reverse, patients having only ED may not have incontinence. So, but every incontinent patient is almost always has erectile dysfunction. So we believe there is a role for neural injury in the incontinence also.
So the reason why I'm asking this question is because in robotic radical prostatectomy, sometimes we do nerve sparing and sometimes we do nerve excising radical prostatectomy. Those who have a lot of periprostatic extension or involvement of the neurovascular bundle, where we deliberately excise the neurovascular bundle. But even in these patients where the neurovascular bundle is deliberately excised, if the urethra is spared and the muscle is spared, then these patients do not become incontinent.
So, the nerves you're sparing is a parasympathetic nerve going to the corporal bodies. The nerve that's controlling the external sphincter zone is mostly pudendal that lies on the pelvic floor. So rarely is that nerve injured directly to the external sphincter mechanism. It's the urethral coaptation that is more subject to sympathetic and parasympathetic. So depending on how much retroprostatic or presacral dissection you do, that's what the injury occurs. I don't think it's right next to the capsule nerve that is sphincteric in nature.
So you think maybe there are lots of nerves which get injured, say while during lymph node dissection, as well as periprostatic dissection, which leads to incontinence or erectile dysfunction?
So I think, it's not commonly known that if you study the bladder, about a third of the patients post-radical prostatectomy have, hypocontractility. So you're denervating retrotrigonally something during that process. It is also, well established that presacral injury occurs those who do extensive node dissection, particularly for bladder and or people who believe in wider dissection of nodes for prostate. So I think sympathetic nerves certainly are in the presacral area. Typically, your radical prostate dissection is not going there. But the periprostatic nerve, whether it's getting injured and affects the sphincter, is less well established. Just thought about is just due to the dual nature of the injury, the ED and the incontinence.
Thank you, sir.
Gopal?
Yes, sir.
You turned a very complex subject into a very simple one. Because of your fantastic explanation, I'm really surprised and I'm very happy. The explanations were very good. So Anthony Atala in his unit were doing a lot of work on stricture urethra. What's the current situation now? Is there so Guido Barbagli from Italy has taken some piece inside the cheek, he sends it to a lab, and then he puts in a substrate and he does an asopa dorsal inlay for longer strictures. Is there some kind of work going on in your lab now on urethral stricture?
Yeah, so Ryan Terlecki is leading that project. As you know, they have published a group of patients that they did in Mexico for anti-urethral stricture. The off-the-shelf urethra remains a desired concept, whether it's plate versus a whole urethra. I think conceptually, plate makes very little clinical impact because of the buccal mucosa being so readily available. It's the longer tubular urethra that you could use even in experts like you, if that was available off the shelf and could be successfully put in, would be a help. So I think that's where the length comes into play. The 1 to 2 centimeter is possible. Beyond that, it's become, in general, all tissue principles of tissue growth. We see that in the bladder, etc. Vascular supply doesn't reach from the sides. Urethra is unique that if you're able to supply the length of the urethra circumferentially from, say, corporal or other spongiosal tissue, then this may be possible. I know they are working on it. I'm not part of that, design, but Ryan is, and I know it's active.
Are there any tissue engineering techniques that you use currently in your practice?
Well, we are doing muscle, instead of cells, we are doing, basically think of as chopped up muscle. So we take the biopsy, we treat it in the OR and re-inject it. So you're injecting fibers rather than cells to, lessen the time, because the cells have to form myotubes. And that's the current clinical trial that we are doing, is to inject muscle fibers. There is some, GYN-related vaginal reconstruction, that's currently. So the latest project is focused on is 2 things: underactive bladder and kidney. Those are our 2 main, at least my projects.
Thank you, Gopal.
These muscles are, say, from the thigh muscle, say, the quadriceps or something?
Yes, we take from the thigh, about a centimeter and a half or 2 centimeter muscle. So a cube is then processed in the OR, and you get it in a liquid suspension form, and you inject it. So within the hour after taking the biopsy, we inject in the urethra.
Dr. Ravi Mohan wanted to ask a question to Dr. Raju Thomas.
Yeah, so Dr. Thomas, the excellent demonstration. My question was, the stricture which you showed in your case was about, let's say, 2.5 centimeters. And once you spatulate the ureter and you would have done excision of lower pole of the kidney, obviously the stricture length would increase. And I was expecting it would be difficult to bring in both the ends with respect to tension. Considering that there is no haptic feedback in robotic, so how would you balance that part of having the traction on the anastomosis? Do you actually do a ICG at the end of anastomosis to confirm that things are all right? Because that first surgery is the best surgery, as we all know. So you have to unmute yourself.
Thank you. So first of all, these are difficult cases because they are not primary. They're usually secondary.
Yes.
So first of all, you're starting off with a little negative oomph to begin with. So once you realize that, then you get a consent for multiple things, including a nephropexy. So you get some more additional length. So don't forget the 3 principles of reconstruction. Doesn't matter if it's open laparoscopic robotics, is number 1, good blood supply. Number 2, no tension. And number 3, adequate stenting and drainage. If you don't have these 3, then you're not going to succeed. So certainly you don't get haptic feedback on the amount of tension that you do. If I use intraluminal ICG, then there's no point giving IV because it's spilled all over. So how do I know about that? Some of it is, of course, being doing this for a long time, I can kind of judge the amount of tension that is generated. So you just have to get your experience in making sure that the cut ends are adequately vascularized, number 1. Number 2, there is no tension. And you can feel it, you can see the way it is sitting together. It has to be adequately tension-free. Otherwise, do a little bit more of the lower downward nephropexy or do a little more urethrolysis. The urethrolysis, you got to be a little more careful so you don't interrupt much of the blood supply coming from the distal to the proximal. So it's a fine balance when you look at the reconstruction. I think the tissue planes that you see with the 3D robot is so superior. Now you might say, I was an open surgeon to begin with, but I think you can see it so much better in terms of the blood supply, the microvasculature, and even the tension, that I think once you get the balance of moving the kidney down or not, or ureterochelicostomy or not, number 1, I agree that the first attempt is the best. And then if you got to go back another time, you're going to have a problem. So the first time, take your time. Don't be in a rush. Oh my God, I got 3 more cases after this. No. You need to make sure you plan it because that patient is depending on you.
Thank you. Thank you, sir.
Dr. Thomas, what is the suture material of choice for pyeloplasty in an adult? And do you use a barbed wire or monofilament sutures?
So increasingly, when you go to the conferences, people are using the barb sutures, including ureteroileal. I try not to do that. I'm still monofilament, monocryl, 4050, or if in a given situation not available, then I would use like a 50 Vicryl. Those are the 2 sutures that I prefer.
Thank you.
Okay, Dr. Thomas, sir, there's one question
Dr.
directed to
Gopal.
Dr. Raju Thomas. Yeah, there's one question directed to Dr. Raju Thomas and one question directed to Dr. Gopal Badlani. So I just want to ask them. So Dr. Thomas, sir, the question asked by the audience is, any role of ICG in your practice during robotic ureterochelicostomy to identify the ischemia part of the ureter? Do you use ICG? That is number 1 question.
I use very frequently. So the intraluminal use is important because you're going into a secondary area where there's a lot of scar tissue. So I use a 5 French open-ended catheter in the ureter so I can identify it without wasting too much time. But once you use it intraluminal, and when you transect it, it's all over the place. So then the IV is not possible. If you want to check for the vascular supply, you got to do not use an intraluminal use. Wait till you have transected. Wait until you are ready to continue after excising all the scar tissue. Then inject the ICG, which will then show the blood supply. Do I do it? Yes. As and when needed. But I use more intraluminal because sometimes when you are going, patient is obese, it's between all the fat, close to the vena cava, close to the aorta, then you need to get that planed quickly without wasting your time. So I do it more intraluminal. I know it is off-label in the US for the FDA, but I tell the patient, and I just use it.
Thank you, sir. And one question directed to Dr. Gopal Badlani, sir. During the radical prostatectomy, there have been some studies going on. Human chorionic embryon grafts have been placed around the endovascular bundles for their regeneration. So are you also contemplating something which we can use during the surgery, which can help in the regeneration of the nerves and can actually improve the erectile function of the patient after surgery?
So we've conceptually thought about the injection of regenerative material at the time of surgery, but currently it's only an experimental monkey model that we are trying to establish the problem before we treat it, rather than prevention, as the nerve graft people have tried, starting from sural nerve to this current amniotic membrane, etc. All of these, that is the expertise of people like Vip Patel and others who are on this program can tell you more about it. But we are still in the established injury model, not in the prevention.
Thank you. Dr. Ravi was saying something. Yeah, yes, sir. Go ahead, Dr. Thomas. Yes.
Ask Gopal a quick question. Gopal, you had a very interesting observation, which we have seen, is that a patient who's incontinent after the radical prostatectomy almost always has ED. Again, research on that. How much of that is psychosocial or psychological? Because, oh my God, I'm leaking, whether it is a little or a lot, and that is psychologically causing my ED, or is it more anatomic, physiological? Has there been research on that, Gopal?
So yes, you would obviously, unless you're into golden showers, you would not want to have sex when you're leaking, and that curtails desire. But in general, you should see some spontaneous erectile activity as a night's sleep, et cetera, et cetera. These patients who are significantly leaking almost always have no erections at all. I mean, they won't respond to Viagra, they will only respond to injection therapy, which indirectly proves a neural rather than vascular injury. And then a portion of them will have no response to injection also, because not only are you hurting the nerves, you're also hurting the vascular supply as well. So I believe the injury is wider in those who have combined incontinence and erectile difficulty. Incontinence alone, you can conceptualize fibrosis at the anastomotic site and lack of coaptation, et cetera, being the cause. And obstruction relating to bladder overactivity is another cause. So you have anastomotic stricture and then you have overactivity. But in general, it's more sphincter incontinence than bladder incontinence in the radical prostatectomy. ED is almost always, whether it's vascular, you take a diabetic and a hypertensive patient and you do a radical prostatectomy, you're going to get a much higher injury rate in that. It's not direct injury, but now you've compromised even more a situation that they were already less than ideal.
Thanks, Gopal.
Yeah, Dr. Ravi, you wanted to make one comment? You can make comment, then we can wind this up the session.
Yeah, my question was already addressed. I was asking about amniotic membrane. Thank you, Dr. Badlani, for that, taking us through an exciting journey. My comment is, when do you expect that we are going to have any human use? Are we expecting somewhere there, or are we still far away from that?
So like I showed you, it's been a 20+ year journey.
Yes.
So it remains a hope that, we'll gain something out of it. I can't promise you.
Thank you, sir. Thank you.
Okay, so thank you very much. I think we are right on time. I want to thank our esteemed speakers, Dr. Raju Thomas sir and Dr. Gopal Badlani sir. It's very early morning there in the US, and we are really grateful to both of them. They have joined us in the early morning hours. Thank you very much, both of you, sir. And of course, excellent presentation by both of them, as always. And our chairperson, Dr. Amlesh Seth, Dr. Sanjay Kulkarni, Dr. Ravi Mohan, for excellent discussion. Currently, we are being watched by more than 2,100 urologists from 20 different countries, and that speaks about the volume of the interest people are having because of you all guys, the wonderful people. So now we move to the next very important session, and that is the robotic radical nephrectomy and partial nephrectomy. And I invite the esteemed chairpersons for this session, Dr. Mahesh Desai, Dr. Jagdish Kulkarni, Dr. R. Sabnis, to please take over the session.
Thank you, Anup. And it has been wonderful program so far. And the last Raju Thomas and Gopal Badlani was a treat to listen to them. And now, of course, we are coming to the exciting subject, because where the robot is used the maximum now, and the partial nephrectomy is going up and up. And I have with me Jagdish Kulkarni, Sabnis, and Gagan Gautam to chair the session. And I would like to invite now, without wasting time, Dr. Anand Shivaraman for the first talk by step-by-step approach to robotic partial nephrectomy. Anand?
Yes, sir. Good evening.
Good evening.
Let me just share my screen and we're on.
Nice to see you. Good.
You too, sir. Used to. Right, there you go. Am I audible?
Yeah, yeah.
Yes. So good evening, one and all. And thank you, Dr. Anup and Dr. Patel for this opportunity. And thank you for doing this program for India. So hope we all benefit from this. And I'm quite certain we will. So my talk today is going to be step-by-step approach for robotic partial nephrectomy. I've been given 10 minutes and I'm going to quickly go through the steps. So preoperative preparation, number one, this is key. Renal angiogram, I think, is mandatory along with reconstructed images. You need to know exactly where the tumor is, what the nephrometry score is, how close to the collecting system is, and is it going to be easy to reconstruct if it's close to the vein. So I would withhold anticoagulants, routine bloods, bowel prep. I don't do a bowel prep. It's only clear liquids on the day before surgery and nil by mouth from midnight. So instrumentation, I use 2 robotic instruments, 3 robotic ports. The assistant handles 2 ports. We only use hot shears and a robotic bipolar and needle driver for rhinography. I've given up using the ProGrasp. Ideal to have Scanlon clips, but you can manage with bulldogs, and I would prefer 2 suctions, preferably the trumpet kind. So applied anatomy, ports placement, and how it varies based on tumor location. For lower pole tumors, the camera probably has to face halfway between the hilum and the tumor. And when you're dealing with posterior tumors, I would place the camera exactly the same way for a lower pole tumor, primarily because when you flip the kidney, you're going to need more space. So for that, the camera needs to be slightly lower down so that when the kidney falls over, it doesn't hit your camera. So again, stent, ureteric catheter, I'm a bit partial to stenting if it's going to be breaching the collecting system, but I see a lot of people have moved away from stents and ureteric catheters. Port placement, it's different for SI and the XI. For XI, it's 4 robotic ports are nearly linearly along the lateral border of the rectum, 6 centimeters apart. But SI, I use the SI system. And it's robotic. The camera port goes above the umbilicus at the lateral part of the rectus, and then we have to have enough space between robotics ports 1 and 2 for the assistant port. I hope you're able to see the diagram, and a subxiphoid 5mm port for the liver retraction on the right side. So the first step is always bowel mobilization, and both left and right, same thing happens. The dissection is in the avascular plane between the geratas and the posterior mesocolon. And if this step is done very well, it kind of makes the surgery relatively easier. So we need to get to the avascular plane. How much to dissect for the bowel? I usually dissect from the splenic to the pelvic brim. And how much to dissect depends on where exactly the tumor is and the position of the tumor. And it's always better to mobilize more than less of the bowel. The next is hilar dissection and medial reflection of the mesentery under urethra and gonadal vein identification. That's step 1. The kidney is dissected, and how much at least. So, or 2 Scanlon clamps. So that is the length of the artery that you should have while you're doing the hilar dissection. And number 2 is you also need to dissect the vein. Whether you clamp the vein or not is secondary, but you will dissect the vein so that if need be, you will end up clamping it, right? So tumor identification, the geratas is incised to expose the tumor. I don't completely excise the geratas fascia, but it's pushed over and above the tumor, and only a little bit of the geratas on top of the tumor is left behind with the tumor. And the reason is when you finish your dissection and the rhinorrhaphy is done, you would want the geratus to be closed on top of the kidney so that, God forbid, if you need to go back in to dissect another tumor further down the line, then it looks pristine. And also, when you're doing follow-up scans, if the geratus is on top of the kidney, it's a lot better for the radiologist to pick up any problems. So the margins are marked with cautery, and I use two companies that do intraoperative ultrasound, BK and Hitachi Aloka. Both are pretty good. So I'll quickly go on to some steps in the partial nephrectomy. This is what I was meaning by not taking out geratus, just dissect it and move it out of the way. Number two is ultrasound is mandatory for most cases. You need to be doing an ultrasound. And only if you do it for cases, even easy cases that are exophytic, you breach the learning curve of using the ultrasound. So I would suggest use intraoperative ultrasound for all cases, right? So quickly go on to clamping of the renal hilum. And this is what I was saying. If you have scanlons, is well and good. If not, just enough space for 2 bulldogs, and then go on. I don't prefer a Setinsky mask clamp, primarily because sometimes the robotic arms may move the Setinsky clamp. Rummel's tourniquet with a vessel loop is acceptable. Arteries are clamped followed by vein. Most of the time I won't clamp the vein, but if I'm on the right side and a tumor is close to the main renal vein, better to clamp the vein. So tumor excision, I'll quickly go on to that side. So how do we excise the tumor? Is it enucleation? Is it enuclear resection, or a good resection with normal renal parenchyma? Again, depends on the site of the tumor. I've always found that the more deeper the tumor is, subconsciously you go and do an enucleation there. You don't want to hit major vessels when you're going deeper into the hilar tissue. But if it's exophytic tumor, I generally prefer to get a good amount of normal renal parenchyma as well. But enucleation is acceptable. Enuclear resection is also acceptable. So here you see this part is being enucleated, and here there's some renal parenchyma on top of the tumor. So the next is rhinorrhaphy. I'm certain very good speakers are going to speak about this. So I'm just going to give you the basics of this. I do a rhinorrhaphy technique, which is 2-layered, and it's done by Stratafix or quill sutures. And I consider the first layer rhinorrhaphy far more important than the second layer rhinorrhaphy. And the quill sutures continuous go from one end of the kidney to then we do this is to close the collecting system. You don't need to separately close the collecting system. Single continuous sutures starting from top to bottom is more than fine to close the collecting system as well. But and the second layer rhinorrhaphy is the sliding clip rhinorrhaphy, where I use separate vicryl sutures, about 5 in all, and sliding clip rhinorrhaphy. And so at the end of this procedure, you'll have about 5 vicryl stitches inside that needs to come out, needles inside, and 2 or 3 quill sutures inside that also needs to come out. So rhinorrhaphy, I'm going to let the experts further down the line talk about it. And what about bolsters and hemostatic agents? I've given up using hemostatic agents, but bolsters sometimes, yes, I still do use it, more for my peace of mind rather than the effect it does, right? So hilar unclamping and nephropexy. So hilar unclamping, I don't do an unclamping after the first layer. Usually I wait for the second layer. But if you're time pressed, then you can do a hilar unclamping after the first layer rhinorrhaphy, and then do a second layer with an unclamped hilar. And always the geratas should be brought on top of the kidney so that it stays in place, and a nephropexy has to be done properly. So tumor retrieval done, this is a standard tumor retrieval. We use some homemade bag or and the drain placed in the lateral renal fossa. Hemostasis by bringing the pressure down to 6 and wait for about 5 to 10 minutes and see for any bleeding before you close. You never want to go back in for a partial nephrectomy. Right? If you have partial Postoperative care, IV fluids, analgesics, antibiotics as per hospital protocol, and DVT prophylaxis, and hemoglobin and hematocrit monitoring done for the first day, and Foley's removal on the morning of surgery, and drain removal. If we breach the collecting system, I would do a drain creatinine, and patients are discharged in 48 to 72 hours. Thank you very much. Thank you, Dr. Mahesh, and thank you for the introduction. Thank you, sir.
Thank you, Anand. It is a very nicely given standard, but very safe step-by-step technique. What we will do is we'll have, because all the topic has been divided in a different distinct, we can have a question answer at the end of it. Now, yes. I will invite the Senthil to talk about the rhinography technique.
So Dr. Desai sir, please you continue for the third lecture, because he has gone for some emergency. He will join later on, sir. So you can please continue.
All right. So I will speak. Jagdish, you wanted to introduce me?
Yes. Well, good evening. And
should I start?
No. That's my privilege. I don't want you to take my privilege. It's a great, proud privilege to have. And when Dr. Anup asked me you have to introduce Dr. Desai in a short time, and I was just thinking, what should I say? And I have to say only 2 words: great Dian of urology of the world, India, and a whooping experience of half a century in urology. May I present you Dr. Desai with his comments on warm ischemia in time in RPN. Is it mandatory? Sir, my proud privilege. Thank you very much.
Thank you, Jagdish. I will share my, where is my 1 minute? Okay. All right. So warm ischemia time in robotic partial nephrectomy, does it matter? I mean, that is a very important. Can you see my video?
Yes.
Yes, we can see.
Okay. All right.
You can see your slides.
Okay.
No video.
So what is important, why partial nephrectomy has come? Because what is important is, of course, oncologically, you need to take out the tumor. But what is important is the remaining kidney. Is if it functionally good, then it can prevent lots of morbidity at the end. So there are modifiable and unmodifiable factor. Unmodifiable is the comorbidity and the quality of the kidney, which you cannot just change. And you have to be careful with that. But modifiable, which is very nicely the Anand has shown, the indiculation technique, then technique of reconstruction, the rhinography, and the ischemia. And I'm going to talk about the ischemia. The earlier researchers suggested limiting ischemia time less than 30 minutes for a preservation of renal function. This debate came because the first paper which was published, a multicentric paper, where it was compared with the open surgery with a laparoscopic partial nephrectomy, and they found that the ischemia time was much more with the laparoscopic rather than open surgery. So this was the beginning of the research that, and they said that it should be less than 30 minutes. This is based on, of course, the retrospective on animal study. So warm ischemia time in the radical prostate, does it matter? Well, basically, anything shorten the ischemia time is better. So then came the early unclamping, selective or a segmental clamping, super selective clamping, fluorescence imaging to manage clamping, ischemic preconditioning, unclamped partial nephrectomy, that is zero ischemia, or you can do hypothermia with the robotic thing. But what is the most important thing which we found is the preservation of the renal function. So we must know the renal arterial tree, and for that the 3D reconstruction came, And I think this is very important because we are trying to preserve the artery. At the same time, we should know which artery is going to come in the way where we can do, whether can we do a selective or we can do a super selective clamping or a truncal clamping. For in this patient, it was decided to do a truncal because the tumor was near to the hilum. And then, of course, as Anand said, we marked the margin with the ultrasound, and then you took out. And this is the typically a radiography where you take a very small amount of tissue so that you can preserve the maximum number. I use hemostatic agent, whatever their this thing. So that's radiography, I think, is going to be will be addressed by Senthil. So I will not go. But what is important is the effect of this on the creatinine. In this patient, it was 0.74. It rose to 0.76 next day to 0.86 at the 1 month. And again, after 1 year, it has come down to 0.8. Similarly, the eGFR was 95 preoperatively, and it dropped down to 89 at 1 month, but it came back to 91 at the end of the one year. Similarly, you have a bilateral tumor, and then naturally here you are going to do a simultaneous zero ischemia or a hypotensive anesthesia. Ultrasound helps you to help out to preserve maximum renal tissue by demarcating the tumor level, and then this is the hypotension. And then, of course, you take out the tumor, and then you do the radiography. So here was a chromophobe bilateral renal cell carcinoma. Again, here you see the serum creatinine was 0.89. It rose to 1.25 because zero ischemia bilaterally, and then at 1 month it was 1.7. But at 1 year, it has come down to 0.84. Lovely. And then eGFR was 91 to begin with. And then it was 42 at 1 month and 92 again at 1 year. And this is very important that the effect of the warm ischemia on a bilateral tumor, or if you take a large tumor, normally we would think of doing a radical nephrectomy. But here, by doing the angiography, you could make out that you can do the super selective clamping, and you can preserve the renal function, and you can have a functioning kidney tissue. So here we did ultrasound, and sometimes I use a color Doppler because it helps us to identify. And here there is only one vessel, so we just isolated the one vessel and clamped it, and it was again super selective clamping. Rest of the rest of the kidney was kept perfusing, and then here is partial nephrectomy done. Ureter was a little bit, the lower part of the calycis was removed. So here we sutured that calycis, and then did rhinography, and then the closure. So zero ischemia, what is the rationale was eliminate the global renal ischemia, the contoured resection, pinpoint hemostatic rhinography, and a better volume preservation. I think better volume preservation is the most important, the aim. And here again, if you see from 0.89 preoperatively, and after 1 year, it has come back to 0.84, hardly any change. And even the tumor was large. And in between, it had gone up to the 1.7. Here is 91 eGFR, dropped to 42, and again come back to 92.5 after 1 year. And here is the tissue. Again, there are many issue, like you can use a fluorescent imaging to preserve, identify the vessels. You can use mannitol. You can use warm ischemia model. Many drugs, hypotensive drugs, we can do it. So let me share our data with you. We analyzed the 294 data for warm ischemia time, and then the mean tumor size here, because the warm ischemia time does depend upon the tumor. Is less than 4 centimeter, 160 cases, 4 to 7 centimeter, 121 cases, and more than 7 centimeter, 16. The nephrometry score, which very important guideline. Less than 7 was 147 and more than 7 was 140, almost equal on both sides. And the warm ischemia, the zero ischemia was in 33 cases, 8 to 20 in 131, largest amount of group, 21 to 25 in 57, 26 to 30 in 44, and more than 30 in 32. So overall warm ischemia time was 19 minutes plus and minus 10. So here a conventional wisdom is that if you keep less than 30 minutes based on the trauma and a vast literature, and but most preferred is 15 or 20 minutes, most it is preferred. So in our thing, if the tumor size was less than 4 millimeter, it was 18 minutes plus and minus 10. If it is more than 4 centimeter, 20 minutes. But conclusion was with increasing tumor size, warm ischemia time increases. Similarly, with increasing nephrometric score, warm ischemia time increases. And then if you see the eGFR in 283 cases, there was no change in 25%, 0 to 15 drop in 40%, 16 to 30 drops in 23%, and 31 to 45 drops in 10%. But after 1 year, no change in 22%, 0 to 15 is 30%, and 16 to 30 is 36%, and 31 to 45 drop in 10% only. So here we found, while seeing the GFR at 1 month and 1 year in a different scenario of warm ischemia, we found the warm ischemia time is not a significant factor for eGFR4 at 1 month. And warm ischemia time is not a significant factor even at the 1 year. So that was a very good observation we did. We also compared with no pre-existing disease and diabetes and hypertension. And we found the warm ischemia time is not a determining factor for the fall on eGFR at 1 month and 1 year, even after the considering comorbidity. So 30-minute cutoff in 2020, every minute counts, cutoff lower to 25 minutes. And now every minute doesn't count. And recent evidence challenges notion of safe 20 to 30 minutes of ischemia time. Every effort should be made to minimize ischemia in the setting of solitary kidney and the patient with the baseline CKD. So in the end, take-home message is warm ischemia time is not an independent predictor of a GFR at 1 month and 1 year, but every effort should be made to reduce ischemia time. Pre-op GFR and pre-operative complication has a significant impact on the post-operative renal function. And lastly, the focus should be on the management of pre-op CKD and a peri-operative control of the hypertension, diabetes, and proteinuria with timely nephrologist referral. Thank you very much.
Thank you, sir. I will take pleasure, Dr. Chakulkarni, with your permission to invite Dr. Mallikarjun. Yes, Mallikarjun, of course, does not require any introduction, but still, I have a pleasure in inviting him. He's a president of Urological Society of India, and he is going to talk on his favorite topic of partial nephrectomy. He has been demonstrating the partial nephrectomy laparoscopic at almost every workshop where he does partial nephrectomy with the ease that other people do TURP. In that ease, he does the partial nephrectomy. Of course, it was all laparoscopic. He was demonstrating the complex cases, complex tumors, but now he has shifted to robotic, and he's going to tell us the robotic partial nephrectomy for the hilar tumors and the complex tumors. Over to you, Mallikarjun. Please go ahead.
Thank you, Sabnis. I haven't shifted to robot completely yet. I still do laparoscopy still because I still believe there is some role of laparoscopy in some cases at least. And I am found, and I think, of course, there is a definite equipment advantage with robot. There's no doubt about it. Well, we are talking about robotic partial nephrectomy. I was asked by Anup to talk on both hilar tumors and dual or multiple tumors, whatever you call it. Let us talk about hilar tumors first. If you look at the hilar tumors, one thing we realize, it's one good thing about hilar tumors is one plane is already made. We need to create one more plane between the tumor and the kidney. But one plane which is there inside the hilum, which has got fat and vessels, it's already clear. That's one good part of the hilar tumor. So whenever you think about hilar tumors, it's going to scare you, but in fact it is going to be appreciating is you have one plane which is already made, which you need to dissect and which opens up the moment you get into it. So I would say you have to have a proper delineation and understanding of the tumors before by a good CT or a good radiological imaging, so that you can understand whether it is truly encapsulated, or I'm sorry, it's not playing. Okay. It's really encapsulated or not, or it is just the encapsulation is proper or not, because my resection will entirely depend to do a enucleation or a nuclear resection versus doing some sort of a wedge resection like thing by the way the radiological appearance is going to be there. So our approach is going to be transhilar. There will be a selective clipping of the segmental arteries, careful dissection, individual ligatures to the vessels and infundibula of the calyces, avoid random suturing of the base, and cortical approximation. This is one of the tumors which is seen in the anterior hilar region on the left side. So we go to the video of the same, and this is, I can't see a clear pseudocapsule. Very clear pseudocapsule I'm not able to make out. There is a discretion between the normal and abnormal, but a clear pseudocapsule is not there. So geritophagia incision over the hilum and exposing the hilum directly. In fact, we have dissected the renal artery by this time. We created a small window all around the tumor into the geritophagia. That's a dissection which is happening before we entered into it. There is a small dissection which happens transhilar before that. After screening the tumor size, etc., by an ultrasound, I do clamp only the artery. I never clamp the vein, especially in hilar tumors, because I want the tumor to be distended. You already dissected the inner plane by inside the hilum to a certain extent. So you make a incision into the parenchyma all around, and that's sort of some sort of wedge dissection. And you start from one end, whichever is convenient for you, by lifting the tumor and getting into the plane what you have created in the hilum already. You'll see that small vessels which enter into the tumor. A small 5 mm Hilmalock clips can take care of them, and you start dissecting it. That dissection which is already made in the hilum will make you get into this plane very easily, and the tumor will start getting away from it. As you go ahead, you start rest of the incision onto the parenchyma and start reflecting this tumor. You see this part of the tumor which is already made, which is already the tumor, the plane is already made, that is into the sinus, and complete the thing. I don't make an incision completed beforehand. So at the end, you excise the tumor with a fair, decent renal margin, especially in those cases where the capsule is not clear, and you have a raw area inside with multiple clips, which definitely look a ghastly appearance. Whenever you have to control, you can have a Valsalva maneuver to see the veins which are bleeding, and my control of blood vessels at that time is in a different fashion. You see that thing which is going parallel to the hilum. The needle will move across as parallel to the hilum, not vertically how you do in a regular rhinography. After that, after fairly decently controlling the vessels, I always put a fat pad if it is possible. That's a fat pad which is going to be kept, and the small veins which will come out once we close the rhinography. So either you can do a rhinography continuously like how Dr. Mahesh Desai has shown just now, or I just take a fat pad which I'll keep inside and then close the rhinography. This will help us. You see, the one scare we always have is these hemolocks getting into the vein or eroding into the vein or something happening with hemolock. But I think this will protect by having. You don't need to close the hilum together. You can still leave a space. Just need to get a pressure between the parenchyma, and so that gives you a better appeal. And opening of the clamp, and you see the hemostasis. And if I put a Surgicel in between and close the zerota above it. So a minimal dissection anterior hilar tumor is very good. Let us look at a posterior hilar tumor, just exactly the opposite. Aranta said a beautiful point of shifting the telescope a little lower down. That patient had a lower ureteric stone with a posterior hilar tumor here. So we removed the stone past the stent already inside, flipping the kidney completely and taking away. There is one small thing which happened. I think present day, I don't take this fat across with the kidney. I leave the fat to the posterior abdominal wall. So you don't need to defat it again once it is flipped. So flip the kidney, taking out the fat. And that's a tumor what is seen there. And that's an artery which is dissected away. It's a single artery. And then it is, and a clamp being placed. And now you demarcate the tumor and start cutting across. And even this had a capsule to a certain extent. So, but we have a good incision all around and start excising it. But on ultrasound, we could see this tumor goes right deep up to the pelvic wall. So you'll see the segments, branches from the posterior segmental artery of the, that is the posterior segmental artery branches, which starts bleeding. That's a vein. and we have a clip on it directly. So the posterior segment of the kidney that branch will take care of the blood supply to the tumor. So that is the excision which is happening it, and we go on giving an incision all across and then reflect the tumor away. And you see that majority of the part is going to be the wall of the pelvis, and in this case the wall was involved, so we had to excise a part of the posterior pelvic wall along with the tumor. So that is being excised. That's the posterior pelvic wall which is being excised, which is attached to the tumor, and that's a tumor. And now we close the that's the excision which is happening. And now we close the pelvic wall, and then it got okay. The same technique we use, and then we close the got touched and stuff. Yeah, that's it. We keep the fat pad inside, and then close the close the parenchyma. That's the parenchymal closure which is happening. So that's how a posterior hilar tumor has been done. And sometimes we see a tumor inside the kidney, and that is going to be intrahilar, truly intrahilar tumor, which is going to be a problem. Sometimes between the vessels and in the calyces, or sometimes posterior or in between to the calyces part. So this is another intrahilar tumor which we are going to show, which is just inside in a patient with a mild CKD. You can see the MRI which shows an intrahilar tumor, possibly behind the calyx. So we do a dissection in the upper pole. We find an upper polar apical artery, which we clip it off and divide it off selectively. We make an we just take a decapping of the kidney, like a part of the small apical segment of the kidney is taken away, and the rest of the tumor is encapsulated. That apical part which is being taken away, and the tumor which is identified behind this is the upper calyceal infundibulum, which is being divided. And behind that, the tumor is identified. That's a tumor which is identified and enucleated. It's just an enucleation because it's inside, deep inside the thing, along with the upper apical segment, rather than not the upper, but the apical segment that is being excised. So after excision, that's a tumor being excised. You'll see the complete excision of the tumor, along with the upper apex of the upper apical part of the kidney. That's a tumor which is excised, and the rhinorrhaphy done in a standard closure of the thing. So this is another way. This is a closure of the rhinorrhaphy. So this is intrahilar tumors, which is a difficult thing which happens. Coming to the dual or a multiple tumors, this is one case with an upper polar hypervascular tumor and a large lower polar hypovascular tumor. We don't know whether both are same or different. The only thing is ischemia time. Definitely there will be a little prolongation of the ischemia time in these cases. So we tend to avoid a clamping in a smaller tumor or whatever is easily possible. So we have a loops across the two arteries which are there. Be ready for that, for the clamping. And we tended to do an enucleation of the upper polar tumor without a clamp. So with non-clamping technique, so that decreasing the ischemia time. So we start doing an incision all around, and that's an incision which is being placed in a traditional way, just trying to enucleate, which is a very well encapsulated tumor. So we're trying to enucleate it and get into that plane with that blunt dissection which happens between the tumor and the parenchyma. And you may find some vessels which can be sometimes cauterizable. Sometimes they may not they cannot hold on by cautery. So that's a blunt dissection between the tumor and the thing. You may see a bigger vessels coming inside, so that they may start bleeding. You may need to have a good suction or a good assistant who takes care by keeping a suction on it and making your path visible very well. So after excising it, you do a rhinorrhaphy. Having a pressure with your left hand onto the rest of the parenchyma will definitely decrease the bleeding to a certain extent, but that will be possible only after the enucleation is possible, and you are going to see some bleeding when the enucleation is being done. So after that, you start having a pressure onto the kidney, and that will decrease the bleeding and start closure. I do an interrupted sutures into the base, and then tie with a figure of 8 sutures only. 2 or 3 of them in this area will control the bleed, like what it has happened just now. That is a complete control has happened with that one single vessel which is being done, and then we close the parenchyma over it after that. After this, it's a standard rhinorrhaphy, sliding rhinorrhaphy technique which happens. So after being done, then we think about doing a bigger tumor. That's a closure of the parenchyma, and that's a outer rhinorrhaphy. We clip the kidney, and now we're trying to enucleate this tumor. This also has got a beautiful capsule. So with a nice vascular plane, we tend to look into the enucleatable plane between the tumor and the kidney parenchyma and start enucleating. This is a dual tumor. So one tumor done without clamping, and one tumor being done with clamping. So a similar blunt and sharp dissection both together between the tumor and the parenchyma, which dissects the tumor completely. So I go a little forward, and that's a tumor which is being enucleatable. And in fact, both turned out to be clear cell carcinomas. Both are clear cell carcinoma. You can see these vessels which are stretched over the tumor there, and which being separated away from the tumor. You can see the veins which are getting opened up, and possibly that requires a running suture or a continuous suture to have a good control of them. In this case, because there is a large area, or the area of attachment is very large, I thought I'll do a continuous rhinography in this case. So I took that's an excision which has happened completely. And now I start doing a continuous rhinography. I haven't clamped the vein on the right side, so there is some element of bleeding. So with the 30 V-lock, I start doing a continuous rhinography in the center part, or a medulla, and the hilar part, the sinus fat of the kidney, and then get the needle out and put a hemolock onto it and have a traction on that. So that's a completion of the inner rhinography. And then we complete the inner rhinography now, get the thing out and have a traction on it with a hemolock. So that will take care of the bleeding completely. And now we do an outer rhinography, previously we used to take a large bite, but nowadays we have restricted the bite only to a 0.5 to 1 centimeter, vertically a bit deeper, but horizontally it's smaller. Vertically deeper, but horizontally flat. The incision, the bite should go right up into the medulla and need to come out to the medulla. But it should be horizontally very small. It's 0.5 centimeter from the edge of the thing. It is just to have a good compression onto the parenchyma. So that's a completion of rhinography which is happening here. So dual tumors being done. I don't have much experience on 3 tumors. 3 tumors in one case. I've done a RF ablation of 2 tumors and enucleating 1 tumor. That's only experience I had with 3 tumors. And this is out, and I think I finished it. Thank you very much. Thank you, sir. Thank you, submittance all over to you.
Thank you, Malik. That was a fantastic talk. As Dr. Mahesh Desai said, we'll take the questions at the end. Now I invite the next speaker, Dr. Chandrasundaram. He's going to talk on the partial nephrectomy T1B endophytic renal tumors. As you know, that as the experience of the smaller tumor has increased, the indications have now expanded. And now people are doing for T1B tumors also. So he's going to tell us what are the tips and tricks for the endophytic tumors and the larger tumors. Over to you, Dr. Chandrasundaram, please.
I am delighted to be involved in this presentation of the World Robotic Symposium. I am truly grateful to Dr. Professor Anup Kumar for the kind invitation. I am delighted to be in the company of stalwarts like Dr. Desai, Dr. Kulkarni, Sabnis, and Gautam, who are all very good friends. The illustrious faculty, including Drs. Shivaramakrishnan, Sendal Nathan, Mallikarjuna, and Rafael Colo, are a delight to be with. So in the next 15 minutes, I will be discussing robotic partial nephrectomy for T1B and endophytic tumors. As you know, for T1B endophytic tumors, a partial nephrectomy, a radical nephrectomy, as well as active surveillance in selective patients is acceptable. We will concentrate on partial nephrectomy, which is much better with regard to preservation of renal function and with comparable oncologic outcomes compared to radical nephrectomy. With regard to my experience with robotic partial nephrectomies, I started doing partial nephrectomies in 2002 with the robotic approach, and the number of robotic partial nephrectomies increased exponentially in 2006. I share with you the last decade of outcomes at Indiana University of over almost 700 patients, a vast majority of which are my own personal cases. As you can see in Indiana, the BMI is over 30 with multiple comorbidities. The OR time was about 200 minutes. Warm ischemia time was about 18 minutes. EBL was less than 200 cc. Conversion to open surgery, less than 1%, with a greater than 1 Clavien post-op complication of about 10%. Local recurrence about 1%, and a positive margin about 4%, all comers. Now let's move on to technique of our robotic partial nephrectomies. I will share with you a few cases to illustrate several technical details. Here is a patient with a 52-year-old lady with two right renal masses. As you can, the mass had increased in size from 2 to 4 centimeters, and that is the mass that you can see on a CAT scan. You can see that this is close to the hilar blood vessels. So the excision as well as the reconstruction should be tailored according to the anatomy of the mass and the renal hilar vessels. The mass is being scored after extensive ultrasound, and the mass has to be dissected away from the hilar vessels after working in the renal sinus. So you can see that the vessels are being clamped, and the tumor is being dissected off the hilar vessels. As you travel and progress towards the base of the vessels, you can see the capsule. The tumor has been excised. In this case, an open-ended catheter was placed in a retrograde fashion to expose the openings in the collecting system. The rhinorrhaphy is being used to selectively close the collecting system and not damage the other structures in the hilum. As the rhinorrhaphy progresses, its water tightness is being confirmed by injection through the retrograde urethral catheter. Care should be taken not to damage the underlying blood vessels that will result in ischemia to the rest of the kidney. So in this case, just a single layer rhinorrhaphy was essential because of the configuration of the defect after the partial nephrectomy. The hilar vessels have been unclamped at this stage, and any bleeder selectively closed. Any other openings in the collective system are also addressed. And that is the end result. You can see that all the blood vessels are being preserved, and there is no bleeding. Warm ischemia time was a little over 20 minutes with a 50 ml blood loss. The next is another hilar vessel where the reconstruction is a little different, and I'll share with you this video. You can see that the blood vessel is right in the hilum, again close to the hilar blood vessels. This is the coronal image of the same tumor. And in this case, a rhinorrhaphy was possible, and that's what we will illustrate. I'm going to skip through part of this until we get to the clamping of the blood vessels and excision of the tumor. The bulldog clamps are used to clamp the blood vessel. The artery is being clamped. We typically use 2 vascular bulldog clamps, as is seen here, for the arteries. The renal vein typically does not need to be clamped except in selective cases, especially in right-sided cases, which are hilar. Then the excision is being conducted now. Again, you can see the margin there and the normal renal parenchyma at the surface. The excision is continuing. When the tumor capsule is exposed, this we call an enucleoresection. You could see that that is a little nubbin of the tumor that is extending deep into the hilum and is being separated from the surrounding structures with blunt and sharp dissection. And you can see that the capsule is intact. And once the tumor is excised, the rhinophary is tailored to the configuration of the renal parenchyma that is left behind. In this case, we decided to do a rhinophary that was more like to manage this horseshoe defect around the hilum. So that completes the excision. Of the tumor. In some cases, a frozen section of the masses of the base of the tumor can be done. In vast majority of the cases, it's not required. Now, again, you can see that the defect consists of a horseshoe defect around the hilum and the hilar vessels, and the sinus fat is in the base of the tumor bed. So after the renal parenchyma is fulgurated, the defect is managed with a running 2O barbed absorbable suture that begins at one end and ends at the other of this horseshoe renal parenchyma. Sliding clip rhinophary is used to tighten the suture as the suturing is in progress. The needle comes out right beneath the cortical tissue in the junction between the kidney and the sinus fat. And once the entire suture is completed, you can see the defect there that is being completely sutured, and the vessels are released. Normally, we do not use any tissue sealant when we do a traditional 2-layer rhinophary, but in cases like this, we do use tissue sealants. In this case, a a suture is being used to stop individual bleeding vessel. And opening the vein is sutured closed. The clamps are released, and that is the defect at the end of the procedure. Now I will share with you my last video in the next 2 minutes of this 70-year-old gentleman with a renal mass. You can see the mass there. This is a larger mass, and I'm sharing with you just the interrupted outer layer of the renorrhea in this video. So this was a 6 centimeter mass in the mid-lateral kidney that was excised. And after excision, as you can see, there's a large defect involving almost the entire kidney laterally, extending up to the hilum. So in the renorrhea, we used 2 sutures, 6-inch long, 2O barbed suture for the deep layer. After the first layer was completed with 2 individual sutures, you can see that there. And the suture then comes out to the renal surface, and a clip is placed to tighten the suture and get good hemostasis. And once that is done, interrupted renorrhea is used for the outer layer with O-vicryl that is used here. Again, sliding clip renorrhea is used for each one of these. For a typical tumor, we do a running outer layer, but in this case, we are doing an interrupted outer layer. The advantage of this is you can keep the defect open until the end of the renorrhea, where all of these sutures can be tightened individually. And the second layer is being tightened here. And then if there is any bleeders after the second layer is tightened and the vessels are released, you can use the end of these interrupted sutures to place another stitch as is being used, as is being done here. The tightening of that stitch is first done. A locking clip is applied there, as you can see there, to ensure that it doesn't slide again after the operation is completed. And that completes the operation. I truly appreciate this opportunity, and I'm looking forward to seeing all of you once we go through this pandemic. Thank you very much.
Thank you, Chandu. It was nice having you with us. Now I'll request Jagdish Kulkarni to introduce our next speaker. Rafael. Jagdish, unmute yourself.
Good evening, Dr. Rafael Coelho. It gives me great pleasure to introduce you. I know you are the currently chair of minimal invasive and robotic surgery at the University of São Paulo in Brazil. And you're going to talk to the subject on a subject which is very close to my heart, is renal tumors with IVC thrombosis. Please go ahead. Stage is yours.
Thank you. Can you guys see my slides?
Yes.
Okay, so thank you very much. It's a great honor to be here today talking about our experience with IVC thrombus, managing a minimally invasive fashion. We used to do that in a pure laparoscopic approach, and now we are only doing this with robotic assisted surgery. Just to remind you some of the key principles on how we manage patients with RCC with tumor thrombus. We know that about 10% of these patients with renal cell carcinoma, they have some kind of thrombus in the venous system. 1% of these patients have high thrombus to the high right atrium. We know that histological features of the primary tumor are the most important prognostic factors like grades, perinephric fat invasion, and nodal and metastatic status. The prognostic implication of the level of the tumor thrombus is kind of controversial, but some studies show that if the thrombus go all the way to the IVC, usually the prognosis is worse compared to thrombus only into the renal vein. And finally, if you look at this 5-year cancer-specific survival can be as high as 60%. That's why we manage these patients aggressively, trying to remove all the measurable disease. So that's why we manage those patients in aggressive fashion, because we can cure actually more than 50% of these patients long term. There are multiple grading systems for IVC thrombus. This is the one that I like to use because that's how I plan my surgery, and that's how I offer a minimally invasive approach to patients with IVC thrombus. I think patients with level 3A, level 2, and level 3A, which is just below the major hepatic veins, these can be safely managed in a minimally invasive approach. In our institution, those patients with level 3B or 3C, in those cases, we still prefer to do open and sometimes extracorporeal circulation. So let's talk about a surgical technique. That's how we put ports in a patient with a right side tumor thrombus. We put the right robotic arm and the left robotic arm in the midline. We have the camera port in the umbilical scar, and I have a 12mm assistant port here and one 5mm port for liver retraction. And I have this fourth arm, which is about 5 to 6 centimeters away from the iliac crest. So it's very similar to a partial nephrectomy, but we put the ports in the midline. When I do partials, I usually put more laterally. So just to start with a simple level 2 vena cava thrombus on the right side, I think these are the easiest to do, and I think it's a totally feasible in a minimally invasive fashion, and these patients have a great post-operative recovery compared to open surgery. So we start the procedure taking down the bladder. We start the procedure taking down the colon, and we're gonna access the renal hilum. And I usually do in the right side, I like to clip the arteries in the interaortal caval space. So this is the thrombus here. Let me see if I can show you. So here we have the thrombus here. This is the left renal vein. And this patient had 3 renal arteries in the interaortal caval space. So we start the procedure clipping those arteries. And this is the major renal artery, because you decrease a lot of the bleeding if you start in the interaortal caval space. So here we are underneath the vena cava. We are clipping the lumbar vessels. We don't need to cut them. You just have to clip the lumbar vessels. And I like to use a tourniquet in order to clamp the vein. And this is the tourniquet just below the tumor thrombus. We're going to use another tourniquet in the left renal vein. This is the left renal vein. And then the most difficult part, which is dissecting above the tumor thrombus. Sometimes you have some short vessels to the liver that you have to clip and cut. I like to dissect the adrenal, and this is the adrenal vein that I'm clipping here, just to make easy to pass my tourniquet around the vena cava. So this is a tourniquet just above. In this case, I actually removed the kidney. I used to do that in the beginning. I know it's not the perfect thing to do because I have to cut through the thrombus, and now I'm not doing that, especially in right side tumors. I try to remove everything in block. So we clip the vena cava just below the tumor, the right renal vein, and then we clip it, we clamp above the tumor, and here we are opening the vena cava and removing the thrombus completely. So these patients, they leave the hospital the day after surgery. The recovery is much, there's no comparison to the open approach, in my opinion. We remove the ostium of the right renal vein, and now we suture the vena cava. You can use the Gore-Tex suture if you have it. It's a lot expensive in Brazil, so we don't have it for every single patient. Then we use a 4-0 proline or 3-0 proline in order to suture the vena cava. Just finishing the procedure. So finishing the suture, you're going to remove the clamp. We remove the tourniquet. And you see there's no bleeding at all. So this is how level 2 vena cava.
So I think so there is some problem in the internet connection. You can carry on with the question answer sessions now, sir. Dr. Mahesh Desai, sir, Dr. Kulkarni, sir. You can continue with the questions.
Okay, that was a very nice video. Unfortunately, we lost him. Now, there's a couple of questions. I think we all participant can ask and share their experience. The Ajay Sharma is asking.
So Dr. Chandru Sundaram has also joined. Welcome, Dr. Chandru Sundaram, sir. You joined, sir.
Thank you very much.
Yeah. Chandru, it was a very nice presentation. And I would like to know one thing from you. When you are doing an endophytic tumor, and while after removing, you find little suspicious that tumor is still there, and you take a biopsy, and if it comes positive, then what you do?
That is a good question, Dr. Desai. It all depends on the situation. I remember one case where I was suspicious that there was a positive margin. And in that case, I decided that I cannot take anything more. And if the margin is positive, I'm going to take the whole kidney out. Only under those circumstances, I think it makes a difference. Otherwise, I think gross examination, visualization under robotic magnification is really the key. So I would say 99% of the time, if you under robotic visualization think it's a negative margin, it will be a negative margin. In one situation, like I told you, I thought it was going to be positive during robotic visualization, but I was unsure and I knew I could not do any more. So I sent a frozen section and it was positive. I was right on the hilum, on the renal artery. So I decided to take the kidney out. So the short answer is frozen sections are usually not required. And a gross robotic negative margin can be achieved by robotic visualization.
Okay. Mallikarjun,
yes,
you are also doing the hilar tumor. And if you are in that same situation where you think there is a little tumor there, and you take a biopsy and it comes frozen, what will you do?
So first of all, I don't think send a frozen. I'll just, most of the time we don't do a frozen at all. It's only our macroscopic evaluation whether I've done it or not. If I feel that there is something wrong there, I'd better do a radical or excise more rather than waiting for the frozen to look at it. That's one thing, sir. Very occasionally, if you see that it's a macroscopically thing, I don't think if it is not feasible to take a donut and just get away with the normal kidney there, I better think about a radical nephrectomy. Oncological clearance is of the prime importance rather than doing a partial. So that we'll stick to it. I think all of us will agree on that.
Jagdish?
Well, I think what you said is clear. If you have to have, revise the margin, maybe you can go down once, and then it's better to. I do frozen section routinely. There is no doubt about that.
But you can revise and then save the kidney.
Absolutely, that's one thing I will try. But that's only once. And if that margin comes positive, I would say no. Let's go ahead and do an nephrectomy.
Well, Dr. Gill presented. He published 4 cases where he had a positive margin, and he did a nephrectomy. In the first 2 cases, he did a nephrectomy, and on a nephrectomy, the histopathology they did not find the tumor.
True.
So this is exactly many times it happens. It happens.
Once I seen he was suspicious. He took a biopsy and that came positive. He redo the resection and took it out. And that patient is about 6-7 years ago, and still there is no problem. So I think only thing is suspecting. If there is a tumor, you can revise it. Or if it is a small tumor, you can always watch and do that. But the another question was that while doing it, you suppose perforate. Because in robot, the scissors comes down. Hello, who's this?
Yes, sir.
A scissors comes down, and that can perforate the capsule. And then what you do? Chandu?
Not all perforations are the same.
Yes.
A little violation of the tumor is not a big problem. You can always revise it and achieve a negative margin. If you don't know where the margin, you violated the tumor, you have ruptured the tumor, you don't know where it is, you think there's a positive margin, you take an entirely new sleeve of the bed completely because you don't know where the positive margin is. On one occasion, many years ago, especially with papillary tumors, you have this mushy, very fragile tumor that will just explode. It'll just, there'll be gross violation. I've had that on one occasion. Unfortunately, once it's done, it's done. So the key is to prevent that from happening. And if in the unlikely event that it happens, immediately bag it so that there is no violation of the surrounding tissue and contamination of the abdomen, and then go back in, get a negative margin.
You won't do the nephrectomy?
No, no, not really, because once there is gross spillage, nephrectomy is really not going to make a difference, and you won't know it for years. Just like you mentioned about a positive margin being inconsequential. Not all tumor violations are the same. Not all tumor ruptures are the same, just like not all tumor margins are the same. You can always observe it and come back later if you need to.
Anand, I would like to ask you a question. Anand, are you there?
Yeah, he's there. He's there.
Okay.
He's there.
Anand, if the tumor is posterior, apical posterior, would you do a retroperitoneoscopy? People are advising that.
Yeah, so I have attempted retroperitoneoscopy. In fact, when I started out with radical nephrectomies laparoscopically, I got trained by Dr. Peter Remington, who always used to do retroperitoneal nephrectomies. But to be honest, when you're doing a partial, the space is a big constraint in retroperitoneoscopy. So I've always found that if you're able to flip the kidney completely, and then access the site of the tumor, I think that's a reasonable way to go forward. But I have nothing against retroperitoneoscopy for people who would like to try that.
There is a one question regarding the clip. Did we have any experience of clip migration? I would like to say yes. I had one clip migrated after 4 or 5 years, and it came into the pelvis, and it formed a stone around it. So we didn't recognize initially, but when we did a puncture and tried to remove that, and then we found it was a clip. And above on the top of the clip, there was a calcification. Did any of you had a clip migration?
Yes. Yes. Yeah, I had actually three clips which really formed a ball. And when we put a PCN with Dr. Patnaik's help, and they just displayed it, they were clips. So we had to do that. Yes, 3 clips, 3.
Okay.
So
Amish, you want to ask question? Sorry.
Stones developed in a radical prostatectomy after in the bladder.
Yeah, that is okay.
Now, if you ask me radical prostatectomy, I had a 10-15 cases. But
Dr. Rafael has joined. Dr. Rafael has joined. You want to ask him question? You can ask him about the IVC thrombus.
Dr. Rafael, I just want to ask you to get to the superior extent of the tumor, be infrahepatic, how difficult and how easy is, and do you have a cardiovascular guy standby?
No, we actually don't. I think it's the most challenging part of this dissection, but I couldn't show the other videos, but I have actually thrombus going all the way to the major hepatic vessels, and we are able to dissect it. You have to clip and cut some of the short hepatic vessels and dissect. Sometimes we do some hepatotomies. We cut a little bit of the liver, but we can actually access the major hepatic vessels with a minimally invasive approach, which I think it's really a great advantage to our patients. I mean, they leave the hospital the day after surgery.
Rafael, this is Dr. Desai, if you have a tumor on the left kidney and you have a thrombus from the left renal vein going into the IVC, how would you manage? Would you go to the IVC first and then the kidney, or?
I do the kidney. If I can show because I lost connection, I have one video with the left kidney. If I still have time, I can show, or because in those cases, I usually stapler to cut the renal vein in the left side. Then I flip the patient and I do the right side. But I usually start with the left side. I remove the kidney, I cut the renal vein, and then I do the thrombus in a second time. Yeah.
Would you do an angioembolization? Would you do an angioembolization?
I don't do that. I don't think it's necessary at all. I know Indigo, he does that. He does embolization in the left tumor kidneys. I don't see any advantage of that. I mean, it's in my opinion, it's totally useless. We have done a lot of left side kidney tumors with thrombus, and there's no major bleeding, and we are able to do it without embolization. I don't think it's necessary at all.
Chandu, do you do any angioembolization before a tumor and IVC thrombus? Unmute yourself, please.
Yes, Dr. Desai, absolutely. I do angioembolization. And the reason why I do it is not because it's absolutely required, but if there was something to go wrong, if you can't access the renal artery and you have to work more on the vein, and then in the bargain you embolize, break off a thrombus and it goes to the heart, it can be a disaster. I mean, when things go well, IVC thrombectomy is great, but it's not to be advertised as something that everyone should do. A good open operation is much better than a bad robotic IVC thrombectomy. So it can definitely be done safely, and it can be done very effectively. I've done several of these, but I've also had one occasion where there was constant bleeding. There was one lumbar vein that could not be accessed. So when things go well, it's great. It's a great video to show, and I think it should be done. But there are lots of caveats. You should go prepared for every complication that can happen in order to do a good job. In fact, in the days of laparoscopy, I did the first hand-assisted laparoscopic IVC thrombectomy in the year 2000, and I do it very selectively. We, especially in America, we have these 35 BMI patients. It's not always easy to do it in all patients. So I think a good selection of patients, being prepared for every eventuality, and the converting if required is certainly acceptable.
Jagdish, you have any questions?
Well, I think only one question to all of you, and I'm looking at single port robot which is on the way. You think that will make any difference vis-a-vis extraperitoneal and intraperitoneal, and if so, in bilateral site in the same sitting? Single port robot. This is open for all.
Well, I don't have a single port robotic experience, but I have a single port laparoscopic experience.
Yes.
But now I have not done a tumor. I've done a non-tumor because, tumor where your oncological principles are such that. Dr.
Sundaram?
So,
Dr. Sundaram, you have anything?
So, sir, Dr. Desai, sir.
Any comments by anybody?
So we need to now wind up the session, sir.
Okay.
Thank you.
So thank you very much, Anup, and thank you very much all the speakers. And it was a really enjoyable session. And of course, the IVC thrombus also was very nice and really welcoming him from the Brazil. That was very nice. Thank you.
I want to thank all the speakers, Dr. Anant, Dr. Mallikarjun, Dr. Chandru Sundaram. The sir has joined us very early in the morning from US, so we are really grateful to you, sir. And Dr. Rafael, my dear friend from Brazil. All speakers, they have given very wonderful presentations. And all moderators, Dr. Mahesh Desai, Dr. Jagdish Kulkarni sir, and Dr. Sabnis, and they've done a wonderful job in moderation. And there were a lot of questions, and I know there was paucity of time, but I think it was a great session, sir. We move on to the next session, again, a very interesting session now. And I invite the chairpersons for this session of robotic radical prostatectomy, Professor N.P. Gupta, sir, Dr. Anish Srivastav, Dr. Srinivas Samavedi, and Dr. Ganesh Pakshi to please take over the session and introduce the next speakers.
Thank you.
No, my video is not working.
Okay, thank you, Anup, and for giving me an opportunity to moderate this session. Anup, am I audible?
Yes, sir, you're audible.
Okay. So without wasting time, as we are already late, I'll request you basically. I'm sure you are tired, and you don't need big introduction, but Professor Anup, he's the hero of the day anyway, and a professor and head in Symposium Hospital in Delhi. So, Dr. Anup, please.
So thank you, everyone. I'm going to present a 10-minute video showing step-by-step nerve sparing posterior approach RARP in high-risk localized prostate cancer. So this was a 67-year-old male having history of LUTS for last 6 months. He was a known hypertensive, and DRE was showing a grade 2 hard nodule on the right side. SHIM score was good. Ultrasound showing 60-gram prostate, and PSA was 22. And MRI showing 2 by 2 centimeter peripheral zone lesion, but there was no extracapsular extension or neurovascular bundle involvement, no subneurovascular involvement, and no lymph nodes detected. Trust biopsy showing adenocarcinoma prostate, right side having 4 out of 6 score positive, left side 1 out of 6 score positive, and Gleason was 4+4, ISUV group 4. PET scan we have done in high-risk patients, and this was showing localized disease. It was a high-risk localized CA prostate, Gleason 4+4. We planned him for the nerve-sparing robotic radical prostatectomy and expanded pelvic lymph node dissection. Now, this is I'm just showing for our young urologists who are watching this program that these are the instruments you should keep ready whenever you plan these patients for robotic prostatectomy. Maryland Caesars Prograph, pretty standard instruments for robotic prostatectomy. ASEAL, if you have, that's a luxury because it will really help in pelvic surgeries. Keep Hemolock and a titanium clip and pliers ready. Lap Maryland and Caesars for the assistant. A very good suction device is very, very important. And VLOC I use for DVC suture and vehicle for bladder neck reconstruction. 3O VLOC suture for vesical through anastomosis. Always keep a rescue vascular stitch ready for any vascular injury, and always keep an open instrument trolley for any mishap if happens. Now, this is the standard port configuration we use for XI Robo. All the ports are in the same midline, in the same line. These are 4 robotic ports we are using. This is the ASEAL port. and this is the one assistant port. So this is typical configuration we use in all pelvic surgeries, patient is in the Tendelberg position. So I'm just showing this video. So we start with the posterior approach first, dissecting the vas deferens and going towards the seminal vesicle. Now, I prefer posterior approach in most of our Indian patients because normally we deal with locally advanced patients and high-risk patients. And I prefer to go posteriorly first because that way I can dissect the rectum early and can dissect it down. The chances of injury to rectum minimizes and my subsequent steps become very, very easy. So as you're seeing, I am dissecting the right side vas deferens, and now I'm dissecting the seminal vesicles on the right side. Now using the XI robo, you can just push a button and you can toggle the scope from 30 down to 30 up. And as you can see right now, we are doing the posterior dissection and it is 30° up. And you can see such a very, very nice vision we have. You can go more distally right up to the apex of the prostate. You can go laterally. I can reach up to the neurovascular bundles from inside only. You can see such a nice dissection can be done from a posterior aspect. Now, once you have done that, the steps now going for the bladder dropping and anterior dissection. Again, careful if you have a BMI patient more than 35 because you might injure the iliac vessels during dropping the bladder. So you should be careful in high BMI patients. Then we are going for the endopelvic fissure dissection on both sides. This is on the left side. So this is the left side endopelvic dissection, and then going for the right side endopelvic fissure dissection. So use of the forearm helps in putting the traction, and you can see exactly the plane between the fascia and the prostatic capsule right there. So once you have done this endopelvic fascia, then subsequently we go for the next step, and you can see there that's the bladder neck transection, anterior bladder neck transection. Assistant, we are holding the bladder up and the assistant giving a tug on the Foley balloon. That's how we identify the bladder neck. So this is the anterior bladder neck, and now we're going for the posterior bladder neck, converting this she into H-shape incision. So this is, we are taking down the pedicle on the left side, and this is very important that you manage this pedicle early so that there is no bleeding. Your vision remains good so that your nerve sparing will not be hampered in the later stage. So very good meticulous hemostasis is very important at that particular stage. So this is we are doing. Now we're going for the posterior dissection. Now, as we know, because we already dissected the posterior seminal vesicles and vas deferens in the first step, this step's really, really very easy. Even in the locally advanced prostate cancer patients or high-risk patients, the steps becomes easy for us. So this is the posterior dissection. We are just doing the final steps, separating the final flimsy attachments from the seminal vesicles. And this is on the right side. So again, taking down the pedicle on this side, on the right side. So this pedicle is very important, as I said, to have the good hemostasis. You can use titanium clips also, depends upon the surgeon's preference. I use more of Humalog clips, but titanium clips can also be used. And once you have taken care of this pedicle on the both sides, then we are now going for, this is the posterior dissection. Already we have done in the first step, but here again we are trying to see if there is anything left. Now we are going for the neurovascular bundle preservation. So we are doing the high anterior release of neurovascular bundle, releasing the bundles from anterior aspect. And again, it is totally athermal. We don't use any cautery here. We use metallic clips so that we have good hemostasis. And as you know, the neurovascular bundles, they travel right from the base up to the apex of the prostate. So we try to preserve those right up to the apex of the prostate, and again, a totally athermal manner. So even in the high-risk prostate cancer patient, this is the interfascial dissection we are doing. Try not to go very close to the prostatic capsule because that will have positive margins, especially on the right side, because you know this patient on the right side has got a lesion. So in this patient, especially on the right side, we stayed interfascial, not too close to the prostatic capsule. Again, interfascial athermal and no cautery to be used. And we did bilateral nerve sparing on both the sides. Now, a DVC suture, I normally put a DVC suture before cutting the DVC because that will minimize the bleeding, keeps the vision good, and I know what I know, and I can see where I am cutting. So I think for all beginners, it's a good idea to first ligate the DVC and then go for the cutting the DVC. I use 2 V-lock suture, as you can see there. Now, this is a very important step because I am doing the apical dissection. The 2 points is, one, you have to preserve the good intra pelvic urethral length, as you can see we are trying to do. And second, you want to avoid any apical margins, because if you're not careful, as you know, the anatomy of the apex varies from patient to patient. You have to be very careful about the apex of the anatomy and try to preserve not only the interpelvic length, but also avoid the posterior margins. So you can see we have preserved here around 1.5 to 2 centimeter interpelvic urethral length, which is very good length. And this is we now cutting the posterior epic urethra mucosa here, and now the prostate is free. Now in this particular patient, the prostate was not too big, so we did not have to do the bladder neck plication. But if it requires, we do the modified transverse bladder neck plication in all the patients, putting a stitch on each side. That's how we do. Rocco stitch we use in some patients. We are showing the bilateral preserved neurovascular bundles on each side, right from the base up to the apex. And this is all interfascial because this was a high-risk prostate high-risk patient, so we remain interfascial. And this is the anastomosis we have started now. This is typical modified von Wellthausen technique. We use 2 3-0 V-lock suture, 15 centimeter long, joined in the midline, starting from 5 o'clock to 10 o'clock. This is a clockwise direction, and you see how we're trying to remove the this needle from the urethra. Never push it. Always try to rotate it out so that you don't tear it out. And Rocco stitch, no, in some patient I use Rocco stitch, especially if I feel there's a lot of tension between the bladder and the urethra part. But in some patient, we can get away without the Rocco stitch. So here we have not doing the Rocco stitch. And now we are completing the first layer from this 5 o'clock to 10 o'clock. We all know that because of the robotic, the suturing is very, very easy. Now we're starting the second layer again from 5 o'clock to 10 o'clock in anti-clockwise direction. And the beauty of robot, as we know, that we can actually see wherever we are taking out the suture, and we can use a bi-manual suturing. You know, on both the hands, it becomes very easy as compared to a laparoscopic suturing. And now we are going to just finish the anastomosis part. So once we finish the anastomosis, I always put a knot. Some people say because it's a V-lock, you might not put a knot, but I always put a knot. And then we check for the water leakage by distending the bladder with the normal saline. And we always do that. As you can see, we're doing the saline distension. There's no leak. That confirms it's a watertight anastomosis. And then finally, we go for the lymph node anastomosis, lymph node dissection. We always go for, in a high-risk patient, extended pelvic lymph node dissection. Is on the left-hand side. Right now, we are dissecting the obturator group of lymph nodes, all the fatty tissues covering the obturator nerve. We remove them. There are sometimes obturator vessels going along. You need to preserve arteries, but vein you can take can clip along with the lymph nodes. And here, I think you should spend more time because most of the complication happen during this particular period. Obturator nerve, you have to first dissect it out throughout the course so that you don't injure the obturator nerve. So in this particular case, we are doing the obturator lymph node dissection right there. And this is the complete template on the left side. Because of posterior time, I'm not shown the full lymph node dissection. And similarly on the right-hand side, this is the complete lymph node dissection. So that will complete the procedure, and that's our specimen. So thank you very much for your patient listening. And we can move to the next speaker. Thank you, sir.
Yeah, Anup, I thought we'll take 1 or 2 small comments in between as well. And I would like to know from you that in a case like this, is there a real advantage of doing posterior approach? Because historically, there has been a debate between the surgeons who prefer anterior versus the posterior. And the evidence-based literature suggests that if there's a very large median lobe, definitely, or even a very large gland, more than 100 or maybe 150 like that, there is a definite advantage with the posterior approach, right? So in a high-risk tumor, do you think there is any real advantage, or your comments?
So Yes, sir. So a very good question, sir. See, I prefer posterior approach because of two reasons. Number one, we normally see very locally advanced and high risk patients having extraprostatic extension. Most of the patients, very lucky to have a patient with a localized prostate cancer and not having the extraprostatic extension. So when I do the posterior approach, one thing I am pretty clear that the rectal part is already dissected out. Plus, we are belonging to a teaching institution. I'll try to train my younger colleagues, and I want to train them in one technique only, so they can master this technique. So although I was trained in anterior approach by Dr. Patel, but subsequently I found because our patients, they're different from the Western patient, and therefore I modified the technique to posterior approach.
Thank you. Dr. Srinivas, are you around? Dr. Srinivas Samvedi. I don't think he has joined.
Ganesh has joined, so Dr. Ganesh has joined, so you can carry on with the next speaker. Sir.
Okay. Thank you. Then may I invite Dr. Sudhir Raval. He is the MD with the Rajiv Gandhi Cancer Institute and a big giant in the field of uro-oncology as such and in robotics. So, Dr. Sudhir Raval, please.
Thank you, Dr. Anish. And can you hear me, sir, and see my video?
Yeah. It's fine.
Okay. So my topic is reduced sparing radical prostatectomy and a step-by-step guide. This is the surgery which we are doing regularly in our institute. Almost 60 to 70% of the cases of robotic radical prostatectomy, they'll end up with this technique. You can see these are the robotic ports. And then we go ahead with the dissection. These are the landmark, Foley's, rectocycle pouch. And then sometime you do have the sigmoid coming in the way. You have to use Pensadora stitch to take the sigmoid out of the pelvis. And once this is done, we use three instruments. And this is the video which has been compiled with multiple videos done in our department by some by me, some by Amitabh, and some by other surgeons. You will see the change of the instrument and change of the some technique also. So we take VOS difference. Once it is done, we dissect the VOS difference and the seminal vesicle first, so that they can be hitched up with the sutures. But if you are using the fourth instrument like Progress, there is no need to take those sutures. These are small vessels of seminal vesicles which will be taken many times. I generally don't prefer to take them. I just buzz them and cut, but it's surgeon's preference. You can take them with the Liga or with Hemlock. So once you have dissected seminal vesicles, one can put a stitch of 30 monocle with a straight needle so that you can retract the bladder and also the seminal vesicle and VOS. This helps in avoiding one instrument. Actually, you need not to use the Progress because of this. They are hanged with the suture on either side, on respective side, right and left, and then you can pull and then the vision becomes better. Posteriorly, you can see seminal vesicle up and denominal fascia. Now, we do the extrafacial, interfacial, and intrafacial dissection with this technique. This is first thing which I'm showing is extrafacial, where you can see that prerectal fat is here and denominal fascia has gone up. Then it comes the interfacial, where you can see the layer of fascia is with the patient, and prostatic fascia is up and denominal fascia is down. And in third, we'll go for intrafacial, where it is really you are onto the prostate. You can see the capsule of the prostate. This can be done easily when you are using this technique. Once you have done the dissection up to the apex, you have to go to the pedicle, they automatically get defined. You have to go to the lateral pedicles. They are just below the seminal vesicles. And you
You can take them with either ligature clips or the Hemolock. Make sure that at this time, the small vessels are taken. If you don't take them, then there is a bleed. This is on the left side, which sometimes is tricky, but with practice, it comes out easily. You can divide it into two. Many times you can see levator ani from here only with the fascia on it and can dissect the neurovascular bundle. You can see that levator ani with fascia. And then you can drop down the even neurovascular bundle from this dissection right here. You need to do that if you're doing in nerve sparing. You can see the levator fascia and then preserved neurovascular bundle on one side. In extrafacial dissection, you can sacrifice the neurovascular bundle and you can go right onto the levator ani. Then we go to the prostatovesical dissection. After you can see that levator ani here, there is no extra prostatic, there is no levator fascia. Once you have done this, you release the seminal vesicle and vas on both sides and then dissect onto the prostate. It sometimes looks tricky, but if you go with some traction and diathermy, and in between you do the cold dissection, the pushing the bladder up, ask your assistant as he's doing that with the suction. This is very easy dissection. The plane, they come out on its own. There is no need to go into the bladder or anywhere. You just have to see the bladder fibers and the prostate. Sometime you can have the big median lobe, and that's not contraindication for this technique once you are experienced. But if you in the beginning you probably may avoid, but it's very easily doable. You can see the catheter here from posteriorly. There are anatomical variant like hypertrophy central zone and the base of the prostate. There's retrozer muscle, and the plane actually comes out with the traction, with some diathermy dissection and the cold dissection. I love doing cold dissection more here, but my other team, they do mainly the hot dissection, which my dissection will be having a bit more bleed at this point of time, also at the apex. You can see this is the median lobe, big median lobe, which can be easily removed from this side. One has to be careful that not to make a big hole in the bladder neck, especially on the posterior side, because only problem with this technique is you can't see the ureteric orifice. So once you have cut the posterior part of the urethra, you need to take a stitch, which can again be pulled and holded by up, and then you go to the anterior part. This can be done with the diathermy. I generally use 0 degree till I remove the prostate. Once I've removed the prostate, then I take the 30 up. This dissection, either you can use the hot shear or you can go for cold dissection. Once you cut, you can just make a flip, just a movement, so that as you are pushing the bladder up, and the bladder goes up. There may be some pumpers, some small breeders, which you can buzz separately. Especially, and here is more important not to use the diathermy because you're at the apex. So now we go for preservation of the dorsal venous complex. You can see how it's easily, prostate is here, the complex is up. We have not opened the DVC. Here the urethra, you can take good length of the urethra, as Anup has already emphasized that urethral length has to be good. You can see a groove here, which is the landmark. And once you cut the anterior part and then go for the posterior part. You can see here there is some bleeding is there. The field is a bit bloody, but then that's the thing. You don't worry about this. Just it stops once you remove the prostate, and after some time there will be hardly any bleed. go for your vesicuretral anastomosis, which starts from 12 o'clock, is reverse. There is no need to suture the DVC. Sometime you may have to take 1 or 2 stitch. Also, you can take the Roca's stitch if you want. Like here, it has been taken. You can just approximate the posterior facial layer. Here, bladder, actually, you need not to put the bladder near to the urethra. It comes on its own. So there is no need to do that thing. But if you classical Roca stitch can be taken in this technique also, that may not be necessary because the continence, return of continence is excellent. Most of the time, when you remove catheter, these patients are continent, or when they come after 6 weeks, they do very fine. They do fine. Only thing is tricky is when you are doing post anastomosis, when you come laterally, the movement you have to learn. I have seen the young boys when I give them this anastomosis, they many times land up with the tearing the bladder neck or urethra because there is a special it's a special movement which you have to learn. And in our center, we don't use 2 needle holders. We use either fenestrated bipolar or Maryland. So that is another thing which sometimes can make difficult anastomosis for youngsters. But once you practice this, is one of the easiest thing to do and very gratifying for patients. There are some places where we don't do it. I'll tell you in my last of the part. There's only few, maybe a minute or so. So so once the anastomosis is done, you put the catheter and you fill the bladder and just make sure that there is no leak. You can see catheter going up. The movement will be there. Like catheter is going up. You inflate the balloon and then you inflate the bladder. Yes, the bladder is inflated. You can see the leak. These are the contraindication, or we are careful when there is a bladder neck infiltration. We will not do this approach. Anterior prostatic disease with extension into the detrusor apron, we will not do this technique. Extensive disease involving the prostate with extra prostatic extension, better to go with anterior approach. And then the large median lobe, in the beginning, you may not do, but you can definitely do later on. Also, the post-TURP or HOLEP, I have a video in YouTube channel also. We have done in those also, but better to avoid in the beginning of your learning or doing this technique. Thank you. Thanks a lot.
Thank you, Sudhir, for an illustrious talk. And do you think there is any difference in the lymph node yield, sparing
No,
versus?
No, we do lymph node as we do it for anterior approach. There is no difference.
Yeah, that's what, there was a question in the chat box. And Dr. Ganesh, would you like to give some comments?
So Dr. Gupta is joined, sir. Dr. MP Gupta is joined.
Okay,
sir.
okay. Yeah. Ganesh, please.
Sir,
anything
I
you would like
to ask one question? Like sir said, initially they were doing posterior and a little bit of anterior approach, and now almost 95% are Regius sparing. So what actually made you do that change?
No, not 95, around 70% of our cases, they land up with Regius sparing because we evolved the technique, and you see we can do extrafacial, and we are confident that now we can give the good results with this technique. But we still do anterior approach. As I have shown you in the first 3 indication, we go for anterior approach. Like if we do 4 radical prostatectomy in a day, 3 will land up with the Regius, 1 will be the anterior.
Okay, and no posterior approaches now?
No, posterior approach is there. When we do anterior, we first go for posterior, as Anup has shown. We do that dissection and then drop the bladder.
I asked because most of us do as Anup is doing. I mean, posterior approach.
No, that's the standard. We do first posterior, then drop the bladder.
Sudhir,
Sir.
now you have enough experience of 4 or 5 years of doing this procedure. Tell exactly the advantages of this Regius sparing, what you have seen in your series.
Sir, as I said, that's very gratifying the patient to see when he's in OPD, you remove catheter after 8 to 9 days, and he's continent. Almost 15 to 20%, they are continent immediately. And then most of these patients, when they come after 6 weeks for first PSA, they are very satisfied with the continence. There will be very few patients who will not be doing exercise and they actually do not recover continence so early. So that's the best advantage. The return of continence is very early.
So only early return of the continence is the advantage.
Yes.
Otherwise,
Yes,
long term, 6 month or 1 year results are going to be the same.
The same, correct, sir.
Okay. Now it gives me great pleasure to invite the next speaker. And may I request Dr. Ash Tiwari. Dr. Ash Tiwari, have you joined?
Yes, sir. He's there. He's there, sir. Yes.
Hello.
Hi, can you hear me?
Yeah, Dr. Ash Tiwari, this is Dr. N.P. Gupta. Friends, Dr. Ash Tiwari doesn't need any introduction because he is one of the pioneers who have made a tremendous research and thoughts of doing the robotic radical prostatectomy in a different way, and he has made several modifications. It has brought this operations to a different standard. I think so. His work is well known all over the world, and today he is going to talk about the nerve sparing in radical prostatectomy. Dr. Ash Tiwari, please.
Dr. Gupta, thanks for allowing me to share my thoughts on the nerve sparing. And instead of looking at the theoretical aspect of nerve sparing, I'm going to share a video, and I will forward fast it because it is one of the live surgical videos. And that will give a perspective as to how I am approaching this operation in terms of nerve sparing. Important thing to remember in prostate surgery is that you have to be prepared that there is a possibility of an extra prostatic extension, as Dr. Rawal has mentioned and Dr. Gupta has mentioned before, that depending upon what population you are operating on, anywhere between 15 to 30, 40% of the patients may have extra capsular extension.
Sorry to interrupt you. Please share your slides, please.
I think you should be able to, I am sharing it. You should be able to see it at this point. No? Can you see it?
Yes, sir. Right.
Yeah, now we can see it.
Okay, fair enough. You are still seeing it?
No, it has disappeared, Ashutosh.
Okay. I see that. Okay, give me a second and I'll make it work. Let's see if this is visible now.
Yeah, it is.
Okay. So my point was that nerve sparing robotic radical prostatectomy has always to be balanced with risk of extra prostatic extension. And the three things are competing with each other: the positive margin, continence, and sexual function. So I do radius sparing. I do conventional anterior approach robotic radical prostatectomy, and sometimes I do a modified version of what we call a tunnel anterior approach, in which I try to save or mimic what we normally save in an radius sparing approach. So what you are seeing here is an intermediate risk prostate cancer, and he is a good candidate for nerve sparing. So first thing I'm doing is to just making a minimal incision anteriorly and finding the bladder neck here. You can see that I have basically opened up a little bit of in front of the prostate and the sides on both sides. And I will get to the bladder neck here.
So I made 3 courses for.
I will lift up the catheter. I will develop a plane posteriorly, depending upon the size of the median lobe. If there is, the bladder neck can be small or big. Everything is being done from an anterior aspect. I have not opened the cul-de-sac pouch of Douglas. Right now, I'm about to incise what we call retrotrigonal layer, which is present behind the trigone and attaches to the prostate in front of vas and seminal vesicles. I will see the front of the vas deferens. I will lift up one vas followed by the second one, dissect it out. I will work on left seminal vesicle first. I will approach it from the medial aspect. There is a plane, what we call a medial avascular plane. I will develop that plane. At this point, seminal vesicle will be attached mainly at the tip. I will get to those vessels and a clip will be applied in there. I'll do the same thing on the right side. I will develop the medial avascular plane. Once both seminal vesicles are up, I will find a plane behind the prostate. I will make an incision into the denominal fascia, depending upon whether I want to be in a grade 1 zone or a grade 2 zone or a grade 3 zone, which we have published before. I will develop a plane behind the prostate. Understanding the planes is important, and I will go as far as distally as I can, and I'll make a little bit of a lateral extension. A good assistance is of a lot of value at this point, and I have someone who has been with me for last 15 years, and Mr. Roy Berryhill, and he understands this operation. He is very subtle, very delicate, and he will help me in getting a retraction or getting the clips applied. As you can see, I'm getting to the point of coming behind the prostate in the apical zone. We have talked before that the neurovascular bundle or neurovascular tissue is more in form of a hammock, and at the base of the prostate where the pedicle is, there is a triangle made by the denominal fascia, prostatic capsule, and the lateral prostatic fascia, and getting into that from medial to lateral is the key. I saw very good dissection in this zone by Dr. Rawal just in the previous talk, and same way I'm trying to develop this plane. It takes a little time to get the medial vessels taken care of, and I'm developing the plane on the posterior aspect, marching slowly on the left side. As you can recall, I have yet not opened the endopelvic fascia. I have not gone into the pouch of Douglas. Entire release of the neurovascular bundle is from the midline to the apex and from midline to the lateral aspect, starting at the base. Depending upon how much inflammation prostate has, you can find a real good plane. Sometimes there may be a small blood vessel. I'm a believer of focusing on nerve sparing and keeping apex under vision. So I like doing things little more deliberately and at the apex, seeing everything what I'm doing. There are usually perforating vessels at this point, which are tethering the prostate to the prostatic capsule and the surrounding area. What you are seeing is the entire neurovascular hammock is kind of spared underneath, including the veins. And now I will be twisting the prostate to the opposite side, to the contralateral side. And essentially, whole of the tissue has been separated and only it is tethering with the endopelvic fascia and the anterior part, and you can see the catheter is being advanced. I'm a little liberal in using some cautery at this point because this is the front of the prostate, but I'm developing the plane, and this is kind of the same plane which we normally, or I would normally use when I'm doing a ridge sparing approach. We have done some anatomical studies and we call this tissue as in hood because this is comprised of fibroconnective tissue, the venous plexus, some muscles, and the diffuser apron. And this paper was published by Dr. Vinayak, and it came in as in Surgery in Motion recently. Once I have done this part, I will go and work on the opposite side. The same thing will be done. Now at this point, what you are seeing that the whole prostate has been released from the posterior lateral aspect. Everything has happened from midline, and prostate is being tethered by this, what we call a hood. Hood is the anterior supporting tissue, which absolutely has a significant role in continence. And depending upon how close prostate is to the anterior fibromuscular stroma, sometimes we can decide to be superficial to the vein, sometimes we can be deeper to the vein, sometimes we can be through the vein. But this allows me to be very deliberate in what I want to save. And as we have mentioned before, we have a nomogram which predicts the likelihood of an extraprostatic extension in different parts of the prostate, right, left, anterior, posterior, base, apex. And I can tailor and change the surgery based on what I'm dealing with in that individual patient. I will put in a suture here at this point. I will try to save the membranous urethral length along with the striated sphincter and all the supported structures, including the pivoperinealis muscle and also the anterior diffuser apron and pivoprostatic ligament. At this point, I will put in an anchoring suture, which helps me in ultimately finishing the anastomosis easy. This suture is very deliberate under vision and allows me to have exactly where I want the suture to go. And even in a difficult anastomosis, this suture becomes a lifesaver. At the end of it, while prostate is being examined for the neurosave, I will do a modified version of what we call Rocco Pagano and a little bit of our own institutional modification, that we will bring everything together Anastomosis will be done using the same suture which I had parked before. If there is a little bit of an oozing, I would use in some kind of an hemostatic agent. Once I have put in 2 on the right and 2 on the left using this double arm suture, I will advance the catheter inside the bladder, and anastomosis will slide down It's important to make sure that I'm not holding the bladder itself by the 4th arm. Once this is done, we just run the anastomosis through right and left, and it is finished. It looks a little bit like this. And if needed, I will do the anastomosis. I will do the lymph node dissection if needed. So this is our technique of doing what we call an anterior hood approach of robotic radical prostatectomy and the nerve sparing. I do about 3 every day. Not every patient is a candidate for this thing. If it is in more pronounced anterior apical tumor, I will not do it, but most patients tolerate this procedure very well. I leave the catheter for about 5 to 7 days. And when we look at it about 6 weeks, the continence rates are pretty comparable to any kind of an continence preservation technique. It has an benefit of being able to recognize the ureteric orifices. We can see the median lobe without any problem. I can change the operation based on extracapsular extension discussion. I can make the operation left side different versus right side different. We can have a left side hood versus right side hood. And a lot of people are very versed with this approach, meaning coming from the anterior aspect. But I'm not an advocate of one approach. Depending upon the patient's own characteristics, I may choose to change the operation. But this is what I wanted to share, and this is one of the live surgeries, so I thought I'll just run it through. My time is just up. Thank you very much.
Thank you, Dr. Ash Tiwari, for an excellent demonstration, step by step, showing the fineness, how you are handling the tissue and all that. I think so. This is an excellent demonstration. I'd like to put you one question. Why you have to put such a big stitch at the dorsal venous complex? Why don't you cut it first, see the individual vessel, you can ligate that instead of putting such a big stitch there actually, because that is your whole concept is based on the anterior hood, and there are a lot of nerves and veins are there.
I think it's a very good point, and sometimes we do end up not putting in a stitch in the beginning and later on just ligating the open venous sinuses. And you're right, mass ligation can have in more necrotic tissue. That's a good point, and I will consider that more often.
Thank you very much.
Ashutosh.
Hi, Anish.
Hello. So I am your student for robotic prostate since 2008. But anyway, I got a chance to do the same for last couple of years, as you know. So students very often ask, because a lot of students must be there in this crowd and the young urologists, your grade 1, grade 2, and grade 3. So I would like certain clarifications, because the textbook of Campbell writes interfascial and extrafascial. So I think, are they more or less similar? Grade 1, 2, and grade 3 versus intrafascial, interfascial, and extrafascial.
I think it's a very good point, and maybe I wanted not to get into this, but this is what, can you see this?
Yeah.
So grades discussion is based on, so first thing is the prostatic capsule. And outside the prosthetic capsule, there is a prosthetic fascia. And after that comes the artery and vein. And then comes most of the loose areolar tissue. And when you look at this, I want to show you this video. Maybe this will show you that can you see the planes?
You're right.
I'm beyond my time, so I'm sorry.
No, it's all right.
But you can see that sometimes I can show you the 3 layers, and it looks like that Anish, I primed you to ask me this question because I had a video ready, and then you are my friend. I know that. But I can show that there are 3 layers, and you can approach the layers if you understand that there are 3 layers. So this vessel is on the specimen, and that is a grade 2-ish plane. If you go deeper to that, then you are in a grade 1 zone.
1, exactly.
So you can see the scissors where it is right now is grade 4.
Right.
The in-between plane is grade 3. And where I am developing is a grade 2 plane. And if I am deeper than that, that is a grade 1 plane.
Exactly. So the video which you showed in your talk was a grade 2.
Grade 1-ish. And then I have this is a grade 1. If you want to see the grade 1, this is the grade 1.
Yeah. So the one which you showed, I mean, earlier in your entire talk was grade 2.
Yeah. I mean, and then you can
kind of
at the apex, I try to become grade 1 more because apex is where most of the things matter. So you can see that you can choose to be grade 1 in the base or grade 2 in the base, depending upon where the cancer is, but you can appreciate it here.
Brilliant, clear demonstration. See, that's what most of the students, they keep asking us because being
But
teachers,
if in doubt, leave go through the veins, even we can, so you can see that there is a plane being developed and I'm little concerned that there is a perforating vessel here. And should I cut it? Should I go deeper? And if I make a sharp dissection, I will not open a flap.
Right. Brilliant. Very good.
But the veins are a good landmark because
they are a good landmark. Yeah.
So if you are seeing levator muscle on the right side and everything else on the specimen, you are in grade 4. If you are seeing prosthetic capsule and veins in the prosthetic capsule on the specimen and vein on the body, then you are grade 1. Grade 2 is when you are either through the vein or just kissing the surface of the vein and vein is still on the specimen. And grade 3 is the most subjective one. I mean, I think that's a gut feeling comes. But here
another doubt which I answer as that when you do an extrafascial dissection, that is the only time when you open the denonvillous fascia. In interfascial and intrafascial or grade 1 and 2, you don't open the denonvillous fascia. Is that right?
You don't have to open unless and until there is a mobility issue or prostate is very big.
Yeah, I think this is these are the questions.
2 different planes you can see. If I go to the deeper plane, I may get into the BPH plane or grade 1 plane.
Very nice. Great. I think
this
all
is
those who are
this
watching
is
have understood.
Between grade 2 to grade 3. And for a disclaimer, when you say you are my student, you taught me urology.
33 years ago, but I am now learning from you. Anyway, let's go to, is Dr. Hemal around?
Next is Dr. Janak Desai. Dr. Janak Desai will be the next speaker. Please invite him, Dr. Janak Desai.
Okay. So Dr. Janak Desai, once again, he doesn't need a big introduction, and all of us, and I think entire world knows him for his the MIP, a development in the area of mini PCNL, but he is now equally into robotics. So Dr. Janak Desai, please.
There is something coming on my, okay. So thank you very much, all the pundits of robotic surgery. Here is a relatively age-wise a bit old, but experience-wise a kindergarten student who graduated from open surgery to robotic surgery. And therefore, I would like to call this the ordeals I went through during my kindergarten days of robotic prostate. I had done almost 500 open radical prostates, was very comfortable with it. And at that time, the general consensus was that a well-done open was equal to a well-done robotic surgery. And a lot of data started coming in from the Western world. And this was one of the papers coming in from Australia, a randomized controlled phase 3 trial in which they concluded that please go to a surgeon that you trust rather than a technique. And therefore, we went on doing open surgeries, but the tide of robotic surgery was becoming very strong, and it was imperative to embrace robotic surgery, which I did. And now with a bit of experience of roughly 50 robotic prostatectomies, I'm just putting forth my graduation from open surgery to robotic surgery. The vision, of course, is one of the most important point of the advantage of robotic surgery: extremely precise, very enlarged vision compared to the open surgery. But the challenge was the tactile sensation. There is no tactile sensation, and everything is vision based. So that is the initial challenge that a surgeon like me who was graduating from open to robotic would have to face. The most important point was that the blood loss was minuscule. The blood loss now in my hands is less than 100 ml, whereas a couple of units in open surgery is almost mandatory. So let me bring out a few things, a few mistakes that I made as I was graduating to robotic surgery. Dropping the peritoneum, which is the most important, the initial step. People do it in different ways, but I do it in the most popular way: cut the median ligament and then make my way towards the center and then drop the central part. So let me run a video. All the mistakes that I did, these are my own videos in which, in this case, I'm cutting the median ligament, the standard approach: pull the median ligament a little bit and then cut the median ligament, drop the peritoneum. As we were taught to drop the peritoneum, cut through the loose areolar tissue. This patient was lean, there was not much of fat, very little loose areolar tissue, and I went in making sure that I should not damage the prostate, my third case, sorry, not damage the bladder, my third case. And I was watching this loose areolar tissue, as you can see here, but this was loose areolar tissue between the fat and the posterior sheath of the anterior abdominal muscles. And very quickly we realized that that was the wrong plane. This actually was the loose areolar tissue which had to be cut to drop the bladder. And then I started making my way through the real plane, the actual plane, which is supposed to be dissected onto the way towards the pubic bone. But by that time, a lot of air had seeped in those fascial planes. And I used to operate, even today, I operate with a pressure of 14. Experts I know operate at a pressure of 10 and 12. But just to be a little careful about the bleeding, the pressure that I'm used to is 13, 14. And this had already made way into the thighs and the abdominal wall. Next day in the morning, the patient complained of crackling sensations on the abdomen and the thigh, an avoidable complication, and which of course did not do any harm to the patient. But of course, you should be able to avoid this with a little bit of experience. So then I had learned that going too much anterior is not a good idea. So it is always better to be somewhere in the planes. So on my 7th case, I ended up with a mistake where I was too low. Again, a very thin lean patient who was operated for a bladder stone in the past, and when he was young, and he presented with this cancer prostate. And I was now trying to go a bit too low. And in that process, you can see that that going too low also is the issue. The bladder was very thin wall bladder, and lo and behold, there is a rent in the bladder. And to confirm that there was actually a rent in the bladder, I made the rent larger by making sure that I wanted to see the Foley catheter, which you can see here. So that was a rent in the bladder. Well, then we made dissection in the right plane. So this was now going in the right plane, dropping the bladder, and very thinned out bladder, very minimal loose areolar tissue. So we were now in the right plane, and finally a suture on the bladder wall. Everything went off well, but unnecessary waste of time, a little bit of adrenaline secretion, and finally the patient did well, but this is an avoidable complication. Now, one more problem that beginners would end up doing is we are used to those excursions of open surgery when we take a suture and we can move the arm very easily all the way up outside the body. So there is a lot of excursion of the hand movements, but deep inside there is very minimal movement, and I had caught the tissue, the suture a bit too much far away, and in the process hit the wall. And you can see a fair amount of bleeding from the pelvic wall. Before you can exchange the instruments, you can't do any cauterization with the needle driver. So we exchanged the instruments, a cautery was done, the bleeding was stopped, but unnecessary loss of almost 40-50 ml of blood. So the point to be learned here was very minimal movements when you are in the deep pelvis doing the anastomosis. This is one more complication. Again, the vision is, of course, should come to your rescue, but here it was going against me, a 0-degree lens, and I was trying to separate the musculature from the pelvic muscles from the prostate, and in the process unnecessarily going too much deep, because the vision is so nice, you feel that you are doing the job so neat and clean, and here you go, you end up damaging a major vein. I was very close to the pelvic notch. The notch between the prostate and the urethra should have stopped there, but went deep inside, creating unnecessary bleeding, went on struggling hard. In the process, lost almost 150 ml of blood. The mistake was I had still not cut the puboprostatic ligament, as you can see here, and unnecessarily went deep. This was actually the place, the notch, where I should have stopped. And this was finally stopped by putting a gauze piece, and a suture was taken at that point to stop the bleeding. A loss of blood, as I said, and a loss of almost half an hour of dissection time. One more complication which happened in this patient, we advised him to undergo biopsy. He wasted time. He came again after a year. By that time, the malignancy had spread a little bit. It had gone into the rectal wall, which was already picked up before the surgery, the loss of fat plane. We told the patient we may have to shave a little bit of the rectal wall, which is what we did in this case. Let me run the video quickly, which is what we did. And in the process, when the rectum was damaged, we tried to close the rectum. So here we go. The prostate was separated, but that little bit of tissue which was going in the rectum made some maneuvers to remove the tissue with minimal damage to the rectum. But in the process, the rectum was damaged. I can show you in a while. This is the damage to the rectum. And the message that I want to give to the juniors, my talk is mainly for the juniors, the extreme experts like Ash and Vip, and they are going to show you some very, very advanced techniques. There are a lot of juniors waiting to embrace robotic prostatectomy. And here is one guy, a relative junior in robotic, trying to tell you the mistakes he made. So the rectum was closed. The mistake that was done was a single layer repair. We talked to the gastro guy and he said it's a clean, neat, sterile situation. So don't worry, just close the rectum. No need of doing a diversion. And the mistake done was a single layer. We should have done a double layer. I'm told that people do a 3-layer repair also. This patient ultimately had a fistula from the rectum to the bladder, and we had to do a diversion for this patient. The fistula was closed, the diversion finally reverted, the patient is doing well. So a few mistakes, but I was determined not to make a very major mistake like cutting the obturator nerve or taking a cuff of the external iliac vein. I've seen videos of those kind of complications as well. And before I end, some pearls of wisdom to the juniors. A smooth sea never made a skilled sailor, so don't worry. And you want to know the difference between a master and a beginner? The master has failed more times than the beginner has ever tried. And finally, a correct decision can double the confidence. A wrong decision can double your experience. So I was adding to my experience in the earlier days. Thank you. Thank you very much.
Yeah. Thank you, Dr. Yes, Dr. Gupta, please go ahead.
Yeah. Dr. Janak Desai, I think so you have made an excellent presentation. And I tell you that we all have done the same, we have seen actually the same complications in our early days also. So nobody has become the master without having any complications. Even my teacher, mentor, Dr. Sarinder Man Singh used to say, if a surgeon says that he has no complications, means he is telling lie or he has not done any surgery. So I think so your presentation was excellent. This is a very good message that robotic radical prostatectomy may be looking very simple on the hands of the experts, but this is a very highly technically skilled operation. It has got 10 steps of the surgery and every step has to be done meticulously. Robot doesn't do anything. Robot is a slave. It is the surgeon who has to decide where to cut, what not to cut, and that judgment comes only with experience. Thank you, Dr. Janak Desai, for your presentation. And now the time has come for the star talk, and it gives me great pleasure to welcome Dr. Anup Patel. Is he here, Dr. Patel?
Dr. Vipul Patel.
Dr. Vipul Patel.
Vipul Patel is there.
Yes. Yes, Dr. Vipul.
You already forgot me?
Yeah, Doctor. Hi, how are you? Vipul is another stalwart in the field of the robotic radical prostatectomy, and he has worked very hard from, I know, from the year 2002 or 3 onwards when he started doing, and he has also done a lot of work in this field, lot of new techniques, new approaches, and he has a vast experience. So we are lucky to have him today with us, where he is going to share his experience of 15,000 robotic radical prostatectomy. Dr. Vipul Patel, we welcome you and please start your talk.
Yeah, hi, good morning. I've been watching. It's very good. Great meeting. Anup, congratulations. Yeah, I enjoyed Janak's lecture. And to be honest, if you're starting and you're not like a super expert, that's actually the one you need to listen to. I think, you know, the more and more of these we do, we see the oncology is changing. You know, it used to be that we had a lot of low risk, but now everyone's high risk. So I think showing these beautiful, you know, dissections of the nerve, it's great, but it's only practical in probably 10% of patients these days to do something like this. So I'm going to balance my presentation. I'm going to show you what we learned in our 15,000. I'll talk to you a little bit about how did I do a nerve spare, but then concentrate a lot on partial. And the reason is that's the reality. In most people, you're not going to do this beautiful nerve spare these days because that's not what we're seeing oncologically. So that'll be pretty much my lecture. Let me see if I can share my screen. Do you see my screen, guys?
Yeah.
Okay.
Yeah, we can see you.
Yeah, so you know, obviously our team has a lot of experience. We've done a lot of these now, but really it still comes down to the fundamentals, and that's what I really want to review. How did we learn it, and what have we learned from our experience overall? That's pretty much my lecture. I think very important is if you're going to do a large volume of these, make sure you have a good database, make sure you have good clinical people who are following these patients. If you don't have data, then it's hard to really learn and make conclusions other than very preliminary conclusions. When we first started, it was back in 2002. I remember Janak and Sanjay Kulkarni, they came to visit me and spend some time, and they visited me along the way. And when they first came to see me, this is what we were looking at. We didn't know. I was trained in open and laparoscopic, but we didn't really know if robotics was going to make it. However, the reason we survived is the complication rates stayed low. I agree most of the big complications occur early, but they never go away. You know, you're never going to have 0% complications. You're always going to have some guys with DVT and ileus. The bigger complications go away, and then they actually come back later because you're operating on cases that nobody else wants to do or can do. And you're the expert, and they're going to send these to you. So there's kind of an up and down on the curve. The other thing we looked at initially was the margins. We were not sure oncologically how robotic surgery would do. And this is one of our earlier publications showing that at least for organ confined disease, it was reasonable. And the margins have stayed constant. And I think our results are better now than we were doing with open or laparoscopic. So these were the two things that I think allowed robotic surgery to survive. After that, then we started to innovate. You know, first it was safety. We had to make sure the patients were doing well. Then over time, these are all the different steps that we've published on, and pretty much everything we publish on, we still do today. I tend to do a few thousand cases of something before I publish it, because I want to look at the data and make sure that I'm sharing something with you that is reasonable and something that I think is valuable. And so all of these things have happened over the last 15,000 cases, and we've progressed to the operation we have now. This is one of the Walsh diagrams here on the left side here, and he shows the nerve bundle. And I think, doing a normal prostatectomy and just getting it out, I think that's easy. The challenge is how much to spare and how to spare. And that's very important. Not every patient needs or can have a perfect nerve sparing these days. And so you have to learn all the different types. Obviously, there's many ways for you to damage the nerve bundle. Some people look like they're doing a great, dissection, but then they're grabbing the nerve with the bipolar, or they're using too much energy. Or at the beginning of the dissection, if they're doing an antegrade prostatectomy, you'll often see they put the clip too low and they've taken part of the nerve bundle. And that's why we've gone to more of a retrograde, not so much an antegrade approach, because in the antegrade approach, there's always a chance, especially in smaller prostates, that you've clipped part of the nerve bundle before you even see it. So this is a very important thing to know. We all like to see this. We all like to see our what we call train tracks. You see the urethra at the top of the picture, the bladder, and then you see these nice nerve bundles. And if a patient's low risk and if they're potent, these are some of the things we like to see. And this is how we did it for many thousands of cases. You can see the accessory pudendals, you can see the levators, and then you can see the rectum. So the retrograde dissection, I thought, gave me the best ability to do a nice nerve spare. And that's because if you release the nerve from below and then anteriorly before releasing the apex or releasing the base, there's less chance to put traction on the nerve. And if you can fully identify the pedicle and how close it is, there's less chance of clipping the base of the neurovascular bundle. We've also modified our technique over the last few years, and we've modified the apical dissection and the lateral prostatic fascia. So if we really want to do a nice tight nerve sparing, I will open the lateral prostatic fascia, but I'll open it a little bit later, and I'll modify my apical dissection to make sure I get a better look at the apex than we were in the past. Apical margins are hard sometimes to prevent, but I think with the modified apical dissection, our apical margin rates have gone down, and we have a much nicer nerve preservation. So this is the picture now. Conventionally, we used to do what's on the left, the nice train tracks, you see the levators. Now we do something more like on the right when we're doing a full nerve spare on a low-risk patient. And you can see the nerve bundle is not even visible anymore. It's behind the lateral prostatic fascia. So everything's buried. So if there's a fascial layer on top and you can't see the levators anymore, obviously less chance of damaging the nerve and also less chance of injury thermally or with clips. And so we can almost hide the neurovascular bundle, but obviously this is only in certain select patients. So here we are, 30 down. There's the rectum, the prostate. We've flipped to 30 up. And this is what we've advocated from the beginning. I think Anup was one of the first to, when he was our fellow, to talk about the toggling technique of going from 30 down to 30 up. And in his videos, he demonstrated how to do this when he was a fellow with us. You can see the fascial planes very clearly. And our goal is to go about 1/3 of the way up the prostate. That's where the nerve bundle is, and not to go too much more. Obviously a low risk patient, someone who deserves a nice nerve sparing, but you can see the fascial planes. And they're variable. You know, I can't tell you there's 3 planes, there's 4 planes. Everyone's different. If they've had a lot of biopsies, they may only have 1 plane. And the younger guys tend to have more definition of the anatomy than the older patients in general. But there's not 1 layer, there's not 2 layers, and it is variable. And, you know, we kind of quantify it roughly, but that quantification of the nerve spare is different for every patient. And that's what you should know. There's no constant anatomy in a prostatectomy. It's very rare that you say, wow, I can see all the tissue planes, no matter what type of dissection you do. And that's because every patient's different. They've had different amount of biopsies. They have a different amount of cancer. All of these things are super important to know. What you can see here is we're doing the same thing on the left side here. We're just releasing. So here what's happened is the nerve bundle is buried behind this hammock of tissue. And therefore, if the nerve bundle is buried, there's less chance you're going to cause neuropraxia. There's less chance of clipping it, cauterizing it, and the prostate you can just peel out. And like I said, this all depends on the type of patient you have. Next, we go a little bit anterior. And let's see if we can do that. All right. And what we do is we connect the dots. So here, we're preserving the lateral prostatic fascia. The goal is to keep all of this behind the fascia, less chance of damage. And we're doing our retrograde nerve spare here. We're spreading. Here I've connected the dots between the two. And I'll do a retrograde approach here. Peel it off. Here at the base of the prostate, this is the key. This is where if you do an antegrade prostatectomy, especially in a small prostate, you make the mistake. At the base of the prostate, where the pedicle comes in, it's about 2 millimeters or so between the base of the prostate and the nerve bundle. And that's important to know because of the fact that you could either get into the base of the prostate or you could potentially clip the base of the nerve bundle. So we're doing the same here on this side, peeling it away. We're just connecting the 2 dots. You see it's going to peel away nicely. We'll spread, and there we've connected to the other side. So this is one of those super duper nerve spares. We enjoy doing them, but realistically, maybe 10% of patients are going to be candidates oncologically for something like this. So here we'll move forward a little bit. You see everything is clip and cut all the way. But what I want to show here is at the base of the prostate, you see the nerve bundle is actually quite close at the pedicle level. And so you have to be really, really careful to avoid getting into the prostate and at the same time avoid putting an Aaron clip over the neurovascular bundle. So there's that clip that goes on. We make it. And the goal is to do this athermally. The goal is to minimize the traction, minimize all trauma, but you have to stay away from the capsule. I'm not an advocate of skinning the prostate. I'm not an advocate of seeing prostate glands. I think the oncology we see these days, realistically, the margin rates are going to be high. So I like to leave a small fascial layer on the prostate. The reason is outcomes. The outcomes are the same whether you leave a fascial layer on the prostate or not, or whether you're intracapsular or not. So you want to stay away from getting inside the capsule. I like to see a layer on the prostate because of the fact these margins. Margins are important, oncologic outcomes are important. So here we'll go. I'm going to just show you the apical part of the dissection. You just peel it away. At the apex of the prostate, you can also get the nerve bundle. But you see here, we don't see the classic train tracks. We're actually peeling this away nicely. And what I'll do is I'll skip to the end of this so that you can see what we end up with. So here I'm just closing the little veins to make sure they don't bleed. And then let's show you here. So this is kind of what we're seeing at the end. You see, even though we know the nerve bundles are preserved, they're buried behind the lateral prostatic fascia. They're under there. You're not seeing the train tracks that are there classically. That's the lateral prostatic fascia. That's the layer. It's covering the levators. If you don't see the levators, you preserve this correctly. So this is one of our super duper nerve spares behind the lateral prostatic fascia. The outcomes we've published, I think when you do this, the outcomes are improved. So it's a matter of judgment. You know, not every case can be a full nerve spare. The oncology has definitely changed over the years, and we can show you the amount of T3 disease has increased significantly for us. The tumor characteristics are also different. We're seeing more and more extraprostatic extension, seminal vesicle invasion, and so we've had to change. And so we published this a few years ago, before and after the US Preventative Task Force decision on PSA screening. There was an inflection point for sure. When we kind of shied away from screening, the oncology did get worse, and it continues to get worse. Higher risk disease, adverse pathology increased, and so what we did was we had to modify. Our margins stayed stable, and that's because we did more partials and less full nerve sparing. And this is probably the reality of where most of us are today, is we have to do good partials on the majority of patients. And because high-risk disease, extracapsular extension, but our nerve sparing stayed constant, our margins stayed constant. So the question is, how do you decide how to do a nerve sparing? And obviously we've talked about the fascial layers. We published on this, 10 years ago, probably now. But these are not always constant. You cannot always see every single layer. Patients have multiple biopsies, patients have prostatitis, patients have bigger tumors, and so you have to play in between. So that's why it's 100%, 75%, 50%, 25%. You have to be relatively rough. How do you know? We published this nomogram with the Bernardo Rocco group many years ago. We looked at 12,000 lobes of prostate, and we came up with this nomogram to predict who's going to have extracapsular extension, which side, and what location. So this is the only nomogram that exists that is very specific for the side and the location of extracapsular extension. So we use this. You can see at the bottom, there's the website. You plug your data in, and it should tell you whether you need to do a full, a partial, and how far out. It tells you 1 millimeter, 2 millimeters, 3 millimeters. So this is helpful. How do you know whether you're 1, 2, 3 millimeters out? I think it's hard by just looking at the prostate. So you have to have some landmarks. And our landmarks have always been the actual anatomy of the individual prostate. Here you have an anteromedial, a posteromedial, and a lateral artery. And this is probably pretty constant in most patients. And so these are big landmarks that you can look for. Even if you're a novice, you're able to see these. And if you use these, you can help. So here is a posterior view. This is the posterior medial artery. If you're medial to that, you're going to get a good 90 to 100% nerve preservation. If you're lateral to that, you're probably going to take about 25 to 50% of the nerve bundle, depending upon the patient. So very important to look at your landmarks, know your arteries, and we've published on medial or lateral. If you're medial to these arteries, that's a full nerve spare, but you have to spare the posterior medial and the anterior medial artery. You can't just spare one because that's a partial. So first we saw the posterior medial artery. Here's the anterior medial artery. You see it right there. If you're medial to that, you're on a full nerve spare. If you're lateral to that, you've probably taken about 30 to 50% of the bundle. So it's still a pretty good nerve spare. You see a nice bundle, but it's not 100. So this is a patient with a large tumor. he needs at least 3 millimeters. And if you're lateral, you're 3 millimeters away from the capsule. Why is 3 millimeters important? It's because 85% of axial capsular extension is within 3 millimeters of the capsule. So if you can get at least 3 millimeters away, most patients, you can still get a good nerve spare and a negative margin. So very important to know your landmarks, know the 3 millimeter rule, know the arteries. All of these things are very important. So nerve sparing, I think, is really kind of like a neurosurgical operation. You have to be careful of the nerves and the arteries, but most important, it's an oncologic operation. You have to do the right operation for the right patient. It does you no good to do a full nerve spare on a high-risk patient with extracapsular extension, because that patient's going to get radiation and hormones, and you're going to destroy any chance of recovery. So I think surgical judgment is just as important as knowing the ways to nerve spare. And that's why I really concentrate on partial nerve spare on the lecture, because that's realistically what most of you guys are doing. And there are other things, you know, it's not just about saving the nerves. If you have comorbidities, if you don't have a good post-op compliance with pelvic floor and penile rehabilitation, you're not going to have as good outcomes. So it's a team approach. You have to pick the right patient, you have to do the right operation, and then you have to support them post-operatively. Otherwise, your trifecta outcomes are going to be very poor. A little bit of discussion on the SP. You know, this is something we've had for a couple of years now. It's definitely different. It has an elbow and a shoulder, but it doesn't have a surgical wrist. And so it's a good robot, but definitely needs some innovation in the future. It's something we've probably done 150 cases with now. This is a lateral view, and you see it's like a whole spaghetti. And what makes it challenging is these instruments are thinner, they're longer, and so they're not as strong. So it's harder to get traction. Hard to do patients who are super obese, have a big prostate, because you have trouble with traction. The best candidates are thinner patients, smaller prostates, smaller tumors. But you see here, there's no elbow, there's no wrist. And so it is a little bit more of a challenge. So I think version 2.0, version 3.0 will make this a lot better and a lot more likely to be used in a wide variety of patients. But we do have it, we do use it. And I think in the future, if you look down the line, probably all the cases will be single port. It just won't be with this version of the robot. It'll be with one that has good strength, has good flexibility, it has a good wrist. And we've published multiple times on our outcomes with this and the techniques of various things. So, you know, overall, 15,000 later, I think we keep having to modify. Right now, it's about modifying against the increase in higher risk disease and extracapsular extension. I do a lot of salvage prostatectomies. We do difficult cases. It's very rare to have easy, simple cases these days. And that's why when we give these lectures, we have to focus on the reality. And the reality is our life is getting harder. The cases are more difficult. The chip shots are very rare these days. And so you have to go in armored, knowing how to do the difficult cases more than doing the simple ones. And I think that's very important. If you want to see, we have a nice a YouTube channel, and you can get online to Robotic Surgery Academy, and you can watch a lot of these cases, and they're just open access, so you can see. So, it's a challenge. I can tell you, I'm still learning. I'm still learning from you all. I like watching you guys. India has always been amazing in terms of its love for technology, and I'm very proud of all you guys. I've watched you since the first cases we did back in 2005. Ashok and I were both there, and we operated at different hospitals around the same time. But it's great. I mean, you guys have gone above and beyond where you would expect, and you guys are now leading and teaching the world. And that's why these conferences are important. There are people all over the world watching this, and they probably need to listen to you guys more than they need to listen to me, because you're living the reality. So that's my lecture, and those are my thoughts. Thank you so much.
Thank you, Vipul, for your excellent presentation. We are impressed with your humility in spite of this kind of experience, you are still thinking that you are learning. I think so that is a great quality of a surgeon. And I like to, there was one question which you have already answered, the single port prostatectomy, and you have mentioned the indications for that. But you know that Da Vinci is the one company and they have got a very high cost, and in a developing country like India, we are looking for, to bring down the cost of the treatment. So there are so many new robots are in the market. What is your experience? Have you used anything else, or still you are doing only with Da Vinci?
Yeah, we're using the Da Vinci because that's the only thing here. I've used most of the other new systems, and it's good. They're coming, and they need to come. I think they're just going to come at a lower level. You're not going to see, the Da Vinci is a mature system, 20 plus years in the making. You're just not going to get that from any of the new systems. They're going to be cheaper. I think it will bring the overall cost down, but it's going to be harder. It's going to be going from multi-port to single port. Single port's a harder case. I think these systems may not be as durable. They may not be as usable. But once again, they'll innovate and they'll get better. So I wouldn't expect the same functionality from the new systems at the same level of efficiency, but they'll work.
Thank you. Anup, like to make any comment, or we move on to Dr. Ashok Hemal?
Yeah, I mean, any other chairperson wants to ask question from Dr. Patel? Otherwise, we can ask questions after Hemal's talk. So we have time after that. Yes.
It gives me great pleasure to welcome Dr. Ashok Hemal. He is amongst one of us only, and today he is the professor and head of the robotics at the Wines Institute. And Dr. Hemal has really good interest. He is the one of the pioneer starting robotics in India, and today we are very happy to see his progress, and we look forward for his lecture about the another aspect of the radical prostatectomy, the continence. So he like to share his experience how to improve the continence in radical prostatectomy. Dr. Hemal, Ashok, please.
So please unmute yourself, Dr. Hemal sir. Please unmute.
Okay. Okay.
Slideshow.
Host has spot. It's unmuted from my side.
Okay, we are hearing you now. Go
Okay,
to slideshow and start. Yeah.
Can you see my slide now?
Yes. Yeah.
All right. All right. First of all, I would like to thank Dr. Anup Kumar and Dr. Bipul Patel as the convener of this COVID symposium and giving me opportunity to participate in it. And Professor Gupta, chairman of this session, Dr. Ganesh Bakshi. And this is a great opportunity for me to get into touch with you all. And as you all know, Dr. Gupta and myself, we were doing an open radical prostatectomy in early 90s. Then we ventured for laparoscopic radical prostatectomy. At that time, Anup was also with us, and we have done a few hundreds of laparoscopic radical prostatectomy before marching on to the robotic. I guess I joined a little bit later, but after listening to Dr. Bipul Patel and Dr. Tiwari, I mean, it's hard to imagine that you can improve this technique any further. So my, as I always say, by failing to prepare, you are preparing to fail. So this is very, very important. As Dr. Patel pointed out, it's a very humbling operation. After doing several thousands of these operations, personally, I feel this is a most difficult operation for me, because if you did not do appropriate job, you are not doing a good oncologic operation, or not providing good continence to your patient, or not providing the good sexual function recovery. So in order to do that, you ought to be very, very careful while performing the surgery. So that's why I put this. So as a surgeon, you always think it is your mistake, but it's not like that. So always think about the patient first. If your patient is obese patient, he already have an overactive bladder or urinary problem, or he is a psychological disorder, endocrine disorder, mobility disorder, constipation, smoking, all these factors, they play a role in your recovery of the continence. Similarly, medical comorbidities. I mean, these are the kind of cases Dr. Patel, Dr. Tiwari, and myself we get in this country. These are advanced cases, and almost 60 to 70% patients, they have some kind of medical comorbidities. Then third issue is the anatomical. The reason is most of these cases, either they have very large prostate or a small prostate. So all these factors you have to take into the consideration. And especially when you are operating on the African American patient, they have a narrow pelvis or a steep pelvis. So all these factors you have to take into the consideration. Then comes the surgeon factor. Of course, I mean, this is a very humbling technique, and you ought to work with your co-surgeon or as a team before embarking on your solo journey. It takes several hundreds of cases in doing a good operation. As I said, even after doing several thousands, still I'm learning. Now, coming to how to improve the surgical, continence in these cases. As you all know, what has changed from the era of the open surgery or laparoscopy or robotic? Why robotic has become good? So there are two reasons. Number one, because of the visual cues or magnified view, our anatomical knowledge or understanding of the urethral sphincter complex has become better. Also, the versatile instrumentation with the robotic, with which you can go into nook and corner and you are able to see apical area very well. All these has translated into better continence in these patients. So therefore, this is a very, very advantage to the patient as well as to the surgeon in doing a very good operation. In other way, the last but not most, least important, also patients should be trained for doing a pelvic floor exercises, and similarly for the preventing the vesicourethral stricture, you should be using less cautery in these cases. I will not go into detail, but basically this is an anatomical diagram, and you all know the sphincter urethral complex is, you can see the dorsal vascular complex here, and this is the urethra. You can see the rhabdosphincter, then there is a circular fiber, and then longitudinal fiber. So there are three layers of fibers around the urethra. Now, so as a surgeon, what you can do, you cannot change the patient factor, you cannot change the biology of the disease, and you cannot change whatever the circumstances you are operating given the medical comorbidities. But what you can do as a surgeon, if possible, you can preserve the pivoprostatic ligament, and by doing this, you are not altering the sphincter urethral complex. You can preserve the external pelvic fascia or liberator fascia if possible, but that is not possible if you are operating on the high-grade cancer. Similarly, preservation of bladder neck has been help in achieving continence, but again, this is debated. Both kind of, the literature is divided on this. Preservation of urethral length is definitely important because that gives you a more intra-abdominal urethral length, which helps in the continence mechanism. Dr. Patel must have talked about the periurethral suspension stitch. He was the first one to describe, and also the technique of posterior reconstruction. And these two techniques have been a game changer for achieving the continence, and especially in a complex situation. Now, coming to another point, the selective ligation of dorsal vascular complex. Again, this is important. It is not necessary to do a dorsal vascular complex in each and every patient. In some of the patients, you control delayedly. What happens when you are trying to put a dorsal vascular suture in the beginning? You're trying to bunching up all the structure, including the part of rhabdosphincter, and that can translate into the recovery of continence in these cases. So the management of apex is extremely important, and often question asked, what about the quality of nerve sparing? So the nerves what you preserve for the radical prostatectomy, these are not the nerves which take care of the continence mechanism. You all know the external urethral sphincter is supplied by the pudendal nerve, so which is not the part of the nerve sparing what you do for prostate. But we do know if you do a great nerve sparing as Dr. Patel showed or Dr. Tiwari showed, if you are going to do an excellent operation, you are likely to preserve external urethral complex nicely, and you are not going to alter the anatomy in that area, and that will help you in getting good continence. It is also have been reported in the literature because some of the cavernosal nerve, do travel along with the autonomic nerves, which helps at the sphincter mechanism. So therefore, nerve sparing is not directly responsible, but indirectly responsible for the continence mechanism in these patients. I'm sure you must have seen these videos, but this is a standard, the anterior approach for doing a radical prostatectomy. After dropping the bladder, you drop the bladder, clean the fat around the prostate, and so initially, as you all know, we always used to open the endopelvic fascia. So here you can see we are opening the endopelvic fascia, but if possible, you can preserve the levator fascia around the levator muscle. Now here you see we are trying to take a dorsal vascular complex, but this is much more proximal what we used to do earlier. Earlier, we used to divide the puboprostatic ligament there, and then we drop all this part. So these are the levator muscle and puboperoneus muscle, which is attached to the urethra that you are not dismantling. And this is a much more proximal control of the dorsal vascular complex. And thereafter, you can go for the bladder neck. So this is one way of doing the anterior technique, and then you can do a bladder neck preservation if you want to do. So this is one technique. The other technique is not entering into the radius space at all. So you are preserving the whole anatomical complex in this area. Here you can see the puboprostatic ligament, endopelvic fascia. So straight you went to the bladder neck, and you are trying to dissect the prostate. So this is basically, oh, sorry. Yeah, so here you can appreciate this is an anterolateral dissection of the prostate, but we have not dissected anteriorly. So this is a kind of, you are preserving the space of radius, but the space of radius is a misnomer. There's so many things in the anterior part. So, I mean, you can use the word, but, the bottom line is you are trying to preserve the periprostatic tissue or periprostatic apple as much as possible. So this is one of the example of doing this kind of procedure. So if you are not altering or distorting the apical anatomy, then you are likely to preserve all those structure, and these things should transfer into the good continence in these patients. So the next is preservation of bladder neck fibers at the vesicoprostatic junction. In the literature, both things have been described if you do a small bladder neck or bladder neck sparing procedure, but this is a cancer operation, and you cannot do a bladder neck preservation in each and every case. So you ought to, tailor your decision which patient you want to do a bladder neck preservation, in which patient you want to take a wide bladder neck, and especially when you are doing for the high-grade, high-risk prostate cancer, those are the cases where you want to make a wide bladder neck and more, the earth towards the bladder, rather than going towards the prostate to prevent the positive surgical margins. And this is some of the, the standard diagram. You can see the puboprostatic ligament, preservation of the rhabdoid sphincter. If you can have a good length of the urethra, that is very helpful for the a good outcome in the continence mechanism. And this is a small bladder neck you can do. There's data published in the literature comparing the full functional length of urethral sphincter preservation does translate into the better continence mechanism. Now coming to whether the nerve sparing helps in the continence or not, as I said, the continence is basically those nerves are sympathetic fibers. They run to anterolateral to the prostate and they go towards the sphincter. And most of the parasympathetic fibers, they are posterolateral to the prostate, which helps in the recovery of the sexual function. Let's see, does it play? So this is another small clip. I am sure Dr. Patel and Dr. Tiwari must have seen wonderful videos. But bottom line is you are trying to go behind the prostate. And the big advantage is because now you have XI robot at most of the places, and you can flip the 30-degree camera up, and you can do a retroapical and retroprostatic dissection. Earlier, we had to have a standard robot. I mean, I'm talking in 2000, early 2000. At that time, manually, you have to pull out the whole camera and turn to 30-degree up for doing a good retroapical dissection. But if you do a posterior dissection first, and then you can do the technique what Dr. Patel described, the retrograde technique of the nerve preservation, that's fantastic for the patient. As I already mentioned, wide nerve sparing technique, they help in the the continence. And these are the outcomes related to the continence mechanism. I'll not go in detail. So next is the concept of reconstruction of periprosthetic anatomy. So one, technically you can do what best you can do to preserve the periprosthetic anatomy or the urethral sphincter complex. If that is not possible, then you can do a reconstruction. As I said, Dr. Patel described the anterior reconstruction technique, but the posterior reconstruction technique was the game changer in this area. And I think at this point in time, most of the surgeons across the world, they do that. And I think this is Dr. Patel's paper in which, the periurethral suspension stitch and then sparing the puboprostatic collar. This is Dr. Tiwari paper in which they preserve the perineal puboprostatic ligament along with the puboprostatic collar. And this is the, again, Dr. Patel's group published the technique of, the posterior repair, and usually he does in 2 layers. I'm sure he must have shown that. And these are the steps. You can watch several videos that are available online that will help you to understand. But Dr. Menon did, the randomized control trial comparing these techniques. On the randomized control trial, I mean, there are 2 randomized control trials, almost you can say 3, but there's no biggest advantage if you follow these cases 6 months out. So the advantage is at 1 month or 3 months, you can get advantage of doing this procedure, but 6 months out, I mean, at least in the published literature, it has not been described. But definitely, I would suggest you may want to use a reconstruction technique that takes the tension away from your vesico-urethral anastomosis and is helpful in the recovery. These are the detail about those techniques, what I was talking. And Dr. Tiwari also published the technique of a Pagano principle. I'm sure he must have shown in his video, in which what he does a retrotrigonalization. So he put a couple of sutures behind the bladder neck in order to provide the small bladder neck. And vesico-urethral anastomosis is key in the continence mechanism, because the reason is, if your vesico-urethral anastomosis is not good and you have not done the mucosa to mucosa anastomosis, then urine will leak and it will cause stricture formation. And the technique for, again, as I mentioned to you earlier, do a posterior reconstruction and a big bite from the bladder, then the urethral side. On the urethral side, you may want to take a small bite, because otherwise the urethra will tear through. And if any clips you see around, try to remove those clips. And personally, I don't do anterior hitch, but it's entirely up to you. All right, so we published this paper last year. I think Dr. Patel, Dr. Tiwari, all of them, they were co-author in this paper. And what we evaluated all the techniques published in the literature, and we published our techniques. It's a extraperitoneal technique, transvesical technique, transperitoneal technique, anterior approach, radius sparing, transperineal. So basically what we found, if you omit the dissection of endopelvic fascia, bladder neck preservation, incremental nerve sparing, by means whether you do an antegrade approach or retrograde approach, these are also helpful in addition to preserving the periprosthetic anatomical structures. Similarly, preservation of puboprostatic ligament and dorsal vascular complex means delayed control of dorsal vascular complex, which will allow you to control precisely. That will also help in having a better continence in these patients. And also the technique of total and partial prostatectomy have been published recently. But if you look into the literature again, there are 2 randomized controlled trials have been published comparing extraperitoneal versus transperitoneal, and label 1 trial for the radius sparing. In this transperitoneal versus extraperitoneal, there is no difference. Similarly, for radius sparing, there was an earlier return of continence that is good in a month, at the most at 3 months, not beyond that. But there is a higher positive surgical margin. So I'll give you a word of caution. You are doing this operation for oncology control. So that is your primary goal. Your cancer control is a primary goal. So you should do a patient-centric operation. In order to do that operation, you can tailor your technique according to your patient. Not go with I'm doing this technique versus other technique. So you have to tailor your technique according to your patient factor, biology of the disease. These are very important. We also published a technique of robotic total prostatectomy for low-grade cancer, in which what we do, we are just removing the prostate and leaving behind rest of the stuff. And this is also available on the literature. And this is also, we have developed the non-human primate model in our W firm with the help of Dr. Badlani. And we are trying to do some of this stuff in this area, how to achieve continence in these cases at early stage. So as I said, the continence is a complex interplay of anatomic, physiologic, and neurologic factor. And surgical component is most important in restoring the anatomy in these patients. And certainly robotic assistance help you in understanding the anatomy and evaluating those areas. And as I mentioned, posterior, anterior, or total reconstruction does help in continence mechanism. So with this, once again, I would like to thank you very much. And I'll be happy to answer any question. And once again, thank you for giving me opportunity, Dr. Patel, Dr. Anup Kumar, and Professor Gupta.
Thank you, Ashok. Excellent presentation. And you have very nicely summarized in your last 3 slides that in spite of any approach, the most important thing is the basic fundamentals, which you have mentioned, that you have to think what is the best operation for a particular individual patient, depending upon the patient factor, the disease factor, and the technique alone is not going to make the difference. But basic principles remain the same. Thank you very much for your excellent presentation. If anyone else like to ask any question, Anish.
Yeah, sir. So Ashok, an excellent presentation. And I think we talked about the continence, the positive margins, but you touched a little bit about the impotence part, cavernous nerves and the pudendal nerve. So would you like to elaborate a little more about the impotence preserving, or that a little more on that aspect?
Yeah. So there are 3 types of the nerve supply in this area. One is the parasympathetic, sympathetic, and the third is the motor supply. So the external urethral sphincter, your continence is predominantly controlled by the external urethral sphincter, and which is supplied by the pudendal nerve. So this is a more like a motor supply. And the parasympathetic supply goes to the penis and the prostate area. So the parasympathetic is the nerve supply which helps in the erection process. Now there are autonomic nerves, they also go in that area. So the question is, autonomic nerves, they goes to the sphincter. And when some of these nerves, they are intermixed with the cavernosal nerves. So if you are doing a good nerve sparing operation, then you are likely to save those nerves also. So that's how good nerve preservation operation helps in the early recovery of the continence. However, if you are trying to do we develop this technique in a different way. So standard, the Dr. Walls described long way, preserving the nerves at the posterolateral part. But if you see the work of Dr. Albert Mellman, that was published in 1992, and that was the study done in the rats, and later on it was the Japanese study by Takinaka in 1994. They found the nerves are not only located at the posterolateral part, they are also on the anterolateral surface of the prostate. Then they work from Tony Costello, looking at those embryological specimen of the prostate, they found nerves on the posterior side also. So the question is, as much as you can preserve periprostatic anatomy, that translates into the good nerve preservation and the continence mechanism. Dr. Patel's technique of retrograde dissection is fantastic. I mean, I do mostly antegrade, but we combine with the retrograde technique for the nerve preservation. So you should go wholeheartedly with knowing all these techniques, keep in your toolbox, but which tool you are going to use for particular patient, that depends on the patient's anatomy, biology of the disease, and what you're finding locally. So you cannot, that's why you're seeing so many techniques, and you're still seeing, now almost millions of these operations have been done in the world, but still we are talking how to preserve the nerves, how to do a good continence. So I think these are my basic statements for about this.
Yeah, so thank you very much. I think you have very nicely covered.
I had one question actually.
Ganesh,
yeah.
please.
Should I ask, sir?
Ganesh, go ahead.
Your presentation was pretty comprehensive and it did explain all the factors for continence preservation. For any other person, it would be like a learning curve throughout, achieving all those factors, pre-op, post-op, patient, disease, etc., etc. So if you can just to summarize or reinforce the audience, tell us practically as I'm doing the surgery, the surgeon factors, which 2, 3 is a must do for me to put the continence in place.
All right, very nice. So, whatever factor I told, these are important. Don't underscore them.
Absolutely.
Patient factor. So, number one, look at your imaging. How many people they see their MR imaging of the prostate before going for the surgery? Make a small chart. Keep on the screen where the cancer is positive. How is the sphincter complex looks like if MR scan, MR prostate has been done. And then you understand the anatomy. What is the BMI of the patient? How many biopsies patient has had? Whether he had a diverticulitis, colitis, all those kind of things. How many previous operations he has had. So all these anatomical factors you have to keep in your mind. Then once you get onto the body, it's totally dictated by the local anatomy, what you are seeing there. Now you have to be very, very gentle. As Dr. Patel always said, this is a neurovascular operation. So try to follow those things. Be respectful to the tissue. The bottom line is, if you maintain periurethral complex, you maintain a pivoprostatic ligament, or you can do just like anterior edges sparing, what I shown you. So maintaining those areas, that is very helpful for the having a continence. So that is number one. Number two, use less cautery, especially when you are dividing the urethra. Bring down your cautery to the lowest. And but when you are cutting the urethra, do not use the cautery. Use a cold seizure. Then when you are doing anastomosis, just do a mucosa to mucosa anastomosis. If there is no leakage, there is no fibrosis, because that's how you're preventing the bladder neck stricture or urethral stricture. So I think each and every step is important. There's no that you do 1, 3 thing and that's how things happen. But in my opinion, every step is important. That's why we are still learning.
Thank you very much, sir. I think
you,
we need to wind up this session now.
Yes,
It's a fantastic session. So
Yeah.
I want to thank the speakers, Dr. Ash Tiwari and Dr. Hemal. They have joined us very early morning from US. Thank you very much, sir, for giving your precious time. Dr. Sudhir Rawal, excellent presentation, Dr. Janil Desai, sir. And of course, Dr. Patel, as usual, the fantastic presentation. And thanks to all the chairpersons, Professor Gupta, Professor Anish Srivastava, and Dr. Ganesh Bakshi for excellent moderation. And I just want to inform that we have crossed the 3,000 mark. 3,200 plus urologists are watching this program live for 25 countries now. And that speaks the volumes of the interest we have created by this program. Now we come to the last and the very important part, which is the masterclass by Dr. Jens Rasweller, and the moderators for this session is Professor Vipul Patel, Dr. Janil Desai, and Dr. Tony Costello. So over to Dr. Desai and Dr. Patel, sir.
So welcome, Jens. Jens has been the president of the World Endourology Society. He is the president of the DGU, the German Urology Society. Extremely well-traveled, one of the few Germans who has perhaps also an Indian citizenship, I would call it jokingly, because he has been to India so many times and interacted with all of us so many times with all his skills of endourology, and now he's going to talk about this robotic prostatectomy. So over to Vipul, one master talking to the next. So Vip, please go ahead.
Yes, Janak, thank you. And Jens, welcome. Jens and I have known each other for a long time. And, as I was training and growing, he was obviously one of our references, and watched him do laparoscopic prostatectomy many times, many endourologic procedures, and now robotics. And so, Jens is unique in that he always evolves. He's always going with the new trends, and he's always learning. And I think we have to learn from him that the learning curve is endless, and for him to continually innovate, I think, is amazing. So Jens, welcome, and we look forward to your lecture.
So
Thank you very much.
I'd like to add here, I'm Dr. Gupta from Delhi.
Yes, I know, I see you.
Yeah, so I like to add in your introduction that I know you since 1986 when I came to Stuttgart with your Professor Eisenberger, and at that time you have just started your career in urology, and we are very happy to see you where you are today. Welcome, welcome.
Welcome. So it's a real honor. So I hope that I can show you then my thing. Is it on the screen? I'm not sure. Let's see. See, do you see the slides?
Yes.
Okay.
Wonderful. Yeah, we can see that.
So I must really say it's an honor for me with this really highlighted faculty, my friends from India, really over such a long period of time, that I can participate on this. And I can tell you a little bit on my journey with RALP, radical robot-assisted laparoscopic prostatectomy. And you know, it started in August 2000. And this is a video that we produced at that time, where we had the device, which would not be possible anymore, for about 2 weeks in Heilbronn. And we did our first cases. And at that time, this was, you can say, the Da Vinci 2000. And you see, you sit at the console. And if you look now on the right side to the console, you see there is no pedal for cautery. So we didn't have cautery at that time. So this was made for the cardiologists. And we just had to use cautery, bipolar cautery from outside. We had only monopolar cautery. But of course, as you see on the left side, we could do already a good of fine movement. And we discussed already here about, let's say, what is going on with the next devices. And you must see that this is the quality that already existed in the year 2000. And if you look, for example, on the length of the instruments, the versatility, the idea that you are moving the device, the camera with your hands, these are all ideas that have been realized there. And the new devices have problems to overcome this and to really do it. So we are more or less in this stage. You have to see when you think about it. What we did at that time, we did a transperitoneal approach. And here you see, for example, like the assistant used the bipolar. And this is when we opened, we always use the retrograde technique. You know, this is the Heilbronn approach. And then we continued with the dissection. You see here also carefully, and we already did what you heard. No minimal energy when you cut the urethra. So already these things have been applied by us. And then this was the way how we did the anastomosis at the time, with single stitches with vicryl. I must say, mucosa to mucosa sometimes is a problem. At that time, we didn't have the Rocco stitch, so we had to adapt it directly. But if you would only take mucosa, I think it would not work. But you see, it went well. We could really do this in the way, put the next stitch and so on. We had a metal bushie there. There was not this perineal push, how we use it now. But of course, the whole procedure took long. So the first case took about 9 hours, and the next case, I think 6 hours. So we were quite involved in the whole thing. And then there was a restart in 2009 because from my ideas and experience with the lithotripter companies, for example, the Modulit SLX, which we developed, it was usually that we may pay for the device, but then we get the parts free or vice versa. And this was not possible at that time. The device would cost us about 800,000 German marks at that time. This is 400,000 euros or 450,000 euros. So it would be very cheap, but I didn't do it. Maybe it was a mistake. Nevertheless, then we continued with laparoscopy. We have done an overall, not 15,000, we have done only 5,000 cases. So I have not the same experience like Vip, but at least a little bit of experience during the last years. And so you see now, of course, this is the pedal setting here with bipolar and with everything. And you know, we could, of course, then go. And we went then to the experitoneal access that we use Also today, for low-risk tumors, for high-risk tumors, we use a transperitoneal access. And I must also echo the experience of VIP, that we also have more advanced cases than low-risk tumors. In the meantime, we face the same, like you know from the States. But at least here you see the approach. This is similar to the laparoscopic approach, and then we put in the trocars. And here you see when we started now, of course, stimulated by VIP's idea and all the others. We heard also Estivari, and you see here very nicely, this is the preservation of the levator fascia. After all these talks, I don't need to discuss about this. I would not go on grade 1, grade 2, because you can just say what is important, and I think this is most important, is that you preserve the levator fascia. And why do you do this? And afterwards, I show you the puboprostatic collar that has been mentioned already. Sorry, because here underneath you are running the branches of the pudendal nerve. And I think this is very important. You have to preserve the pudendal nerve underneath the levator fascia. If you keep the levator fascia intact, you will never injure it. And then, of course, afterwards, we are coming to the issue of nerve sparing. At that time, the anastomosis was with a continuous suture, not according Patel. At that time, we used the Van Veldhoven technique, where we start at 6 o'clock. But basically, it was the same. We used a PDS suture. This was prior to the era of the VLOC or other sutures. But anyhow, you see how it went well. And we did here also already a posterior reconstruction. And then came the final evolution, 4th generation device, the XI, you know this. And this is now, and I want to show you a little bit of our standard approach, what we do now with an extraperitoneal access for low-risk tumors, transperitoneal access with an extended lymph node dissection for high-risk tumors. Why transperitoneal access? Because here you see the indications for the extraperitoneal access. If we have a very low risk, we don't do any lymph node dissection. But if we have an intermediate risk, we do a limited lymph node dissection. And we use Gelita Taft, as you see here. And we are just almost finishing a study comparing the use of this Gelita afterwards to really minimize the incidence of lymphocytes. Of course, if you do a transperitoneal approach, the incidence of a lymphocyte is very low. And that's why we do, when we do an extended lymph node dissection, we do a transperitoneal approach. But this works also, I must really say, very well, because the lymphoria was one of the last problems we had with our patients. It's not the stricture we discussed, it's not the bleeding, but it was the lymphoria or the lymphocyte formation. We could really significantly reduce. So, and here, once again, the idea I mentioned, this is already a paper from 2001 from Steiner, where you see the cause of the branches of the pudendal nerve here. And I think this is very important, because if you are below, as if you preserve the levator fascia, then you will never have these problems. And then, of course, this has the impact, and every one of you knows the old approach, the red one, where we saw the levator muscle, and we don't see it. And how we are doing this, you see it here. Now this is with the XI device. It's basically the same thing. It's more or less a blunt dissection. And you see already the nerve shining through on the right side. And we stay, of course, medially. And so this is a kind of blunt dissection. So you have nothing in between. If you go more to the apex, sometimes you have the levator muscle perforating the apex of the prostate, then you may have to use a little bit of cautery. But you can do this very, very nicely in a more or less atraumatic approach. And this is probably what VIP has described already, that you early release it. And it's very interesting, because VIP came from the descending technique. We are coming completely from the retrograde approach, but I think we are meeting, because I think it's very important. Here you see the same thing on the other side, that we are aiming at an early release of the nerves, and I show this a little later. And here you see it's not a complete preservation, of course, of the puberoprostatic ligament, but we cut it more or less at the level of the bladder neck, because you will see this afterwards. This is the level of the bladder neck, and when we do so, we can then preserve the puberoprostatic color and cut the dorsal vein complex, which is here at the level of the bladder neck. You know, this is the triangle of the bladder neck, and we suture it here. We don't suture distally like we did before. And so therefore there is no risk, and you will see this afterwards, of injuring, let's say, any structure of the muscle or something, because it's not there at that moment. This is just the dorsal vein complex that we do, and that's all. So we use the V-lock suture here, several rows, and it works then quite easy. So here we had a little problem to find the hole, but now it works. And you are all, of course, familiar with this. So we are just going then 2 rows and 2 or 3 rows, and then we can proceed. So this is how it looks like. And this is according Estevari's publication. Takaneda did the basic work for it. So that this the preservation of the puberoprostatic color, I think this is very, very important. And when we cut here, we are going down and we find the urethra sometimes later. This is, of course, a distance of about 2 to 3 centimeters, of course, depending on the prosthetic size. And here left you see the schematic drawing. And here you can use cautery because you are far away from the muscle at that time, from sphincter or so. We use, you can use the 4th arm, or you can use our abu as a retractor. Depends a little bit how many people we have in training, whether we need. And you see this is still not yet the sphincter, so we can still continue. And then afterwards the urethra appears very nicely, and then by a blunt dissection, and then you can say, okay, now it's time to be careful, of course, and to try to achieve this by blunt dissection, more or less this long urethral stump. And once the urethra appears, then you can, and it just shines through here already, but not completely. And then finally, when it's down, and you can see the distance that you are going down is this 2 centimeters. Now here is the urethra, more or less, not yet completely in this patient, and that's why I can really underline if you do the suturing at that level, so you are not in the way. Now here you see now the early release of the neurovascular bundle. This is according, you can even say, the open surgical approach. We have a balloon in the rectum at that time, which we fill with 40 cc. This is from our radiologist. This helps us very nicely to identify the serosa of the rectum here. And then we can really start with an early release on both sides. And I think this is very important. And then we do the next step, a very, very long intraprostatic dissection a little bit, and then a very long stump that we create, and then we go down carefully. And on the left side, you see behind, of course, we will then cut the rector urethralis muscle. And here we are careful with the use of monopolar energy. We cut or just use it very, very selectively. But anyhow, this has not an impact on the wound healing. But here, of course, you see, then afterwards, we can identify the rector urethralis muscle, and it comes down, because we need this afterwards for the Rocco stitch. And then comes the posterior dissection, a little bit like in the old Pat Walsh schematic drawing. And here you see already the Deneuve fascia is usually covering the seminal vesicles, but sometimes, of course, you can do this. Here we are still far away from the nerves because we have already detached them. So this is the part of the pedicle time. We will see this later on a little bit better. And what is nice then with this and the balloon in the rectum, we have already, everything is free. There is no tension on the neurovascular bundle at that time. So this is probably the advantage that we see on this. And then we go completely down until really the total rectus serosa is detached. And then we can, usually we lifted up the prostate. And now this is probably, I can say the mixture that we did, that we are now pulling. Here you can, of course, also place a clip, but I think it's not necessary, as we heard already. So such clips usually you can easily find in the bladder afterwards. So I'm really only used 2 or 3 clips like you have seen with Vip Patel's video at the pedicle. We see this afterwards. So then is the bladder neck. So we are pulling down the prostate and opening the bladder neck. You can do a bladder neck sparing dissection. This, of course, depends a little bit on the indication. I must say, in most of our cases, we don't do this because it's, as we heard, about 10%. So we have not so many patients that we can really rely to do this. It doesn't matter at the end, because we will not have a bladder neck contracture. And I think the real bladder neck sparing has not such an important impact on early continence. The impact on early continence is more because you have a long urethral stump. I think this is more important. But you see here, finally, you could also undermine the prostatic urethra here. We don't do this. I usually open it here, and then that's it. So the opening is not very big, but anyhow, you need also to identify the orifices. Here we had a little midlobe, so you see it was not really worthwhile. And then I think that's very important that we try to find the vesicoprostatic muscle. I think this is very important from an anatomical side. So first you cut through the detrusor muscle, and these are horizontal fibers, and then come the vertical fibers of the vesicoprostatic muscle. And you can dissect this, and then you cut through the vesicoprostatic muscle, and then you enter the sinus urogenitalis, the urogenital sinus, where you find the vas deferens and the seminal vesicles, of course. And so this was, and this muscle here, this is what we use afterwards for the Rocco stitch, because we use this vesicoprostatic muscle to stitch it afterwards to the rectourethralis muscle. And you see, this is now the sinus urogenitalis is an open place. So it's really, you can reach this by blunt dissection. You can open this by blunt dissection. And then, of course, you are going to control the deferential artery and clip the vas and so on. And you see here, this is the clipping of the vas and control of the deferential artery. You don't need to clip it. You can also cut it through, but we do it as a routine. We just clip it here. This is more or less a routine that we apply always in the time. And then we dissect the seminal vesicles out. And of course, then the same on the other side. And because when we have this, we come very quickly to the apex of the seminal vesicle. I think this is very important. You can use, in my view, monopolar coagulation here. Maybe some may criticize this, but I think the nerves are far away from this place. I can show you in a minute. And this is the situation then. As you see here, this is the pedicle, and I can show you in the video how it goes. This is the way where we have to cut, because everything is free. And so the neurovascular bundle is released. This is only the pedicle still, and all the rest is dissected. So this is the last step. Of course, this is a little bit different to a descending approach, where you do this relatively early in the procedure, but it has no impact. And then finally, it looks a little bit like in the video you have seen from Vip, that we have 2 clips controlling the pedicle, and the rest you can see afterwards. And of course, then we do the same on the other side. You see, this is the course of the, I showed this is the course of the neurovascular bundle, and particularly the parasympathetic fibers, they go down. And so sorry, and then, so you can then again safely place a clip here in this direction and then proceed with the dissection. And the nice thing here is, of course, you can, let's say, adapt very nicely individually to the situation of the patient. If you have a patient who has basically a very low risk tumor, then you can stay very close to the prostate. If you have a patient with a high risk tumor, of course, you will stay very, very close, more or less to the other side, to the nerves. And then, of course, put the distal stitch. So this, you see it here again. That we play, we can place here the final clip. And here we really went a little bit more distal to avoid any risk of injury, and then we could, this was more or less the last part of it. Good, I think that's good. Okay, so then up. Oh, yeah. Good, and this is how it should look like afterwards, so that you see, as we heard, the three layers of the sphincter. So the rhabdo sphincter, lysosphincter, and mucosa, the levator fascia, the endopelvic fascia, which is intact, and then the clips here of the prostatic pedicles, and the bundle who is running more or less here. Here you see the course of the bundle. Now, just finally coming back to the vesicoprostatic muscle, as you see here. So you have the detrusor here. This is the vesicoprostatic muscle. And so this is always what we stitch then as the Rocco stitch to the rectourethralis muscle. And you see, it looks a little bit like here in this schematic drawing from Rocco. In the original way, we modified this just a little bit. And we use a Wheelock suture here again. And I think there is still another advantage of this Rocco stitch, and you will see this soon. It releases, it helps not only with the anastomosis, it also releases the tension on the neurovascular bundles, so that the vascular supply here of the arteries is much better. And you maybe if you do a next case, you can watch this. If you have sometimes you cannot see the pulsation of some of the arteries here, and once you put the stitch, then they are starting again being floppy, and you can see really the pulsation of the artery, of the small arteries here. So, and that's why we do this and fix this down. Usually you have to do 2 or 3 rows. You know this, how to use a Wheelock stitch. So okay, this is then the basis. And then comes the anastomosis, which we have mostly modified, unless we have a very, very wide opening. Then we go back to the Van Veldhoven, to more or less the Patel's technique, starting on the right side at 3 o'clock with the quill suture, and we have modified it a little bit at the end of the suture, and so, but it works very nicely. And of course, everyone is aware that it's the advantage of this Patel's approach is that you have a nice alignment of the posterior wall with your first stitch, and I think that's really good. And with the Van Veldhoven, sometimes you may have had some problems in between, and I guess this makes really sense to do this, and that has become our standard approach. And I must say we basically do not see a stricture, bladder neck stricture or so anymore. We've had some cases with a urethral stricture, but not with a bladder neck stricture. So this works out. And I think what is also important, coming back to Ashok's talk, is that you have a very, very long urethral stump. I think this helps you a lot to have good continence. I don't think that the suspension stitch plays a role. Why? Because you know, if you do the preservation of the pubic collar here, you don't need to lift it up anymore. So this is already fixed anteriorly, so you don't need it. The only thing is what we do afterwards. When we finalize this, we do an anterior kind of reconstruction that we stitch the dorsal vein complex that we used to the bladder neck. This, you know, this has been also described by Ash before, so this is also not something new. So yeah, I think this is clear. My journey, I can tell you, is as we heard about, there is an ongoing improvement technological wise, and I think that's very important if we think about cheaper alternatives. I see it's still very difficult to say. Let's say if I would get, let's say, the Avatera device for almost for free, and I should give away the XI to our surgeon who wants it, I don't know whether I could accept this. So I think I would not accept this, because I'm used to this high standard. So when we need to buy another robot, a second or third one, we will stay probably with the technology. If I start with a very, very new one, maybe the situation, as I have not a robot situation, is different, and maybe in India it could be. What we have learned, and I think this reflects all the previous talks, we have improved significantly our knowledge about the anatomy. We have defined this, we have better suture material, and so that's why we get excellent functional outcomes. And of course, since we are applying our techniques, as we pointed out, we can still say that we can provide excellent oncological long-term outcomes. I think after now these 20 years of follow-up, I can say this. Thank you very much. It was a wonderful and exciting journey.
Hi Jens, Vip Patel here. Congratulations on a fantastic talk. It's always a visionary lecture, and you delivers as expected. I guess as a visionary, someone who's seen the evolution of the technology, what's our next step? I mean, do you want a different type of robot? Do you want a single port, or is it imaging? Is it AI? I mean, what's the next big step? We know how to do the procedure. We have a robot that works. So what changes the game?
Yeah. This is a very, very good question, because we are all surrounded by people who are excited about new technology, let's say AI. But I'm not sure that Alexa will tell me soon how I should do my prostatectomy. I must really say they may give Alexa may give me advice what I should cook today and maybe help me with cooking of something, but I'm 100% sure Alexa will not help me and say, oh, why don't you do this way? I think we are still far away from these things. And therefore the need, I must really say, one of the last thing was the toggling of the camera, which is very, very helpful. I'm very pleased at the moment with the way I can act. I see the single port not as a solution, I must honestly say, for the prostatectomy. Maybe there are other indications, and because you still need something to bring in. So why can't you use then the additional trocars to do I would say, a better job. And I saw you. You are very, very experienced, and you can look at Kauk also. It looks sometimes you are trying to prove the principle, but it's not yet that we say, oh, this is the way I want to go. And the advantage for the patients, I also do not see so much, because we have to take out the prostate and so on. So there are other things. What you see in ESWL, I could tell you very easily, I would like to have, for example, a device maybe like with a burst ESWL that fragments or pulverizes the stone, or a radiological diagnostic that tells me now my stone is completely pulverized. But here, maybe a little bit of navigation, but I know the problems about it. Also, you've worked with it. We have soft tissue navigation. We cannot 100% rely. We change the shape of the prostate. I don't see an easy solution for this. You see, it would be nice that, of course, in the prostate you see the tumor, and then you can say this is the way to provide to get 0 positive margins, for example, because you can see it. But I'm not sure that we are. Honestly, I'm a little bit maybe pessimistic in this way, but I'm not sure that this is the way at the moment we can go.
I would agree with you. I think the next step is imaging, intraoperative imaging. Yes. I know where the prostate is. I know how to save the nurse, but it would be really nice to know how close is that tumor to the capsule. Do I have extra capsular extension? Because that changes my outcome. It would improve my ability to do full nerve sparing. It would reduce the margins. It would reduce additional treatment for the patient. So we do have some imaging systems coming. There's one MRI coming that it doesn't require shielding, and it can be used intraoperatively. I think we will probably have that here at our institute within the next month or two. So using that in the operating room in real time during surgery, I think that might be helpful. That may change the game.
The other thing that didn't really work was, the hexamine level, the PDD for the prostate, the PDD for bladder cancer, we know. And there was the possibility you cannot use the same thing. You can use only the original vitamin alanine to inject, because the hexamino level in acid you cannot inject. This is not only used for intravesical application, but this would be something, you see, that you get a kind of fluorescence out as on the surface of the prostate. And if there would be a fluorescence, you could say, okay, oh yeah, here I have to be very, very careful. But I had seen only early trials, and it has not come out because of these technical problems and problems with the substance and so on. But I agree with you that if you could then, because I think this is our problem, that we need to have something during the operation at a certain point, and then we need the exact information, and not something done before with a different position of the patient. Right. And so on.
Yeah, for sure. Other questions from any of the moderators? Well, gents, that was fantastic as always. So we'll miss not seeing you at the AUA, because I understand it got canceled for in person.
And not even at the WCE, because it's in Germany and it's also canceled.
Yeah, so maybe ERIS. Otherwise, maybe next year at the next AUA. So that's why it's really nice to have events like these. We get to see our friends and keep learning. And I think it's been great. I've really enjoyed it. And I'll put it back to Anup to close the session. Anup?
Thank you, Professor Rosweller, for a very excellent presentation, and Dr. Vipul Patel and Dr. Dinesh Desai for excellent moderation. So all good things come to an end. This meeting also comes to an end. So I will first request Dr. Patel and Dr. Dinesh Desai to give their concluding remarks, and then I will put a formal vote of thanks.
Yeah, as I said, fantastic meeting, fantastic faculty, great organization. And I think we should take a chance to pause and just reflect on why we had the meeting. It was to support COVID response in India. We've all had friends and family who have passed away or have become very sick. And I know in India, the pandemic's not over, and it's not over here in the United States. We've gone into a period where we're having the highest rates elective surgeries canceled, and all the ICUs here are 120% full. So it tells you that it doesn't matter how many resources you have. The virus is the virus, and vaccines and masks are the key. But it also gives you a big part of the human element, is that, you know, enjoy your friends, enjoy your family, because life is too short. And so, you know, it's great to see you all healthy and happy, and I look forward to seeing you in person. Thank you.
Janak Desai, sir, your concluding remarks.
Yeah, a fantastic meeting. Actually, VIP started this meeting in Florida. I attended a couple of them. Fantastic meetings he was putting up, and as I said, we are still very small kindergarten kids, but he invited us, and we got exposed to this wonderful world of robotic surgery and slowly embraced it. But here in India, with VIP's help, of course, Anup, you have done a fantastic job. You have put up this meeting. Last year, we had Pat Walsh as our star speaker, and this time Jens Rasweiler. By the way, people don't know that Jens is a fantastic musician also. After a very hard day in our endourology sessions, a very absorbing day, we are all looking forward to the evening program when Jens comes up on the podium with his guitar and the crowd goes wild. So he's a very talented fellow. And VIP, of course, he's a mentor to us all. For me, I can never forget, he came to Ahmedabad to teach me, and then of course all of us have gone to his place, and somebody was making a comment in one of the sessions, how come VIP, when you operate there is no bleeding? So, you know, I put up this message to everyone. Well, VIP does nothing. VIP is not a great surgeon. God shuts down the blood supply to the pelvis when VIP is operating, and therefore there is no bleeding. So anyway, so all good things come to an end. Thank you so much. Thank you everybody for attending this meeting. Thank you, Jens, for accepting our invitation. And once again, thanks a lot to Anup. You did a fantastic job. Thank you.
Thank you very much. The patrons of this meeting, Dr. Janak Desai and Dr. Sanjay Kulkarni, sir. My mentor, Dr. Vipul Patel, I owe him everything I have achieved in robotics today. Of course, my old mentors, Dr. N.P. Gupta and Dr. Hemal, they taught me how to do urology in India. So I am fortunate to have all my three mentors front of me in today's meeting. And all the esteemed faculties, international and national, they have done fantastic job. And as I told, we have crossed the magical figure of 3,000. So as per the current estimate, 3291 urologists from 25 countries, they were watching this program live. And that shows the interest the program has created. I want to also thank the sponsors for this event, Intuitive, and of course, the Grover Audiovisual, who have helped us in live streaming of this program. And you can see it was flawless. And above all, we finished on time. So I think that shows that all our faculties, they have done wonderful job. Thank you very much, sir. And we hope next year we meet in person to have this meeting as a physical meeting. So thank you very much, sir, for joining us today. Have a great evening. And we will meet again next Tuesday. Thank you.
Good night.
Good night, sir.
Good night. Good night.